I mean, literally, like, sitting there turning over 11.
And, you know, I have always, we're some jobs, we told our crews that we would contract them, would you ever? Do you have a wireless modem? Have some kind of idea for a solution, and bring me that also. Don't just bring me a problem.
Yeah, the conference
Bring me a solution, tell me what you think will work. And it's not what you want to do. It's not what
Good morning, everyone. I'd like to go ahead and start the February meeting of the Governor's Emergency Medical Services and Trauma Advisory Council. If you could help us out by putting your cell phones, pagers, iPhones, iPads, whatever on stun, we'd appreciate it. I did not get the usual signal from the production booth, but I assume we are being broadcast by TTAF, and we thank them for that. That being said, please be sure when you come up to the microphone that you get very close to it so everyone can hear you, not just for purposes of the TTAF webcast, but also so that everyone in the room can hear you. And I apologize for if you can hear the whine, these speakers are live up here, and so I'm getting a lot of feedback, so I don't know if y'all are picking that up or not. The first thing I'd like to do is go ahead and, per our strategic plan, repeat the vision of GETAC, and that is a unified, comprehensive, and effective EMS and trauma system for a healthy, safe Texas. And our mission is to promote, develop, and maintain a comprehensive EMS trauma system that will meet the needs of all patients and that will raise the standards for community health care by implementing innovative techniques and systems for the delivery of emergency care for the entire population. And at this time, I'd like to have a reading and/or approval of the minutes from our last meeting.
Could we correct spelling in a few places? Dr. Greenberg's name has been misspelled in a couple of spots. Other than that, I'd make a motion to approve.
Okay, we have a motion and a second to approve the minutes with the correcting of the spelling of Dr. Greenberg. Is there any further discussion? All those in favor? Any opposed? Thank you. Excuse me, under the chair report and discussion, I just have a few brief things. First of all, I'm very pleased to now publicly state that Dr. Ronnie Stewart has agreed to serve as vice chair of the GETAC Council. So thank you very much, Dr. Stewart. We appreciate that. And the next item is we are going to move. There's item agenda number 1, which is reviewing the strategic plan document that has to do with the number of meeting days and, yes, conducting the regularly scheduled meeting to 2 days. We are going to move that to the very end of the agenda because we want to meet with, of course, the stakeholders, but also the chairs of the committees to discuss that item. That being said, given the length of our meeting, we might be here at the lunch hour. So if anyone, and I would recommend committee chairs or council members one at a time would like to do this, we can go pick up food at the buffet and bring it back in here to eat, and we'll have a working lunch. Rather than everyone have to pay for it all at once, you can wander in one at a time, and starting at 10 a.m. and buy a ticket. It's $11. The iced tea and water will be in here, so that when we recess briefly so everyone can get lunch, you can go in there, you'll have a ticket, and you won't have to fumble with your wallet, and we can get back in here and get back to work if we go that long. At this time, we'll hear a report, the Assistant Commissioner's report from Kathy Perkins.
Good morning. Somebody asked me how things are going right now. It's quite frenetic, as you would expect during a legislative session. One of the big milestones is next Friday, which is the last day for filing bills. We heard about a week ago that there were 2,000 bills in the queue for the Ledge Council to work on, so there's always a mass frenzy and numbers of bills that get filed in this last week. So it's going to, and the committee meetings have now started, which makes things very crazy for my staff and I. I wanted to talk just quickly about the department's budget. The good news is that my division did not take any additional cuts this time. We basically are going to stay at the same level that we were the last time. We have spent a lot of time over the last year and a half. Are you getting that? So we spent a lot of time over the last year and a half looking at the priorities of our work, making decisions about where we would not do routine inspections, and et cetera. EMS, of course, is one of our highest risk categories, and that's not one that it'll depend on our staffing resources that we have, but it's not one that we've cut out routine inspection work and complaint investigations. But there were a number of programs that we have that we will not be doing routine inspections anymore and only doing high-risk complaint investigations. So that's good news. There's also been discussions. I testified at a hearing about dedicated fees, and we've talked before about dedicated fees, and that meant that much of what is generated, I have 10 or 12 dedicated fees in my division, including the EMS fee and the hospital licensing fee, and that though there are significant balances in dedicated fees, they're talking about providing additional appropriations for those dedicated fees. The challenge will be if they give us more dedicated fee and then take away general revenue out of that same strategy, which is what we heard they would like to do. Well, for us, that's a problem because in every strategy I have, dedicated fees are for a specific program, general revenue are for the other programs that don't have dedicated fees. So if they increase EMS dedicated fee appropriation to me or hospital licensing fee appropriation to me, that's not a bad thing. That would be a good thing. But if then they take the same amount away in general revenue, then I am not in the same place. I could be in a worse place because of the other programs that need the general revenue for us to regulate. So in the health profession strategy, as an example, EMS has a dedicated fee. It also has some GR that supports it, but the rest of the GR supports social work, marriage and family therapists, all the other professions that I regulate. So I don't know what's going to happen with that. There was a committee, and as I said, my testimony was on the big uncompensated care fund, 5111, what we use that money for. And that one does have a very big balance. That's not a regulatory fee. It has about $400 million in it. And there have been a number of discussions that I've heard, just to let you know, discussions for use of that uncompensated care fund, including helping support the trauma registry, which I think is okay. There's also discussions about using it for a trauma dispro program. That could be an interesting use of those funds. So there's a lot of discussion down there about using the dedicated fees for the purposes for which they were intended and not letting them continue to build up. So we'll see what comes out of that. There's some bills of interest that I just want to make sure you guys are aware of. The first one is House Bill 15 by Colkhorst, relating to level of care designations for hospitals that provide neonatal and maternal services. Basically, this creates a whole new system. There are words in there about dividing the state into regions, neonatal and maternal regions, about designating 2 new types of hospitals, neonatal intensive care units and maternal levels of care. This would be, we estimate 500 hospitals total would seek these designations because there are words in the bill that say if they don't achieve the designation at some level, then it affects their Medicaid payments. And over half the babies in Texas, about 56% of babies in Texas are born in under the Medicaid program. It has so it creates a system, it creates a new designation program. The challenge with this one, as with stroke, when we first started, there was no entity doing stroke surveys. Now we have Joint Commission and we have DNV doing stroke surveys, and we've been able to roll that out slowly. We've talked to one or two organizations that might be interested in doing it, but they haven't even started down that pathway yet. So this could be a really interesting bill. HHSC, the Health and Human Services Commission, certainly is going to be very interested in this because of the Medicaid language, and have asked us, do we think that it should, do we think that we should establish a whole new system, or in some way tie it to the system that we currently have? And we have provided feedback that, the RACs took on stroke and now cardiac with no additional resources. We have verbalized that to take on this whole new program would be somewhat of a challenge. I don't know, this bill has a low number. That is usually indicative that there's a lot of support for it already, and Colkhorst believes that there will be Medicaid savings from this bill, because many hospitals have what they call a NICU. This sounds like trauma all over again. I think I told them I'm having deja vu from the early, 1990s. But they don't really have what you need to have in place to be truly a NICU. So it's going to be an interesting thing to see where this one goes. As I said, it creates a task force. It creates very short timelines to get rules adopted. About 2 years? No, not even that. Not even 2 years. 18 months, and then within 6 months after the rules are adopted, all the hospitals are supposed to be designated. And we've shared that those are not reasonable. That it's just not reasonable to do it in those timeframes. So this is an interesting bill. If it's not on your radar, it has support, and I think it could move forward. I don't know what it'll look like, but just wanted you to be aware of that one. And wherever I have the opportunity to provide my input, I'm doing that. There's a couple of bills about repeal of the driver's responsibility program. I think you guys are already aware of those. One of them is 104 by Gonzalez, House Bill 104. House Bill 245 by Menendez, relating to authority of emergency room physicians and certain emergency medical services professionals to hold a person believed to have a mental illness. We've provided a lot. One of the things I want to make sure you guys understand, we rarely seek out a legislative office to provide input on bills. Usually we're asked. One of the things that I would ask and remind you is, oftentimes if there's a bill that says EMS, the first call that anybody makes is down to our office. If we don't know about the bill or who was behind the bill or why the bill's being filed, we're doing the best we can to look at the language in the bill and provide input. It really is helpful for us if we know where a bill came from and what the thought processes are on the bill. This one I now understand better. I had no idea where it came from, and I understand now that there was support for parts of the bill, but how it got written in Leg Council is not how the people who are supportive of this wanted it to roll out. Okay, and that would have been really nice to know before the bill got filed or when the bill got filed. So it creates a whole new certification program for EMS and mental health. On top of it would be an additional certification. It would require quite a bit of resources. My understanding is that piece may be being pulled out of the bill. I think it was about trying to get docs involved in the hold of mental health patients, which is appropriate because right now it's a sheriff making those decisions or a police officer or whatever. So I've talked to some people today, and it sounds like it's being worked. So really important one for you guys to know about. House Bill 337 will have us regulating sexually oriented businesses. Owners, operators, and the employees will require us to create a whole program for licensing of the dancers as well as continuing education. I will be seeking your advice on this one. Everybody wants to be an inspector. And they're supposed to have their license on them even when they're working. I'm not quite sure where that's going to be. House Bill 409 by King related to a state emergency medical services director. This is another one that we were not aware of, that we provided input on, feeling like the medical directors might have some concern about it, and have now found that maybe they might not quite be that concerned about it, so we're a little confused. I think that it doesn't say much, but sometimes interpretation is in the eye of the beholder, you know, and so if this is something that is wanted by stakeholders, it would be probably helpful to have more details in there about what this actually means, okay? Let's see. Another one, repeal the driver's responsibility program, House Bill 790. House Bill 975 is requirements relating to the requirements for obtaining an emergency medical services license, and this really creates a local certificate of need program for EMS. If you have not looked at that bill, you probably need to. And House Bill 1342 by Raymond, same thing, relating the requirements for obtaining an EMS provider license, local certificate of need. A new bill that I have not looked at yet, and so I can't speak too much about it. House Bill 1656 by Island, relating to funding for emergency medical air transportation provided to patients enrolled in the state Medicaid program. So I don't know much about that. It's going to be an HHSC bill. Senate Bill 53, relating to life support services provided by certain emergency medical services personnel. This one has already had a hearing, and it really is, now I understand this bill better than I did before, and it's really trying to line up the Texas definition for paramedic and so that when they get Medicaid reimbursement, they can be reimbursed the same way they're getting reimbursed by Medicare. Okay, it allows for a paramedic assessment. Senate Bill that's not even what it shows. Let's see. Okay, I think those are the major ones. Before I move on, is there any questions about any of the bills?
You mentioned that one about the city-county medical necessity for ambulances. You may not know, do you think that comes out of the problems of having too many ambulances, and that was a way to regulate that?
Yes.
Okay.
I do know that that's why, the whole fraud issue. I will tell you that almost all the meetings I'm having downtown, the whole issue of Medicaid fraud is the topic this year. How to reduce Medicaid fraud. EMS, the NICUs, that's part of it. All of those issues are involved in the Medicaid fraud issue. Okay. All right. The Texas Medical Board adopted the rules that we had been working on with them for requiring EMS medical director course, as well as not allowing an EMS medical director to have more than 20 providers under them unless they have a waiver. We will be working with the Medical Directors Committee on the criteria for both of those issues. And then I'm going to take a minute to say a few words about one of my staff persons. He's not here, and I'm sorry that he's not here, but he's going to be my staff person for just a couple more weeks. Maxie Bishop has served as the State EMS Director for 6 years, and I don't know where the time went, frankly. He embraced my division's philosophy of trying to achieve voluntary compliance and helping licensees to do so, to break down bureaucratic barriers that arise despite our best efforts. We try hard, but, we're bureaucrats, so sometimes we put them up. He has served with dignity and caring. After he often drops in on providers during his travels around the state, not to inspect but to communicate. He has represented Texas at the national level in an extremely positive manner and has helped the attitude toward Texas EMS in a very, very positive way. He has treated his fellow employees and other staff in such a positive, collegial way, often thanking them for the work they do. With 61,000 medics now in the state of Texas and over 1,200 providers, the workload in this program is significant, and we don't have enough resources to manage it, and they work very, very hard to try to license people in a timely way and do the work that we do. It's a challenge, and he always thanks them, always has a positive attitude, a smile. This is not an easy role, State EMS Director. Trying to maintain the required state objectivity while passionately loving EMS. It's not easy. In wanting to see this profession grow in stature and respect in this state. It's been my honor and privilege to know and work with Maxie since my days as Bureau Chief of Emergency Management, and I am looking forward to continuing the relationship in his new role, where I know that he will continue to advocate and work for EMS in the state of Texas. So I wanted to take those few minutes to say those words.
Maxie had a death in the family, and that's the reason he's not here today. And just in case he looks at this later, he can hear us. If we could give him a round of applause of appreciation.
And just to finish off, we will be posting his position, and I'm looking for a good replacement for him. Thank you. That's all I have.
Thank you. Any council members like to comment? Well, I know Maxie will definitely be missed in the organization, and I knew him before he was on here, and I can't believe it has been 6 years, but he'll have some big shoes to fill, but always a pleasure to work with. Any other questions for Commissioner Perkins? Thank you. State EMS and Trauma Report, Director Guerrero.
Now, that works. In the vein, talking about Maxie, I'm actually mad at him because he's leaving me. We were supposed to retire out of the state together. I am pleased to make an announcement. I'd like to introduce you to Starla McLaren. Starla, stand up. Starla is administrative assistant for the Trauma Systems Coordination Office. She will be working with you on GETAC and on your agendas for the committees and on your travel reimbursement and on our arrangements here. So you will be having contact with Starla a lot. Nancy Rosas, fortunately, is still with us. She is in nursing school now, so I expect that this will be her last semester with us. But she's able to transition over to Starla, so it's not like we just dump GETAC in Starla's lap. So we're thrilled that Starla is here. So you'll be getting to know her. I'm going to move on with the funding report. Just as a reminder, the meeting dates for May is May 15 through 17. We will be here in Austin at this hotel. If you need our office to make flight arrangements for you, you'll need to contact Starla or Nancy. Okay. For the funding, as of February, our trauma designation program, we have a total of 267 designated facilities. We have 31 facilities that are in active pursuit. I think that's the highest number we've ever had in active pursuit. Some of that comes because we've had a lot of change of ownerships, or what we call chows, across the state. Whenever ownership changes, the designation is no longer in effect, and so they have to go into inactive pursuit. For the level 1s, we're up to 16 right now. Level 2s are 13. Level 3s, we have 48, and we have 190 level 4s across the state. On stroke facilities, we have a total of 103 designated facilities. We have one level 1 pending right now, which is the Methodist Hospital in Houston. That'll be our first level 1. Level 2, we have 98, so that's your primary stroke facilities. And level 4s, we currently have, level 3s, we currently have 4 of those, so that's your support stroke facilities. For funding, for 3588 monies, remember that this year was, or in 2012 was the first year that we did it this a little bit differently. We took $26 million of that fund and transferred it to HHSC, of which they were able to add to it with federal dollars in the form of a trauma add-on to the standard dollar amount for Medicaid. We didn't really know how this was all going to pan out when we started doing the numbers. But what it did is it pumped up the available money that went to trauma facilities to around $60 million. And then we make them whole. If any one of these facilities that's on the trauma add-on through the standard dollar amount, if they, through this program, got less than they would have gotten through our calculation for the uncompensated trauma care, we had money in reserve to make them whole or bring them up to that amount. So it was kind of a no-lose situation for the hospitals that participated, and actually came out to be a win for most. The drawback for the ones that did not participate was that we had to kind of wait to see, well, actually we did the disbursement for them, but we had to wait to see how much we had to make up the difference. How much, were there any hospitals that we needed to make whole and make up that difference? So we just got the information from HHSC about 30 days ago. And those funds are actually going out probably today and hitting bank accounts either today or Monday. So that was actually a good thing. They're going to continue that for 2013. So those hospitals that were on the SDA trauma add-on, they're still participating in it for fiscal year 2013. So we will go through this cycle again next year. Any questions on that piece?
So Jane, I just have a couple of questions.
Okay.
The $60 million increase, what's that mean? That's a plus $60 million over what it was previously, or what's the 60 million? What does that mean, $60 million increase?
Well, what they did is they took the 26 from our fund, and
match.
then they brought down match for that. That pot was set aside basically for the trauma facilities that were participating in the trauma add-on. So the money was distributed to those hospitals throughout the course of the year on a monthly basis. And they got that money, the add-on, for every Medicaid patient that was admitted to their hospital, not simply trauma patients.
Yes.
Okay.
And so still, I'm still just need to be clear in my mind. So that 26 million but there was an additional 34 million
Mhm.
that was added to that to make a total of 60 million?
Yes,
And so that 60 million, so that total 60 million is, well, that total 34 million is in addition to the 26 million and the other part of the trauma fund that was not matched.
correct.
And how much was that? How much is that?
Well, that was
It would be around 50 million
59, let's see.
if I'm correct.
It was 54.7 million was our allocation.
Okay, so I'm clear on that now. So then my other question though is you've said a couple of times the hospitals that didn't participate. So it sounds like every hospital who did participate, y'all think did better. No?
Not necessarily.
Okay, so a few that did not, and you're making them whole with respect to with respect to making it the same as what they got the previous year,
Correct.
correct? And then you've said though hospitals who didn't.
Well-
I thought there was no real choice in participation. I thought if you participate in the Medicaid program, you were participating in this program. No?
I don't think so. They have a choice whether they wanted to do the add-on.
And additionally, some are not eligible for the add-on. So those that already get what is considered to be full Medicaid reimbursement are not part of the add-ons, okay? And yeah, there were a few that weren't whole, but we will make them whole. Not that they would got what they got last year, they'll get what they should have gotten based on the formulas.
Based on what they should have gotten this year,
This
based on
year.
the previous
Or,
formula.
well, yes, yeah, we're late because we had to wait on the numbers,
So it's for the previous fiscal year.
yes.
And then the plan is to continue that moving forward to fiscal year 2013? Is that to do that same?
We've already transferred funds this year to HHSC to continue that program for this year. We don't know where it's going in the future. We'll have to see what the legislature does. Just so everybody's on the same page, the SDA payments only went to trauma facilities, but they were not just for trauma patients. Those SDA payments were for all Medicaid patients.
SDA, standard dollar
Standard
amount?
dollar amount. Trauma was for all Medicaid patients. So hospitals trauma facilities got additional funds for taking care of Medicaid patients.
So it sounds like from y'all's standpoint, in general, it was generally beneficial to the trauma system to do this match. The hospitals that participated, generally beneficial. Yes.
Yes. They at least did not go backwards. There were a few, again, that didn't get as much, but yes, I think it was beneficial.
Okay. The reason why I ask all these questions is because, we will have to explain this to people, right? So we have to answer questions. When someone asks me a question, I have to say, oh yeah, this was better, and here's the reasons why. I have to understand what actually happened. So it's really an additional $34 million plus 34. That's the way I would look at it.
Right.
Okay.
Now, we will be sending out letters to each one of the facilities that gives the breakdown for their facility. We have a spreadsheet that lays out the calculations. So we're actually going to put the spreadsheet out on our website. So, people can go in and look at it. And there'll be an explanation of how the calculations were done. Okay.
And so for the providers, for the people in the room who, particularly, for the whole system, I will say, this is why making the case for why the driver responsibility program is important to the patients of Texas, to the patients we care for, because it's essentially, if I add it up correctly, it's an additional $100 million right now, even not dispersing the whole amount. If you add up all this, it comes up to additional 100 and whatever that 60 plus 54. So what's that? That's 114 million. So it's very important.
One of the caveats with that is if a hospital is in a system, so there are 5 hospitals within their system, and if they're all 5 of those hospitals are designated, they don't have to be designated at the same level, but they all get reimbursed at the highest designated level. So in other words, if you have 5 hospitals and you have one that's at level 1 and everybody else is a level 4, all the level 4's reimbursement is based off of the level 1. So they get a higher percentage or higher dollar amount on their trauma add-on. So that's could be one of the reasons we have 31 in active pursuit. Could have something to do with it. Okay. Let's see. Moving on, fiscal year 13, our appropriation is $57.5 million. We'll disperse 54.7, and again, we're going to do the $26 million to HHSC, and so that they can get the match. It'll be the same process as this year. And for fiscal year 12, for EMS, they received $1.1 million from the fund. The RACs got a little over $500,000, and of course, we've talked about the hospitals. For the 911 and the 1131 monies to hospitals, in 12, we did the August disbursement. For 911, it was almost $500,000. The 1131 was a little over $500,000, so it was totaled out to just over $1 million. For our EFs, our extraordinary emergency funds, we had $1 million set aside for fiscal year 13. We funded 4 EFs so far. We have a remaining balance of $807,000. For ECA training, I'm sorry, let me back up. Tobacco rack grant, we have $2.4 million for fiscal year 13. The contract started September 1st, and they won't run through the end of the fiscal year, which is August 31st. ECA training, here it is. We've had funded 4 ECATs so far, and we have a remaining balance of $11,000. The LPGs, we're just working on, let's see, for fiscal year 13, we had 111 applications were received. 103 applicants were eligible. 82 applicants were actually awarded. Now, for the upcoming LPG, we have a webinar that we're doing on March the 8th that we're going to talk about the how to submit your RFP how to respond to the RFP for the LPGs for the coming LPG. And that concludes the financial report. Any questions?
Does that conclude your report?
Yes.
Okay, thank you. Now we have Division of Disease Control and Prevention Services, and I apologize, but I'm not going to attempt to pronounce your name and ruin it.
That's quite all right. I answer to anything, so I'm used to
As
any
do
and
I.
all manglings of my name. I'm Jana Zumbrin. I'm the acting director of the Disease Control and Prevention Division. In my regular job, I'm the section director of infectious disease prevention. So I don't have a great deal of in-depth knowledge about the EMS trauma registry, but we have our SMEs here, so I want to give you an update, and any questions you have, we'll be glad to field those.
Thank you.
I do want to mention that John Villanacci is now in the acting role of the environmental epidemiology and disease registries section. So we have two vacancies, one that I'm acting in the role of and one that John is acting in the role of, that hopefully the department will be able to fill in the coming few months. Based on Kathy Perkins' legislative report, I'm thinking we may need to develop a new registry functionality on reporting of injuries in sexually oriented businesses. So any of you who would want to be in on the requirements meeting of that, just feel free. I do have a couple of updates about the registry replacement project. First thing, we have gone live in production with the enrollment registration component. And so this new feature allows facilities to have greater control over their own accounts and to self-administer their accounts. And specifically, facilities will be able to create and manage new users. They'll be able to have new users complete system training online and enable new users to, let me move this microphone better in front of me. I feel like I'm fading in and out. Enable users, new users, to complete the user agreement online, and this will support customer service by directly updating regulatory license data changes on a monthly basis, automatically providing new entities with instructions via email on how to establish an account manager. And as I mentioned earlier, it allows new account managers the ability to receive online training. The second item about the registry that I want to update you on is that we also are now live in production with recommendations from the American College of Surgeons. So as of today, long-term acute care facilities and rehabilitation facilities can begin reporting trauma brain injuries and spinal cord injuries for patients who go into their facilities within 30 days of discharge from acute care settings. So what this really does, it enables these trauma patients to be matched between their post-acute care and their acute care to evaluate the outcomes beyond just simply survival at the acute care discharge. This will really allow us to evaluate the relationship between the acute care and the post-acute care, and really allows for evaluation of the entire system, including all phases of care for these patients. And that evaluation will assist in informing and developing public policy. Also, when we began this replacement project, one of the requirements that stakeholders requested was for the system to be compliant with national standards. So you may be aware we're continuing to follow the National Trauma Data Systems Implementation Plan to be both NMSIS and NTDB compliant. And as stakeholders also have expressed recently, not all stakeholders are able to submit data in the new format of the new system. So we are continuing to accept data in the old format, and so we just need to work with stakeholders to determine a mutually agreeable date at which point all users will submit based on national standard data sets. So we're in communication with stakeholders about this, with the stakeholders and their software vendors to determine how they can best implement the 2013 NMSIS and NTDB data specifications. And to that end, we'll be holding webinars and stakeholder meetings this month and next month to discuss the timelines first for the NTDB data sets. And once the issues with the NTDB data sets have been worked through, we'll go through the same process with the NMSA data sets. Also, as part of implementing the new registry, the staff has been reviewing Regional Advisory Committee business associate agreements to determine if some of those need to be updated. So far, about half of the RAC's business association agreements have been reviewed, and we expect to review the second half by about the middle of this month. And then by the end of the month, we'll be notifying the RACs that need to update their business associate agreements. Once those updated agreements have been done, the entities will be able to attach those updates within the data system, the accounts in Maven. And that's the end of my report. I'd be glad to try to answer any questions, or more likely call on the program and projects SME to answer any questions you may have.
Any questions for Commissioner Zumbrun? Go ahead.
Yeah. Can you clarify for the LTECs, is that mandatory or voluntary reporting to the NTDB? Maybe I misunderstood.
Okay.
Is it also rehabilitation facilities or just LTECs?
What we're starting out with is long-term acute care and rehabilitation facilities that are operating under a hospital license. So we have used the hospital license list for general and special hospitals, and we have contacted all of those starting back over a year ago. And so we already have established some account managers for some of those accounts, and we will reach out to other facilities that are not on that list as we go through this implementation. So right now, TBI and SCI are reportable conditions by law in Texas, and that includes getting post-acute data. So it's not voluntary, although we are rolling it out, and so we anticipate that not everybody is following the exact same timeline as we implement.
Question, Tammy, with respect to these TBI reporting requirements, if they're reported to the registry, does that meet that reporting requirement, or does it need to be reported separately?
To the registry, we have had a law that all of the TBIs, regardless of their length of stay, are reportable. We have never been able to actually implement that because we haven't had a mechanism for reporting, because that would include all the TBIs that are seen in emergency department and are sent home. So we do have some traumatic brain injuries being reported to us that are there for less than 48 hours, so they're not meeting the trauma inclusion criteria, but that's only about 5,000 cases a year. So not all of the facilities are using the trauma registry to report TBIs who are not there for at least 48 hours. So we are going to have two different records in the system. We'll have the record for the acute care of the patient, and we have a separate record and a separate account for the long-term acute care and the rehab data.
Any other questions from council? Okay, thank you, Commissioner Zumbrun.
Thank you.
Next on our agenda, we are I'm blessed to have a Texan who is now the director of the National Registry. So it's my pleasure to introduce Mr. Trey Rodriguez, who wanted to make some comments and make a presentation. Welcome.
Thank you very much for having me and the time to address the committee. As a certified EMT in 92 and a licensed paramedic.
You have to move the mic.
As a certified EMT in the state of Texas in 1992 and a licensed paramedic still to this day, it's a pleasure to be in a position as the executive director of the National Registry of EMTs to come back to my home and address this committee, this council. Thank you very much. I'm going to take a few minutes to talk about the National Registry structure and the evolution of some of the requirements to be nationally registered and to maintain the registry, more importantly. Now, the mission of the registry is not only to serve as the national certifying organization for EMS professionals across our great nation, but it's to develop a process which assesses and measures the skills and knowledge of our providers to determine entry-level competency, and then to assess and attest to continued competency throughout the length of their careers in a manner that's fiscally efficient and administratively efficient to deliver and execute, not just at the state level, but for all providers. In addition, such that the National Registry will attest to their competency on entry and continued publicly, if required, and defend that. All this being done in a manner that is not a fiscal or administrative burden to the state or the providers at any level. The Board of Directors is a diverse group made up of constituents from across the nation. I'll draw your attention in particular to the presence of a number of people from the great state of Texas. Dr. Dave Peirce, who's sitting in the audience today, Deb Kaysen from Dallas, Maxie Bishop, though he's transitioning roles, he's still on our board, will be through June, and myself, who I resigned my position in December to take over as the executive director of the National Registry of EMTs, starting in January. Now, the history of the registry is long, and it's filled with a passion and commitment for protection of the public and continued evolution of EMS systems across our great nation. When we look at the investment into the EMS community across our country, it's in the realm of $50 million plus. And we are the only accredited certifying entity in the United States for EMS personnel that's recognized by the NCAA. Now, let's put this in context. For the physicians in the room, your accreditation licensing process is accredited by the same group. For the nurses, the physical therapists, RTs, it's the same group. So it's a very demanding process. And when we look at this map of utilization of the National Registry certification for EMS professionals, the thing that stands out the most is the green. Those indicate states which use the National Registry of EMT certification at some level and in some form. So what you'll find is 45 states utilize the National Registry certification, including the federal government, the U.S. Army, the U.S. Air Force, the Department of Homeland Security. Now, it's interesting attention when we see the white that stands out. What we find is the utilization in those states is it's not at a state level mandate, but when you go to those states, you'll find pockets of nationally registered professionals which are requirements of the service they work for. Now, we have literally hundreds of thousands of nationally registered providers in our great nation. The U.S. Bureau of Labor estimates at any given time in the country is about 850,000 EMS professionals or emergency services professionals. The registry has certified to date 411,000, roughly. Now, several years ago, we began to look at the process to assess competency on entry into practice. And we moved from a paper-based knowledge assessment to a computer adaptive methodology, which utilizes item response theory as a better means of assessing entry-level competency. This was done through a multi-year process looking at best practices across other healthcare professionals. That has been launched, has been very successful, and the outcomes are as expected, they're solid. We began to look at the life of an EMS professional, the continued competency piece, which led us to look for best practices, the American Board of Medical Specialties in particular, where we began to examine how can we renew the process of recertification, which led us to the model which we call now the National Continued Competency Program or Requirement. This model has been a work in progress for several years. Multiple stakeholders from across the nation at every provider level, including members of the public. The program requires individuals who are continuous in practice to maintain their license, complete continuing education hours, and be challenged with new topics, as well as engage in self-assessment, individualized learning process in the recertification period. These are the 4 tenets of the model: professional standing, practice performance, lifelong learning, and cognitive competence. The requirements for continuing education, which is usually the big one that people want to know, how do I maintain the credential? We redesigned them and split them into 3 simple categories. National, which is half of the total, 50% are national topics. 25% are local, and 25% are individual. So let's take a second here. National, an example of a national topic would be AHA guideline changes. It's a good example. A local would be the local medical director or medical authority, based on needs of that community, will determine the topics required for that 25%. And then the individual is based on a self-assessment exam that the provider would take, receive feedback on, and then can be directed to bolster areas that maybe need some additional work. The net effect of this restructuring is focused, directed, continuing professional education, which allows us then to reduce the net hours significantly in some cases. So at the emergency first responder level, it's 16. At the EMT level, it's 40. At the A, or advanced EMT level, it is 50. And at the paramedic level, it is 60. So let's stop for a second. And using the paramedic as an example, we've gone from 72 to 60. Those 60 are focused and directed to either national topics. The national topics are defined and selected through national stakeholder committees. The outlines in the educational material that have been identified are then developed and provided as part of the National Registry of EMT Services to those providers and to the state. The local requirement, which is 25%, are determined by the medical director or medical authority based on needs identified in quality assurance, changing environment, that's determined by the local medical authority. And the individual learning assessment piece is done through a low stakes, web-based self-assessment that's again provided as part of the service of the National Registry of EMTs for the individual to reflect on their own strengths and weaknesses and to develop those over the course of their next recertification cycle. Now this is combined with what we call the Mark King Initiative. Now Mark King was the state director of West Virginia who died unexpectedly, way too young. And the Mark King Initiative would allow states who utilize the National Registry of EMT certification to reinstate every provider who's currently licensed, whose registry had lapsed. So in the state of Texas, for example, everybody that's currently licensed by the state would have their national registry reinstated, and then they would have to maintain that through the length of their careers. Now in the state of Texas, we have to date about 106,000 Texans that have been nationally registered. A tremendous number over the course of the years. And I myself took my national registry at UTL Science Center, Ronnie Stewart's shop, in '94, the written and the skills at the beginning of '95, and have maintained it since then. So I believe that's the last slide. If there's any questions.
I have just a couple of questions for you. I appreciate the presentation. I noticed in one of the first slides you noted that there was 411,000 initial certificates and only 83,000 recerts, for a total of about 20% of the initial recerts, mathematically anyway, recertifying. What do you attribute to that?
Well, that's on an annual basis, so the cycle. So we have people that recert. It's a cyclical process. So in any given year, we may have 80-some thousand with a total of 400,000. And it also depends on the utilization of the National Registry. So for example, in the great state of Texas, National Registry required on entry, but then it's optional to retain, much like yourself. I see you're a licensed paramedic. Did you maintain your National Registry, sir?
I had it a long time before National Registry was around.
Fair enough. So did I in the early 90s. So what we find is, because it's optional, we have individuals that will choose to maintain, some 30,000, and others that will choose to stay with their state credential, because there's two processes to manage. And usually that's what we see with some of the numbers.
What is your fair estimation of how many states utilize National Registry for the entry-level testing but don't require ongoing recertification?
That is a fantastic question.
35.
35.
So 35 out of the 45 states utilize you for initial but not ongoing?
Correct.
Okay.
Thank you very much for being here today. When we were looking at, next to the last slide, looking at those numbers, in looking, for instance, at the breakdown for paramedic for 60 from 15 to 15, is that annual or biannual?
Every 2 years.
So that would be during your certification period every 2?
Correct.
Okay.
So for the state of Texas, it's actually, the net is a reduction, which depending on your perspective, for the provider, it's the net hours are reduced. For the administrative perspective, potentially could be an efficiency gained in the administration and in the cost of the certification process, at least in terms of CE hours and on that side.
I would also thank you for coming today, and a nice, concise presentation. One area that I'm kind of interested in, because I've worked with the Emergency Medicine Board on putting together some of the similar sort of clinical competency assessments. And I know right now for the physicians, we're getting a lot of pressure to include in our practice performance patient satisfaction. I don't know if that's something that y'all see coming on the horizon. I mean, there's actually quite a bit of emphasis that's being placed on the physicians for that.
Absolutely, and I think that's a key component to this process. The frame for patient satisfaction really resides with the state and the employer and the individuals that credential the person for practice in their community. At the National Registry level, if we can serve as a resource in those discussions, we'd be happy to do that. But the focus of the organization is entry-level competence and skills and knowledge, and then continued competence and skills and knowledge through the course of the career.
Thank you. And actually, I do recognize, looking at this, that you actually parallel our processes. Absolutely. Almost exactly.
Well, we did an environmental scan of best practice in healthcare professions, and the American Board of Medical Specialties has done a fantastic job in establishing the pillars. So, I think the challenge when we began to look at this is to say, what's the best standard? What is the world doing? And let's see how we can move in that direction. I'm not suggesting the previous iteration was not effective. I'm saying it was an opportunity to build and to grow.
Trey, thanks again for coming as well.
Yes,
does this 60 hours allow for an increased number of online hours that would be accepted?
At this point, the online, we have limitations for online or distributive education methods. We looked at that several years ago, and in our analysis, we had some inconsistencies in time requirements versus allotment of educational hours. One of the things that we're committed to do is to revisit that. So in all likelihood, in 2014, we'll re-examine that process and determine if we're at a place now to open up or be more liberal with what can be the amount that can be earned online. And the point here is, when we had a committee that looked at online education over a period of time, and what we've consistently found in nearly half the cases, and again, I use the paramedic level, you could get roughly 10 hours of paramedic level continuing education in about 45 minutes. So then we would ask the physician stakeholders and the administrators whose job is to risk manage, would you feel comfortable delegating your practice to someone that spent an hour and a half and got all their C requirements for a 2-year period? And that's where we have some defined limits. It's not to say that those are set in stone. So we're committed to, in all likelihood, in 2014, we'll start that process up again to revisit that.
Let me ask one more question too. We sometimes look at card courses for use for recertification, and certainly there's been the argument that when you take it the first time, it's continuing ed. When you take it the second time, it's maintenance ed. How's the National Registry feel about the use of card courses for transition courses as well as regular CE?
Well, the transition courses, that's the purview of the state. So I think, it's based on your local need and the composition of the educational resources and of your stakeholders. In terms of the card courses as continuing education, I think that's a good source. One of the things that we've done in this new model, which the National Continued Competency Requirement Model, or I'll just say NCCR for ease of speak, we've removed the historic requirement for all the various card courses. So when we say 60 hours, it's a true 60 hours. It's not 60 hours plus ACLS, plus ITLS, or PHTLS, plus. It's a true 60 hours. Excuse me, that's not to say that at the local level, the medical director, if Ronnie Stewart is my medical director, and I say Ronnie Stewart because we were both at UT Health Science Center just for historical sake at the same time. If Ronnie was my medical director, Dr. Stewart was my medical director, and he said, Trey, you need to take ACLS as part of your local content, well, then there it is. It's part of my CE portfolio.
Okay. Thank you.
I have a couple of questions with regards to the CE portfolio. I noticed that you had 50% at the national level. Could you kind of break down how you would go about giving someone credit for their CE programs? I know in Texas we have a lot of in-house CE programs related to CQI and PI, and I saw that you had about 25% of the recognized CE from that group. So it's kind of a bit of a transition. I know that, as you spoke, the ACLS and the PALS are obviously something most medical directors want to see from their staff. What is the registry doing to, say, acknowledge or certify the CE that's being provided in the 50% not within the national realm? I mean, is there fees? Do you have to submit syllabuses and CVs of the people instructing? I mean, can you go through the process of what it is that you would accept under the 50% that has local and...
Sure. The outline for the national topics, the outline for the educational materials will actually be developed and provided as part of the registry. So there's no additional fees for that. That's part of the registry service and commitment to all of our stakeholders. I think if you have a program that's approved by the great state of Texas to deliver continuing education, then that suffices the needs of the National Registry, much like it does today. The only stipulation historically, and will still to this day, is the amount that can be allocated versus a distributive education format versus a traditional in-class format, which we're committed to actually revisit, starting in the 2014 strategic plan. I think the CQI or quality assurance driven educational initiatives, I think they're critical. They're so critical that we've actually simplified the CE model or CE portfolio model to say national, local, and individual. The local is in your area, there's, maybe there's some learning needs or some challenges around a particular patient presentation type or disease process, and you're there. There's an allocation that can be used to not only improve the performance of your system, but also used to maintain the credentials of your staff. And then at the local level, at the individual level, that self-assessment, that assessment tool, again, is developed and provided as part of the services of the National Registry. There's no additional fees. It's part of our commitment to protecting the public through excellence in patient care.
Okay, I just wanted to try to put that out there just to make sure. I know that, with these things, anytime there are changes, there's always a lot of water cooler talk and some speculation, and I wanted to be sure that as far as the component that I feel the most passionately about, which would be the CQI driven, you're right, Texas is a big state, and we're very diverse, and one thing that may be appropriate in the rural community probably isn't seen maybe in the more populous areas. So I know that was a question that had kind of been floated around. Are they going to require us to do a bunch of arduous things to be able to get our CE that is somewhat responsive to the daily need versus a whole process of months and months trying to get it approved? So
Absolutely.
Let me add one more question too. When we mention allocation of hours, because just like Ryan, we hear a lot of things and people ask us a lot of things, and sometimes we say things that people take out. I want to make sure, let's go back to the medic. If that 60-hour, is National Registry going to require a minimum category breakdown in each area? So part of that 60, the 30 hours national, would that have to include X number of cardiac, X number of respiratory, X number of special pops, or is it just going to be across the board?
So the national topics will be defined by a stakeholder committee.
Okay.
And so the first iteration, because this is actually being rolled out in April. In North Dakota. So the first set of national topics for our first pilot for the state of North Dakota have been established by our national committee. The educational materials that support those topics have been developed. They're in the process of being disseminated in the next few weeks. And at the end of the day, it's an educational institution. So when I was teaching at UT, I would then, we'd have to frame up the course. Obviously the coursework and follow the normal academic requirements for that. And then, we could issue a certificate, or even better, because the recertification process is now online. It's a web-based to create a workflow efficiency. And really, if there's workflow efficiency, there's a cost of efficiency in the administration. It can be done all online, simply by entering the topic and the course number, and the provider identification, and it's submitted. And what we find is, over about 60% of our applications now are done in that manner. And so I'm segueing from your question, and I recognize that. The web-based or the online recertification process allows processing time to go from roughly 2 weeks via mail, traditional mail, to about 48 hours online. So it's incredibly effective in its turnaround or cycle time reduction, and it creates efficiencies all along the workflow and the process line. So,
as an EMS educator, we thank you for going paperless, because that has sometimes been a very arduous task to get every piece of paper with all the I's dotted and T's crossed. With this new implementation, are we looking at an increase or a change in fees?
Not at this point. There's none foreseen, at this point.
Okay.
while I've got you at the microphone, I'd like to ask a couple more questions, if that's all right. We have a venue to kind of dispel some rumors so that people can bring their blood pressure down and hopefully get back to kind of pinpointing in on patient care. I'd like to ask you just kind of a frank question. Is there a push from the National Registry to get the state to condone or to pass rules that people who are National Registry will have to maintain National Registry going forward?
So let me make sure I understand your question, Ryan. You're asking me if there's a push by the National Registry to require the state of Texas to maintain their national registry,
If that's how they got their initial certification.
if that's how they originally entered into practice. Not that I'm aware of.
Okay.
I've been nationally registered. I've been licensed, certified, and then obviously when the paramedic licensure came out, much like yourself, in the state of Texas, a lot longer than I've been nationally registered. And both are, one's over 20 years and one's approaching. And I've never been approached or inferred that I have to in either case. So.
It's obviously one of those rumor mill issues that has some people across our state really with their blood boiling. So I wanted to be sure to just ask the question. I know that it's a point blank question. I apologize for putting you on the grill. Another question I have is we noticed at the bottom of some literature that there's a statement that says in order to participate in the program as outlined above that you have to be nationally registered. Is there any thought to the process that in states that have taken on the process of national registry for initial certification, so Texas in essence has a partnership with the national registry?
Absolutely does.
Is there any thought going forward that once you get the competencies and everything rolled out, that we would have an opportunity to potentially maybe subscribe to the CE portion of it, to where we could partnership on the CE without the person necessarily having to be national registered? I understand that it's obviously a perk of the national registered person, but if the state is going to accept that as evidence of meeting core competencies, then whether the person is carrying the national registry or not, they're still meeting some core competencies.
Yeah.
So I guess my question is, in the future, as a potential partnership or venture, would it be possible that we could look at doing some sort of a partnership where people could enroll within like a CE version, but not necessarily have the national registry?
Well, I guess my first statement on that is the registry. I mean, we do partner with the state offices, as well as our stakeholders, and the function beyond the science of determination of entry-level competence in the testing and item response theory and that process is to ease the administrative burden to administer 61,000 in the case of the state of Texas certifications, and then maintain and track those. And that's the part of the function and the service of the National Registry. I think when we talk about partnerships or relationships at that level, I think those are places to sit down and have that discussion. I mean, my first thought on that is, if you have an individual that's passed the cognitive exam and the psychomotor exam, so they've met the requirement for national certification and entry into practice, which is usually the biggest hurdle in someone's professional EMS career, in that framework, then to then meet the ongoing requirements to maintain that credential, but to let it lapse administratively, that sounds to be quite expensive, and not just in frank dollars, but in administrative work processes. So maybe the discussion there is to say, we're partners in this, in providing patient care and public protection. Let's talk about it.
Thank you.
Ryan, I just want to kind of tack on to your, we got all wound up here.
Wrestle the microphone.
Did you enjoy that? Sorry. To kind of tack on to the rumor about maintaining national registry once that's been acquired. The other part of that rumor that we hear up in the hinterlands where I live is that those that are not nationally registered will be required to obtain national registry in the future. Is that a...
Well, the national use of national registry, for example, in the state of Texas, let's just go through a scenario. If Texas was to move to the national registry as the standing credential, and Mark King was to be used, so everyone that had ever been nationally registered that is currently licensed by the state was reinstated. The individuals that from the old days, like myself, and it sounds like Ryan from the old timers, their credential is not affected by that process unless the state makes a decision to do that. And there's a couple different models that can be employed there that the registry would be open to.
Okay, thank you.
Absolutely.
Well, I'm maybe a little bit confused because I'm actually reading the Alabama National Registry Amnesty PDF. And down at the bottom, as far as this Mark King Initiative, it says participation in the Mark King Initiative is authorized by state EMS agencies who require EMS providers to maintain their national EMS certification as a condition of their continued state certification / licensure.
Right.
And, I mean, that was on your slide as well. So,
Right.
yeah, what I'm hearing is basically two different things. It wouldn't be required to obtain national registry, but for the state to participate in this initiative, it would be required.
So let me clarify. So if I, much like, let's use Ryan, if you don't mind, Ryan, you're here. Ryan was certified probably in the early 90s, like myself, where national registry was not a requirement. So if Mark King, if the state adopted the national registry, including the Mark King, we would not go to Ryan and say, you have to become nationally registered. He's licensed in your state. That would not be affected. Everybody that is nationally registered at that point, or would be reinstated, would be required to maintain that credential for the length of their career. So you'd have, over time, as the group, the people like Ryan and myself would progress in their careers, those numbers would fall.
But if we're looking at a situation similar to the physicians where we're being required to participate in maintenance of certification, not licensure, maintenance of certification,
Correct.
then aren't all these people that are not nationally registered, then is there going to have to be some other process for them to participate in maintenance of certification, or are they going to have to get a national registry in order to participate in your program?
Well, I think if we're having that discussion, I think we would look to have those individuals mirror the maintenance of certification requirements, which in this case would actually be more cost effective than the current model, and they would maintain their state credential.
How would they mirror that? Would that be through your agency or through DSHS, or?
I think we would work with DHS to determine the best fit administratively.
With some of the changes coming down the line that we've heard today, and let me give you a little background on where this is coming from. Having chaired the education group for Texas, people ask us a lot of questions, and we talk to transition courses. And the one that said it, some people asked, do you think we need to keep our national registry? And I said, yeah. I said, at some point in the future, we're probably going to have it. Now, I think some people thought that meant 30 minutes later. If we go back and look traditionally at 1996, when we started to look at the strategic plan for EMS, accreditation didn't get done until 2012, 2013. Right. So I think some people thought, oh my God, we have to go do that in a minute. And that's when the water cooler discussion started. That's when people got upset. Even though we knew a lot of this was coming down from National Registry, that's not going to affect us, if ever, for decades, more than likely. But even if it does, I know that in the state of Texas, there'll be tons of stakeholder input, and it will have to come from National Registry as well as DSHS as well as from committees. So I'm just going to say this publicly, don't see it happening anytime soon. Just want to make that clear to anybody out there, that for those people that do have it, and I think what a great idea for those people who were ever nationally registered and let it lapse to be able to go back and get it. Much easier than they had been in the past. I think that's a great thing.
And let me make a point to say, if you're currently licensed and your registry is lapsed, this is the question that and it's a really logical question. Does reinstatement involve taking the cognitive, the computer test?
That was my next question for you.
Reinstatement is, as long as you're in good standing, you're licensed by the state, then your national registry will be reinstated. There's no additional testing imposed by the registry.
Thank you.
So to be clear, to Don's point here, or Dr. Phillips, at the bottom of the Alabama statement, it says that this program, in order to participate in the program as you outlined, that the state must require continued competency and certification with the National Registry. In Texas, that is not the case. So to be clear, you're saying that those who were certified through programs in Texas, became certified with National Registry, maintains their National Registry, they will have access to this CE program, even though our state does not require them to maintain their National Registry.
Yes.
Okay.
Yeah,
All
well,
right.
because they're nationally registered providers.
Right. Well, it just said in there that this program is only available to those that work in states where the state mandated National Registry continued participation.
And
That's
is that
what-
a state of Alabama website?
That's actually the PDF.
Yeah, it was the
Regarding
PDF.
their amnesty program with
Yeah.
National Registry. And there's another one as well that's has a similar statement.
The registry has a long history of supporting education for all EMS professionals. So when you go on the registry's website and you look for skills assessment sheets or documents to do skills testing, to do any number of things, they have always been provided for use by the EMS community to further develop, us, the providers, and that commitment will not change.
Any other questions for Trey? Okay, it's already been said, but just so my email doesn't blow up, this has been a discussion about the National Registry Program. There have been no rule changes, no intent to change rules or anything about CE or anything like that. So we, as you can tell, that's kind of a touchy subject here, so we were glad that you were here today to explain that, your National Registry Program, and it was very informative. We have something we would like to present to you. You're a star, you're in the Texas EMS magazine, and so we've got some pages here, and we appreciate you being here today.
Thank you. Thank you. Thank you very much.
Thank you. And did you say you were going to stick around? Okay.
Yes, sir, I'll be here as
If
long
any
as-
stakeholders have questions, Trey's agreed to stick around through the meeting and then probably a little bit afterward.
Absolutely, thank you.
Thank
Thank
you.
you again for allowing me to address the council.
Thank you, Trey. Dr. Smalling has to leave, and so he's requested to give the Cardiac Care Committee report. Dr. Smalling?
Thank you very much. I apologize, I have another commitment, so I would like to hopefully this won't be very controversial. The Cardiac Care Committee met yesterday a little bit after 4 p.m. We had an excellent attendance. Dr. Wozniak and Todd Haugen discussed plans for a new STEMI system survey. As you may know, the DSH has had a STEMI system and stroke system survey last year. When we reviewed the results from that survey, there were some concerns about the data and for a variety of reasons, and so it was felt that we ought to revisit that. The plans are to generate the survey with the collaboration from our committee and other input, then distribute the survey to the regional RAC executive directors, who will then delegate whoever in their group needs to reply, and then make sure it gets back to the survey team. It'll be analyzed and then reported at our August GETAC meeting, and the results will be distributed to the overall GETAC organization. We also reviewed the recent update in the STEMI care guidelines and compared them to the previous STEMI care guidelines, and basically the main changes are they have encouraged use of fibrinolytics if patients presented with a first medical contact to anticipated balloon time of greater than 120 minutes. Then they also allowed now a urgent angio and PCI of a culprit artery in patients who receive fibrinolytic therapy, with a few variations on that. Lonnie Den then reported that 120 STEMI receiving centers in Texas are now reporting data to the National Action Registry, and probably for the first time, mortality data from Austin, Houston, and San Antonio will be reported at our next meeting from the Action Registry. We have been accumulating a good deal of information on STEMI care and had proposed at a previous several meetings to put that on the GETAC DSHS website. We were informed that the server capacity on that website was not sufficient, and so CETRAC agreed to house the information with a link from the DSHS website. Catherine Bissell reported that web portal and what they have built so far. We will put references on STEMI care and EMS STEMI care on the website, as well as protocols for various geographically represented STEMI systems, for instance, large metropolitan areas, rural areas, and so forth, so that other RACs and other STEMI systems can have a resource to model potentially what might work best for them. We also will put sampler STEMI care feedback reports from STEMI receiving centers to EMS providers on the website, so other STEMI systems can see how that would work. Finally, there was a public comment. Joel Romo, the lobbyist for American Heart Association, reported on plans to submit a bill for establishing STEMI, a mechanism for certifying STEMI centers, both sending and receiving centers. In Texas, the model will be similar to the previously approved stroke bill. Obviously, funding probably won't be asked for this biennium, but hopefully we'll pursue some private funding sources to help get the effort going. That concludes my report. Any questions?
Any questions for Dr. Smalling? Do you need counsel to take any action on any items? I didn't hear.
Not.
Okay.
Thank you so much.
Thank you, Dr. Smalling. Some folks came in a little late this morning, so I just wanted to remind everyone that agenda item 1 is going to be pushed to the very end of the meeting. And if anybody wants to get the buffet ticket now, it is after 10 o'clock. You can go buy that so we can move through the line faster. So any council members that need to go do that, or committee chairs, or stakeholders that would like to do that, or DISH's staff, you're welcome to go do that. Does council just please leave us a quorum up here? Thank you. Next, we'll hear from Bruce Clements on preparedness.
Good morning. Okay, we're on. Good morning, everyone. Good to be with you. Just had a few things to update you on. I'm here on behalf of Dr. Paul McGaha, who has been acting as the Assistant Commissioner for Regional Local Health Services, and kind of in keeping with kind of a theme this morning of a lot of people coming and going, I have a couple of announcements to make. We do have a new Assistant Commissioner who has been selected. He should be here at the next meeting, and his name is David Gruber. And he's going to be serving as the Assistant Commissioner for Regional Local Health Services, which, of course, HPP and FEP, all the preparedness programs are now in that division. Just a quick overview of some of his background. I've known him for quite a few years. He's been in the preparedness arena, both HPP and FEP, for quite a few years. Most recently, he served as a special assistant to the director of the New Jersey Office of Homeland Security. Formerly, he was also a senior assistant commissioner with the New Jersey Department of Health. He does have some Texas roots. He was a preparedness planner in Dallas County for a while, and prior to that, he had 21 years of naval service, including assignments as a pilot, an intelligence officer, and a chemical warfare specialist. So we are very excited to have him on board. He will be starting the first week of April. We have another new position as well. As you all may recall, our HPP branch manager, Beverly Ray, retired several months ago, and we do have a new replacement for her. We did reorganize a little bit, and now we have all the grants management is really in one branch together. So this is HPP and FEP grants management, and the individual selected has been with us now for about 3 hours. She started this morning. Her name is Lisette Osborne. She comes to us from DSHS Region 7. She has a BSN and MSN from UT San Antonio. She's a former neonatal nurse practitioner. She has about 20 years of public health experience as well, senior positions in healthcare, school health, public health. She's the current president of the Association of Public Health Nurses. So she brings a real passion and a real wealth of knowledge to our program. We're looking forward to getting her going, and she should be here at the next meeting as well. So those are our two personnel announcements. A couple of quick updates then on the program. The timeline now for the current RFP and the upcoming FOA, the funding opportunity announcement. First of all, I want to talk briefly about the HPP funding opportunity announcement. I just checked my messages just a few minutes ago. I was on the phone this morning with CDC. That funding opportunity announcement should be posted today. I was hoping to have an overview for you this morning. Unfortunately, it hasn't hit yet, and CDC won't share anything until it is formally posted on grants.gov. So that should hit later today. I do want to point out, though, when you look at the numbers on there, we requested that CDC and ASPR be very conservative. It's a lot easier for us to take numbers that are not final, that are actually lower, and add to them than it is, obviously, to take a temporary number that is higher than what it eventually winds up being. It's easier to plan up than down. So we've asked that they be conservative because this is kind of a preliminary first stab at what the budget will be. They don't have the final numbers yet, but they're going to make their best guess with all the best information they have, and they are going to shoot low. So the numbers you see will in all likelihood go up to some extent later. On the RFP, the proposals for the HPP RFP are due in by 2 o'clock next Monday, March 4th. We hope to have contract negotiation conducted in about mid-April, and then we'll post the final awardee list to the Electronic State Business Daily website by the end of May. We anticipate distribution of the final FY14 contracts to awardees beginning in mid-June. Of course, those timelines are they're tentative, so they're subject to some change, but that's what we're anticipating at this point. We are going to step up monitoring a little bit to just assure that we spend down our funds. That's been an ongoing priority for ASPR and for CDC. By the way, there are going to be 2 no-notice drills coming up in the near future, 2 separate available bed report drills that should occur sometime in the next several weeks. Our ASPR HPP project officer, by the way, is also interested in using some of our healthcare coalition work and our mass fatality efforts to share those as HPP best practices nationally. So they're getting more information on those and will be sharing them with other HPP stakeholders across the nation. 2 things that we have coming up as far as kind of exciting or interesting initiatives. We have a new initiative kicking off. We're going to explore crisis standards of care. As you all probably know, 2009, the Institute of Medicine put out an initial report on crisis standards of care, put out then after that a more comprehensive report that is pretty prescriptive. It lays out who should be at the table, what the questions are that we need to ask for hospital, for EMS, for public health, to define what the triggers are to switch over to crisis standards. An example of that is allowing a provider to do things that are a little outside of their scope of practice when you don't have enough nurses or enough physicians. So we're going to start exploring that, kind of using that prescriptive approach that the IOM has laid out for us, and I think many people in this room will be involved in those meetings to begin that. It'll take about a year. We'll probably have 3 larger meetings to bring stakeholders together for discussions, writing the report in between. So more to come on that, and there is also a preparedness survey that's going to be done statewide. All the long-term care facilities and all of the hospitals across the state will be receiving an electronic survey asking specific questions about preparedness. And then that will be followed, for the hospitals, that'll be followed with a telephone survey to kind of get a little more qualitative information as well. We're working with Texas A&M on developing that survey right now, and so within the next several weeks that will begin, and we hope to have the final report sometime in June. So that completes my report. If you all have any questions.
Any questions for Bruce? Thank you for your report.
Thank you.
Next on the agenda is the Preparedness Coordinating Council. Eric Epley, Vice Chair.
thought he was buying lunch.
Preparedness Coordinating Council hasn't met since the last time I gave our briefing. They have one coming up very soon. You're going to give the GETAC Disaster Committee, you're going to wait until we get in order for that.
Is that okay with council? It's okay by me? Go right ahead.
So GETAC Disaster met yesterday. Several things going on, obviously. The Texas Texas Division of Emergency Management's conference is later on this month, March 25th through the 28th in San Antonio. There's a mass fatality conference that's occurring in Houston starting next Monday, which is already has registered 300 plus people, and will be a big event. There'll be a high focus, as Bruce was discussing, there'll be a high focus on mass fatality this year, so that's going to be kind of the kickoff event. TDMS, the Texas Disaster Medical System, which is led by Dr. Kidd, discussed all of these issues plus a HIPAA-compliant disaster medical record capability. Right now they're using paper, and so we're going to try to use one of the commercial off-the-shelves products to put that into a HIPAA-compliant thing and then take the paper out of the whole process after the fact. The Emergency Medical Task Force project, led by Victor Wells and the other teams around the state. 12 of the 13 ambuses are licensed now, so we're very excited we're moving that along. Mike Elliott, I think, knows which bus is not licensed. The establishment of a driving course with DPS, with the Texas DPS. We've established essentially an EVOC course for the ambuses. The DPS has opened a new facility in Florence, Texas. It's state-of-the-art, and DPS has brought the ambus operators on. They're putting together a certification course to drive that. So in addition to sort of FAO status, they'll have special ambus training, which is incredible. The MMU working group has been working on job descriptions and standard operating guidelines, which we're excited about and moving along. The MIST, the Medical Incident Support Team course, will be at the TDEM conference on March 26th and 27th. There'll be a blast email goes out on Monday about how to sign up for that, and we're encouraging as many people as they want to sign up for that. Last week we held an ambulance staging manager class in San Antonio. We had 19 personnel trained. So the final thing is that we're putting together the dates for what we call the refresher, which is a 1-day or 2-day session for ambulance staging managers who've been trained previously and medical incident support team guys as well. That will be in Galveston. Dates to be announced, but will be late April, and all the details will be announced then. We had a wonderful presentation from Dr. Maggie McGraw on electromagnetic pulse, EMP. If you haven't heard about this, this is scary, scary stuff. It's kind of like pandemic for electrical things. Cars, electrical lines, everything kind of just gets blasted out. So it's part of a nuclear explosion. If you had a state agent, a nation state that went rogue and blasted a nuclear device over our nation at 400 feet, 400 miles up, you could actually knock out the whole power grid for the whole country. So it's a frightening discussion. TMAC, the Texas Emergency Management Advisory Council, something that Chief Kidd has tried to mimic. I think your good work here with GETAC. So he's building that process out at TDEM, and I think it's good to see other state agencies mirroring what DSHS has led the way with on that front. And from our homework, so our group committed to asking for 90 minutes, for a 90-minute slot. There was also discussion, at least by, we're already in collusion, some of the chairs, so we'd like to find a way to pick our time slots, our dates for the whole year. At least Jody Deadly and I are in agreement. We'd like to pick, if we're Wednesday morning, then you're Wednesday morning the whole year, you know, and so you kind of can predict out for your club members there. Nick Sloan will be our registry representative to the Trauma Systems Registry, and that's it. I'll take any questions.
Any questions for Eric? The MIST training, are there prerequisites for that?
There are.
Okay.
It's in the brochure that will go out. There's
Okay.
ICS 300 and 400. There's several, but yeah.
Okay, thank
guys.
you. Air Medical, Shirley?
Okay, I'll try not to drop the microphone this time. The Air Medical Committee met yesterday morning. The items of discussion, the first item was the regulation of out-of-state air medical providers bringing patients either into or taking them out of Texas. We've had this discussion at several of our meetings. After the last GETAC meeting, a work group was formed, and they formulated some questions that will be submitted to Maxie so that he can provide written answers. Maxie is aware of the questions. He was part of the work group. And so we're just, I guess there's just some cleanup to do on the questions, and then they will be submitted to him. But the questions, and I'll just kind of paraphrase these as much as I can. The question asks about, one of the questions asks about oversight of providers entering Texas being necessary, particularly in addressing quality issues when poor care has been documented. The next question, when an out-of-state EMT gets in the back of a Texas ground truck, the MOT should, at least by Texas law, define what level of skill is necessary for that patient, so that rather than having to question them about their certifications, the MOT should take care of that for them, and hopefully that will. They talked about an MOU with some of these out-of-state agencies that would alleviate the need for dual licensures, some Texas and Louisiana, or Texas and Oklahoma, Texas, New Mexico. Even for some of those scene calls that are dispatched by 911, however, trying to do a number of those MOUs, certainly in a short period of time, is really not feasible, especially when those services have, if they're a large service and they have a legal department that those all have to go through, that always complicates things. The question has been asked, do you agree if there are quality of care issues with the out-of-state provider, that those should be handled as medical director to medical director conversations? And I think that the general consensus from our folks is yes, it should be. Trying to run those through the state entities is going to be very difficult. And a timely process. But then the other part of that question is, then where is the loop closure? So how do we make sure that that happens? And then in reference to Texas Health Code 77305, does that mutual aid agreement address those requirements? In 15711, it says you must have a patient care record for every patient transported. So does the documentation example care provided by blank or the care provided by transfer per agreement with a service, is that documentation enough to meet that requirement? It states in rule that out-of-state responders entering Texas to provide care have a defined number of times where they can come into the state before they need to obtain Texas licensure. So, what is the process for monitoring the number of times those services come into the state? And I think we all know that there is no way to monitor those. And then the last question was, would a model such as a compact license for nurses benefit Texas DSHS licensing oversight for compliance and competencies for EMS providers, with national EMS guidelines being the rule? So those are the questions that we've been tossing around for several meetings. And so we hope to have the written answers for those. We know Maxie's leaving, and I think we'll have those taken care of and won't have to discuss those again. The Air Medical Memo of Agreement for Mutual Aid for Disaster Response. There were some issues with the MOU or MOA. Those are being worked on by Rick Bays and Jeff, and if I mispronounced Jeff's name, I'm sorry, but Jeff Hogan. And we probably won't have a draft for our next meeting in May, but hopefully in August we'll have the draft on that. We also talked about our draft rules, our draft air medical rules that were turned in, I guess, over a year ago. What we have been told is that actually what Maxie said was he was waiting on the model state guidelines to be approved, printed, before he was going to do anything with our draft rules. The model state guidelines are now published on the Ames website. That's version 1, and I think there's an expectation that there will be a version 2 in the future, and it will go on just as any other document does. But the committee would like to now see some movement on our rules, on the revision draft. A gap analysis was done. Previously, Alicia Warren spent many, many hours doing the gap analysis of those two documents, and what we found certainly was not surprising to us, but our draft rules are certainly more comprehensive than the model state guidelines. So what we would like to do is have a meeting with DSHS personnel sometime before our before our May meeting. Sit down for 3 or 4 hours. I've talked with Jane about doing this, and just go over those two documents, the gap analysis, see if we need to do some blending, whatever it is we need to do, and then move forward with those rules. Our newest committee member, Tracy Fox, volunteered to serve on the Trauma Systems Committee work group for us. She is here, so I think that'll be probably a little easier for her to do that, and she's very good about doing things like that. Kathy, in her report, mentioned House Bill 1656 by Representative Dillon. That was dropped last week. It's called the Emergency Medical Air Transportation Act, and it's been designed to create a new revenue source for funding emergency air ambulance services statewide, who currently receive no state or local funding offset for services provided to indigent patients. The proposal there is to add an additional $5 penalty to every motor vehicle moving violation, and then would be deposited wherever it needs to be deposited. And then as those funds are distributed through the Texas Medicaid program, it would draw down additional matching federal dollars. So even though it's a brand new bill, and we realize that there's parts in there that are not perfect and that are not going to work maybe just like it's written for DSHS, I certainly would encourage support of the bill. And that's my report.
Any questions for Shirley? And there's no council action necessary? Education, Jody?
Thank you, sir. Education Committee has met twice since we last got together. We met on January 18th in Waco, and again this Wednesday on the 27th. Had 6 items on the agenda. The first one, we were looking at equivalency and transfer process. We have a lot of students now who are approaching colleges and universities because they're wanting to promote at their departments where they looking and needing college hours. Maybe they took their EMT or their paramedic program from a non-traditional college or university environment, and we're trying to find a way to get the equivalency and transfer. Most of the discussion centered around equivalency because transfer is guided by the Texas Education Coordinating Board and Southern Association of Colleges. trying to figure out how we convert those hours through private education to college credit. We polled every education program that was there, and almost every program had a different process for getting that done. Some would allow you to CLEP. Some would allow you credit for it. Some would not allow you credit for it at all, but yet would mark CR on your transcripts. Some would allow you to use that to go to paramedic school, but not count the hours. So what we're going to do is to take this on because one of the questions that was discussed at length is, does the certificate or license show competency equivalent to the standards that the college would accept? And I think that's probably going to be our longest standing issue, is to try to figure that out. You would probably look for a survey coming out from us to all the education programs and colleges. I'd like to find out at least what the most prevalent way is, maybe some ingenious ways that people are doing it. We know that there's no way we can get the colleges and universities to have to do it, but we're going to work really hard, especially to try to help some of the rural and frontier areas where the education might not be as accessible to them. So we'll keep on working on that one. Medical directors for CE programs, we did discuss that at length regarding transition courses. I think it was a loophole that sat there for a long time that people just didn't realize until we started to look at transition courses, and I think there's been some consternation and just outright confusion on who's going to have to take a transition course or what it's going to entail. We are looking at transition courses that they can be taught by initial education or they can be taught by CE. And examining this, in conversations with Dudley, we looked and saw that if you are an initial program, and all initial EMT and advanced and paramedic programs have a medical director, that transition content can be taught by CE. But when we look, you can do advanced CE currently without a medical director. So that loophole has kind of been there, that if John Doe wants to teach CE at the advanced level, he can do it without having a medical director, whereas that same content that would be taught in a paramedic program would have to be approved by a medical director. So we looked at this the last two meetings and bringing forward to the committee today. Probably, I'm not sure if we want to act today or if we need to post this for another 30 days, but the committee members prepared the following motion for action on January 27th, GETAC Education Committee meeting, and it's very short, and that is that all EMS education programs in Texas must have a medical director. We felt like that was the best way to cover that loophole. I don't think it was intentional, but if we're looking at transition guidelines, that everyone except this one would have to. Didn't think it would be onerous, didn't think it would be tough. You're just having a physician review the same content that you're presenting. Item 3 was negotiation on contiguous state regulatory agreements by DSHS. We identified the need for those institutions along our borders, that if we have students needing to go outside because of boundary issues, because of educational opportunities that are not that far away, but maybe not in Texas, if you're in El Paso or Sherman or Denison or Wichita Falls or anywhere up on the border, that if there's a positive education opportunity for you just a little bit north, we want to work really hard to get those barriers down to allow those students to then go to wherever. At first, there was a motion on the table to request DSHS to help negotiate regulatory agreements with contiguous states. And after a lot of discussion, we decided to take the word contiguous out and say that if there's a positive education opportunity anywhere and that the program directors and the medical directors are in favor and have the right MOAs, MOUs, contracts, and agreements in place, why would we want to restrict that? So we're going to do a little bit more work on that and bring that one back to GETAC probably for action at our next meeting. Agenda item 4, which is quality of online EMS education, we actually tabled it, and then there was a motion to take it off the agenda, and that was unanimous, and that's what we did. Medical director oversight of students during clinical and field internships. Medical director committee identified the need for notification of the service provider, medical director, that there are clinical agreements between the EMS agency and the educational program. Some felt like this should be in the provider rule, others felt like it should be in the education rule, but somewhere we think it needs to be in rule. We had a lot of discussion whether we should just, our suggestion was to add a signature line to the field agreement. Should it be part of a contract? How do we know? And I think the big issue came up, as long as this is communicated in some fashion that's documented, whether it's an MOA, MOU, contract, added to the agreement, email, something, so that there would be an opportunity for both medical directors, because the question originally arose that if the school medical director sends students to the provider for clinicals, whose protocol or guidelines are they working under? And certainly it comes down to that precept in the back of the box, who's working for the service medical director. However, there's no way that we've tied those together so that there's an understanding between those two, because sometimes we end up with issues. And our group is certainly trying to iron out those issues. In our agenda, it said review that. It didn't say discuss or take any action, so we have reviewed it, and will certainly be in favor of assisting both sides with whatever document they want to and draft for that. Item 6, representation on trauma system committee registry work group, and the committee chose John Creech to serve as the as the education representative. At the beginning, too, we also had a moment of silence. It seems like every meeting we have, we look and we've lost another pioneer, we've lost another provider. Certainly don't mean to leave any out, but certainly when the educators find out that another educator has gone home, it certainly rings a bell. And some of you have probably heard that Kelly Wolf, who was a longtime EMS educator at Careflight in Dallas, was killed in a motorcycle accident. And a lot of us knew Kelly, worked with Kelly, respected Kelly. So the committee did observe a moment of silence for him. And we also congratulated Maxie at the end and thanked him for his service with a standing ovation. And we will be presenting him with a certificate later. Our next work group meeting is scheduled for April 12th here in Austin at the Public Safety Training Center at 4800 Shaw Lane. We'll be in Building J in Classroom 1, and that'll run from 9 to 3.
Any council questions for Jody?
Did he make a motion about the education committee, about the medical director for CE? Sounded like he sort of made a motion.
No, the committee looked and said, because on the agenda it said review, we reviewed and felt like the committee would support whichever direction, but did not make a motion. I did come to the medical directors and on my own give you all my comments, but as a group we did not.
Okay, so council doesn't have to take any action.
Not on that one. Would ask for agenda item 2, and that is all EMS education programs in Texas must have a medical direction or medical director oversight. We are looking for a motion to move forward on that one.
Would that be a proposed rule change, or are you just looking for an endorsement of that?
We would be looking for an endorsement of that to then move to DSHS to help them write the rule so that we close that gap for CE.
Is that the same as agenda item 9 here, which is actually agenda item 8? Is that the same thing?
Actually, 2 separate ones. Item 9 is reference students doing clinical rotations for the medical director responsibility. We're looking for support from GETAC for medical directors being involved in all education programs.
So I'll entertain a motion for that.
So,
And a second?
Second.
Okay. Any discussion? All right. As we make sure we get stakeholder input, I will open it to the floor for stakeholders if they have any questions or comments about the GETAC endorsing that EMS education programs must have a medical director.
Who
Howdy, Dudley Waite, City Assurance EMS, and as Jody alluded, I brought this to them, I guess a meeting or two ago, and the medical directors as well, something we discovered in our system quite by accident. And I just want to make sure that in your committee meeting, when you said all education programs, that all is going to include initial and CE and renewal and partridge in a pear tree education.
We started to
programs.
list them out separately, and we said, let's just put all, and that encompasses all.
All right, cool. And as long as they know that, I think we're good.
Okay.
All right, thank you.
We're good.
Any other stakeholder would like to ask questions or provide input?
Just from the medical director's perspective, we completely support that.
I had a question, and just so I'm clear, if for some reason I wanted to open Vance's EMS CE, and I got state approval with state numbers, I would still have to have a medical director for ECA or EMT Basic?
Correct.
Okay. Last call for stakeholder input. Any other council discussion? All those in favor, say aye.
Aye.
All opposed? Motion passes. Is that it, Jody?
That's it.
Okay,
Thank you.
Dudley, that's why you hung around close.
Absolutely. Howdy, the EMS committee met Wednesday at 4 o'clock in the afternoon. First item that we had to discuss was we lost a committee member since the last time we met in November. Tony Gilchrist with EMS for Children has left his Texas position to assume a position in Washington, D.C. I'm sure we'll see him in and around Texas, either pushing surveys or doing other work here, continuing to advocate for the safety of children in the pre-hospital and hospital environment. But we wished him well, so that leaves us an opening on our committee. We put him on there because he was from EMSC, and he's been a pretty valuable member of the committee, so he's going to be missed. The first thing, big item on our agenda was the items that we've been looking at for the last 6 to 9 months regarding ways to help regarding the number of ground EMS providers in metropolitan areas and suggesting rule changes to you guys. We talked at length about this in November, and you guys asked that I do a survey. That survey has not gone out, although it is ready to, and I hope to put it out after the meetings conclude today. We did have another interim meeting in the meantime, and we talked about it, and this interim meeting was in Houston. It was extremely well attended, and the ideas, the 7 ideas that are on that piece of paper were the first one, the administrator record, was so well received in Houston that the EMS committee kind of felt like we were having to put the brakes on it. They were wanting to go from 0 to 90. Now, granted, they have issues in the city of Houston that a lot of us aren't facing in our communities, and so they may be a little bit more motivated to see some things that'll try to fix that. But we continued with that meeting and had a lot of great input by the stakeholders. Some of that's actually going to go in and help craft the survey. And because we're starting to kind of narrow down on a consensus of what all these ideas would be, and so we're hoping to have the survey completed and a little bit more work on this, and maybe be able to bring you some real recommendations at the next GETAC meeting in May, because some of them are coming together really well. And if you'd like me to review those in the essence of time, I won't, unless you want to hear what those ideas are that we've already kind of feel like we've reached consensus on with the stakeholders, and which ones we haven't. Took some public comment on that, and then we got to our next agenda item, which was to nominate somebody from the EMS committee on the Trauma System Committee Registry Work Group, and Brian Petrilla was nice enough to volunteer for that, and so he's going to be serving on that. Dr. Shaw gave us an update on the EMS for Children, which he'll do for you guys. Jane gave us an update on the status of the 157 recommended changes that we turned in, and for some reason there's something going on here in Austin that's got everybody distracted. It may be traffic or some music festival. I don't know what it is. Something's going on here. And so that's kind of taken some time away from the DSHS folks, but that's still moving forward. We got a report from our representative on the combined work group that Shirley spoke of to talk about fixed wing rotor and ground issues when they're all on the scene and trying to treat the same patient. Dr. Greenberg was nice enough to give us an update on the Texas Medical Director rules and the rule changes there for everybody that was in attendance. And then we talked about the medical director's position on EMS students and the medical director needing to have knowledge of what those students are doing and where they're coming from and all of that. The EMS committee voted to support that and recommended GETAC that GETAC also support the fact that medical directors need to be involved in that decision. And through signatures on the agreements, or however that turns out to work out, the EMS committee feels that it's our responsibility as EMS operators to make sure that we are watching out for and taking care of our medical directors, and this is certainly an area where I think a lot of us may have not done the best job in that. And so we see the need for the medical directors to be involved in that process, and so we supported it as a committee as well. We also supported the Education Committee's work on developing a process for having clinical agreements outside the state of Texas. Some of the folks that attend our meetings have been talking about that for a little bit because they're closer to hospitals out of state than they are in state, sometimes by hundreds of miles, and felt that if they could find a way to do that, that would be very beneficial. So I think as Jody continues working that process forward, our folks are going to be involved in that as well, and we continue to support that. And we also supported the motion that you guys just passed on CE needing medical direction, as well as all education needing medical director oversight. We got a report on some legislative activity, and we are going to meet again before the May meeting. We don't know where or when, but it'll probably be sometime in the mid-April time frame. And we've been invited to go to the Valley. And then we've been invited to kind of go to the Valley doorstep of San Antonio. So we don't know where that meeting is going to be yet, but as soon as we get that confirmed, then we'll put that out.
Any questions for Dudley? I didn't hear you say there's any council action needed.
Not this time, no. We hope to bring some in May.
Okay. Thank you. Injury prevention, Shelley Stevens Stidham.
The Injury Prevention Committee met on Wednesday at 2:30. We selected Courtney Edwards as our from Parkland Hospital as our trauma systems work group representative. We were scheduled to have a meeting or a presentation from Fort Worth, who has just been designated as an international safe community by the World Health Organization and the National Safety Council, but they couldn't make it, and so we're going to try and reschedule them and have them come to our next meeting. For the last several meetings, we've been talking about developing a tool called the Spectrum of Prevention. It's actually a tool that exists, and we've been talking about trying to develop injury-specific spectrum of prevention tools that have evidence-based strategies in those. For those of you who don't know, the Spectrum of Prevention is actually a 6-level tool that goes from looking at policy strategies down to individual level education. And so for the last several months, our committee members have taken different topics and have developed a spectrum tool on those different topics. And these include like motor vehicle crash injuries, alcohol-related motor vehicle crash injuries, pedestrian injuries, older adult falls and stuff. So we had several of those draft copies available and for the committee to look at. We hope to finalize that at our next workday meeting. We also made them available to stakeholders, so we're looking for stakeholder input into those as well. Our next meeting, we're planning to have a workday meeting in Temple on April the 12th, and I'll be getting an agenda to dishes on Monday for that. So we hope to finalize those spectrum tools at that meeting. We also had some discussion about the length of how long our meetings need to be in the revised format. Virtually all of our committee members like the existing format, but I'll be sharing more of that at the executive committee meeting after this meeting ends. We had some updates on the TTAF TIPS course that was available on Monday. I think there were 46 people who attended that educational symposium on injury prevention. And then we had some updates on the TTAF-sponsored EMS and Trauma Advocacy Day that was held on Tuesday. And I believe that was it. No council items to be considered.
Any questions for Shelley? Thank you. Medical Directors, Dr. Greenberg.
Certainly. We had 10 of our 11 members available. We completed our business on time, and coincidentally, neither Dudley Wade or Eric Epley spoke. I think that's just a coincidence. Absolutely. Dr. Beeson actually volunteered to be our representative to the task, the work group, for the trauma systems. We endorsed the promotion of the pediatric evidence-based guidelines, which I think we're going to hear about in a little bit, and request that a link be placed on the medical director's webpage for that. The committee has agreed to review and to forward to DSHS recommendations for Texas Medical Board Rule 197 required courses for EMS medical directors, and we will possibly be having a follow-up meeting in April before the next meeting of this committee in May to help move that along, because there's already physicians asking which of those courses may be approved. And we're going to try to do that at the TCEP meeting, which is up in Frisco in April. Hopefully, I think I can get a quorum by doing it that way. We discussed the medical director's involvement in continuing education, the motion we just passed, and we were unanimously in support of that. There are two position statements that are on our agenda here, both of which the Medical Directors Committee continues to support as submitted. I didn't know if you wanted to do those now or hold those for later. It's totally up to you, of course. You're the boss. Those are items number 7 and items number 9. The committee continues to endorse both of those position statements as submitted to the council.
I'll let you complete your report, and then we'll go ahead and do 7 and 9.
Okay. Going along with item number 7, the EMS transport to freestanding emergency medical care facilities, because of the change in the climate and change in numerous different structures being built providing emergency care, but not those of which are freestanding emergency departments, and because of mental health issues, we will be bringing forward to the next council meeting another position statement on EMS transport to non-traditional emergency medical care facilities. There's probably overlap in there, but the committee felt pretty strongly that the current position statement only applied to one of those type of facilities, and as this gets more complicated, we think we need to try to adjust to that. The committee also unanimously supported the concept of shorter meetings overall, and felt that if some of the reports given to it that are redundant throughout other committees and to the council could be done once, that we could probably get our business done in a shorter amount of time. We finished on time in an hour and a half. We could probably finish in an hour. We thank Maxie Bishop for his service, and on the public comment, Dr. Jay Kovar brought forward the issue of mental health issues in EMS, and he's not here, but I think he essentially made a suggestion that there be a committee set up for that. I think more importantly, his suggestion is appropriate that we start to look at those issues a little more heavily because it's affecting everyone. So we have 2 action items for today, and then for next GETAC meeting, 2 agenda items we would like to request. One is the position statement on EMS transport to non-traditional facilities, and then we will be bringing forward some courses for recommendation to DSHS for approval for Rule 197.
The mental health issues, is that critical incident stress for providers, or medical directors have mental health issues?
Well, that would be both.
Both? Okay.
And
just wanted to clarify that.
And it's actually dealing with the mental health patients.
Oh,
so not mental health for providers, which is clearly an issue. Of course, doctors don't have any mental health issues, right? We need 13, 14, 15 steps, but no. No, this is for the patients that we are caring for.
I think also specifically it relates to if some of the legislation passes, because there's going to be a need for education for
for the EMS providers to be able to hold patients against their will.
Yeah, well, yeah, and it's that there are now some other, again, it goes under the other non-traditional destinations. There are mental health areas, there are the sobering centers, and it may be appropriate, or probably is appropriate, for EMS to transport to some of those centers. That would be a big change. So, I mean, and everybody's dealing with mental health issues in the hospital, outside of the hospital, so I think it's an appropriate thought.
Okay, you mentioned a committee to do the work on this. Would it be more appropriate maybe to have a work group made up of some people from our standing committees, or did you have other intent?
Dr. Kovar actually said consider a committee on it. I think we probably need fewer committees rather than more. I think maybe integrating mental health into all of the committee work might be a good idea. Maybe the council should task each of the committees currently existing to look at mental health issues within our purview and bring it back to the council.
Okay, my recommendation is that we just, as a council, we charge the committees at their next meeting to discuss the mental health issues of the patients and current topics that need to be addressed. Would that be sufficient?
Yeah, no, that would be my recommendation as well.
Okay. Is that something we need a council vote on? No? Yes?
Did I hear you say you wanted to do, how many, 2 or 3?
2 or 3 what?
How many representatives from each?
No. I just think each committee, this is just me talking.
Okay.
I just think each committee should put this as an agenda item. Mental health issues affecting fill in the blank. So EMS committee, medical director committee, air medical committee, and there may be some committee that doesn't have mental health issues to go along with it.
We can provide them.
Yeah, no,
Okay, maybe not.
I may have confused things. I had initially mentioned a work group,
Okay.
But Dr. Greenberg's saying if each individual standing committee will put it on their agenda for next time to discuss, then we can find out where all the issues are and move from there. And I think I can just make that recommendation as a council to the committees for next
Yes.
meeting.
And we do have that on I'm going to put that on the agenda for our next meeting. That concludes my report.
Any questions for Dr. Greenberg? Okay, while we're currently on that topic, we will go to the council agenda, item 7, which is review and possible, Before we do that, do these other committee reports affect items 7 and 9?
Do not think so. I do not think so,
No.
unless they think so.
Well, we'll let them get up and say so. It does. Okay, we'll go to that number 7, which is review and possible approval of the GETAC Medical Directors Committee position paper regarding EMS transport to non-traditional freestanding emergency clinics. And to approve that, we'll need a motion and a second.
I would so move.
Second.
Somebody seconded down here. I didn't.
Second.
Jody. Okay, thank you. All right, and now we're open for discussion.
Do you want me to present it? It is actually available on the website. I don't know if we can pull it up and show it. I would have been saying that I think only the recommendation should go forward. The entire document is actually very good. It's in your packets, but some of the rules will change, and that part of the document will become obsolete quickly. I do not think the recommendation will. And the recommendation, in short, says that the medical director of each EMS service has the responsibility to determine if they should be transporting to freestanding emergency facilities and taking into account everything they should take into account, how it affects the patients, how it affects the hospitals, and how it affects the EMS service.
Is there any council discussion? Does anyone in the audience like to make any comment or ask council any questions? Not hearing any further comment from the audience or from the council, it appears we're ready for a vote. All in favor?
Aye.
Aye.
All opposed? Okay. Motion passes. Next, we'll go to item number 9 on the council agenda. Review and possible approval of GETAC Medical Directors Committee position paper regarding education program medical director's responsibility for clinical care provided by EMS students during the students' clinical rotation. Have a motion and a second.
This was brought to the council last meeting. At that point, it was sent out to EMS Committee and Education Committee. I think we've heard from both of those committees that they approve as well. It was discussed at our Medical Director Committee, again with unanimous support. I think it reflects reality, but it gives power to this committee and to DSHS to make sure that the right thing is done. So I'd recommend approval as written.
Any discussion by council? Would any of our stakeholders like to make any comments or ask questions? Seeing none, we'll call for a vote. All those in favor?
Aye.
All opposed? Motion passes. Pediatrics Committee, Dr. Macias.
Thank you. The Pediatrics Committee met on Wednesday at 10:30. A number of new agenda items. We had an update from our EMSC working group. For those of you that have known Tony Gilchrist for many years, he's taken a position with the National Resource Center in Washington, D.C., and so is going to be spreading his good work with the NRC nationally. So we will be searching for a new coordinator for the state EMSC office. But the work continues nonetheless. We have several levels of evidence-based guidelines and evidence-based protocols. NHTSA is about to release 3 this fall that will be published in Academic Medicine for pediatric seizure management, helicopter EMS, and pediatric pain management, all in the pre-hospital setting. And those will be published in Pediatric Pre-Hospital Care. We have an ongoing project for looking at a respiratory distress pre-hospital protocol that is tracking outcomes in Austin, Dallas, and Houston. So should have a report with actual outcomes within a year or so. A number of published evidence-based summaries, which can be used by different agencies to uptake in protocols as they desire, not intended to be prescriptive, but intended to provide some guidance for pre-hospital protocols, will be published on the state partnership website within a month. One other agenda item that's particularly important for the state partnership is that the EMSC National Office is undertaking the National Pediatric Readiness Project, which is an assessment of emergency department readiness for pediatric emergencies. This was done in the state of California. In their piloting, achieved over 90% cooperation with that. If you haven't had a chance to go on the National Pediatric Readiness website, it's a wonderful website. You fill in the survey and you have real-time output for the institution, for the hospital scores, with an availability and accessibility to a QI toolkit for how to improve those outcomes. We are asking members of our committee to help with the contacts within the state. We have one more month to take our 32% participation up to 80%, which is our target. Second initiative was State Child Fatality Review Team update. Of note, there are 2 particular issues which tie back into the trauma registry. We want to better understand submergent injuries as well as the infant mortality data, so we'll be looking at crossover for that. To that end, we have nominated Jorge Science as our representative for that Trauma Systems Committee Registry work group. We talked about pediatric imaging implementation strategies. We're grateful to this council for endorsing that position paper, and we'll be looking at a vote in our next meeting for strategies for actually implementing those policy changes and providing resources to hospitals for access to online registries to minimize ionizing radiation. Our future agenda items will include an addition of quality metrics that we hope to evolve for both pediatric pre-hospital setting as well as emergency department settings. So that will be a big discussion point in our next meeting. Other than that, we have no council requests at this time.
Any questions for Dr. Macias? While you're there, I would recommend we go ahead and handle council agenda item number 5, if that's okay with you. Okay, which is it's discussion and possible action related to the position paper on radiological studies, dosing in children, and recommendations developed by the pediatric subcommittee.
Oh, I was under the impression that discussion was in the November meeting. Not true?
Did we pass something, or was it just a discussion point?
I think it was referred back, wasn't it?
I think it
trauma.
I believe so.
Yeah, it was, I brought up the issue that I still wonder if this is within our purview, and I don't know if Kathy left or not. She had some concerns, I think, the same way. Is she? That it's a great document. I mean, but where does it go to from here? How does it get utilized appropriately? It really, to me, it is the practice of medicine, the way it's written, and I don't think that qualifies under what we're doing.
So if I might respond to that, I just want to echo that there's a similar position paper by the state of Pennsylvania that has been endorsed by their similar committee. It is not intended to be prescriptive. It is intended to provide opportunities for enhancing the minimization of ionizing radiation and hopefully encouraging interfacility transports to be attentive to those issues as well as ED-based settings.
Yeah, they don't have the Texas Medical Board, though.
Based on the minutes, it says here that Dr. Vizzetti made the motion to request GETAC adopt the position paper. There was an amendment by Dr. Greenberg to recommend that GETAC endorse this position and forward this paper to the appropriate departments for consideration, and the motion passed unanimously. So it appears we've already discussed it, and I guess by departments we meant back to the Department of State Health Services. So
Okay, I'll take that action then.
Yeah, I think we're done with it.
Thank you.
All right, thank you. Stroke Committee, Dr. Rutledge.
Thank you. We met yesterday, and I want to start off with our subcommittee reports. We have a subcommittee on stroke data collection, and we're starting and trying to focus this as a RAC-centric method because of issues with the Department of State Health Services and how we do a registry and all that. Several different plans were discussed. And to that end, we also had a presentation by the American Heart Association. Diane Barrett gave a presentation on a national cardiovascular data registry. We have no action items in that regard and continue to try to find a method to provide data for GETAC and the state. We also have a subcommittee on EMS stroke education. And we hope to have written recommendations prepared by the next meeting to be reviewed by the Education Committee and the Medical Directors Committee, and then hopefully come forward here. Basically, the stroke education is like, sort of how many hours for what level and what sort of things might do, but also very open-ended so that medical directors have room to run and be able to efficiently provide that education. We also have a stroke survey work group. Previously, a survey was sent out to all the RACs. It was a wonderful survey, but a bit burdensome and a couple of years old. And our thought is by doing SurveyMonkey and just doing brief 1 or 2 questions, 2 RACs every quarter, we may be able to provide better information transfer. And our first question is more how we can help the RACs better. In regards to the trauma registry work group representatives, Last time we designated Ron Eichler, and he's still the primary. Unfortunately, we have a whole bunch of people who want to help, and so we also have some people who will be backups or assistants, and that includes Warren Porter, Deb Motz, and Catherine Bissell. So it's nice to have a lot of people that want to help. Report from the Texas Council of Cardiovascular Disease and Stroke, which is me. There's an initiative by the academic neurologists in the state of Texas. This is Dallas, Waco, Austin, San Antonio, and Houston, to do an ask at this legislative session. They basically, in outline, would like to have full-time data collectors at these centers so that they could more quickly respond to national trials and that our state could be a site of national trials. They also have an ask in for telemedicine equipment that they would then distribute through the state so that they could also use that information and make that part of the trials. And so we'll see how that moves forward. We also then had a presentation by Mark Alberts. He's a nationally renowned stroke neurologist that's just moved from Chicago to Dallas. And he gave a presentation on a move for national certification for acute stroke-ready hospitals. What is very interesting to me about that is this basically mirrors what we've been doing for the last 8 years here with our stroke support facilities, and basically the requirements that they're proposing nationally are basically the requirements that we already have in place. So that's very interesting. That's my report. There are no action items. I'm happy to answer any questions.
Any questions for Dr. Rutledge? Thank you for your report.
Thank you.
Trauma Systems, Jory Klein.
Good morning. The Trauma System Committee did meet on Thursday, so you have a PowerPoint of the information that we shared with the committee, but just to give you a quick overview, we pulled the data out of the trauma registry for 2011, so it's called the 2012 report, but it really reflects 2011 data. And you'll see in that there were 117,000 injuries that were treated in the trauma centers in Texas. There were 3,267 deaths. Our mortality rate for all of those injuries is 2.8, which is 1% lower than the national report from the National Trauma Data Bank. So I think there's a lot of things that we should say thank you to all the people in the audience. In addition to that, you can see the breakdown for the level 1s all the way to the level 4s. We looked at the injuries and the mechanisms, the reasons for admissions to the trauma centers. Falls is the number 1 with 46%, motor vehicle crash 22%, and firearm injuries 2%. So there was a discussion, we talked about the rules. The rules are still being reviewed or the recommendations provided by the committee are being reviewed by DISH, and they're formulating that into a format that we can all understand. That's continuing. As far as action items, we did have, before we get to the action items, we did have 4 new members that were present: Lori Boyette, Alex Ramos from El Paso, Carla Hosick, and Janine Rawlings were also the new members that were present for the committee meeting. For action items, there's 2 things that we would like for you to consider. One issue was somewhat controversial, believe it or not. We talked about firearm injuries. Obviously, that's a huge issue at the national level. And so the committee's decision was that firearm injuries that people are talking about are usually caused by individuals with mental health. You've already talked a little bit about that, and the Trauma Systems Committee does not feel like mental health is something that we can address, so we leave that with you to address. In addition to that, we feel like we should focus our efforts on the injuries that are killing Texans. In addition to that, there were 2 other items that we talked about. One was the opportunity to write a letter to the American College of Surgeons. They are rewriting their new book, the Green Book, into a greener book, let's just say. And so in that book, we had made a recommendation from the Society of Trauma Nurses, the American Trauma Society, and several other organizations that they should address the educational requirements and the credentials of the trauma registrars. However, when we were at the meeting in TQIP, they decided that they potentially were not going to support those recommendations. And so we would like to write a letter from the Trauma Systems Committee of Texas and through GETAC to the American College of Surgeons, asking them to follow those recommendations, that we feel like good data is essential for us to make good decisions. Good decisions are made and good data comes from people who have the appropriate level of education. So the committee did yesterday support that and voted to bring that to you at GETAC, and hopefully you will support that. The second issue is that we did have the opportunity to talk about a best practice work group. This is specifically looking at the trauma patient population. The committee did support that, and so we bring that to you with the opportunity to create a best practice work group with Brian Eastridge as the leader in that particular organization. We did have our first trauma registry work group meeting. It was an introductory meeting. Again, that meeting was at 8 o'clock on Thursday morning. And so there were 5 issues that we asked those people that were present to go back and to address. One is to identify the top 5 barriers or needs to make the registry work, or they're having in their agency, and they're from their stakeholders. The second was to define the top 5 data elements or data reports that the committee would like to have to be able to make better decisions. The next one is recommendations and solutions to change those barriers into positive events. And then the last 2 was to identify educational needs, and the last was the resource needs. And so that's the summary of the Trauma Systems Committee. Can I answer any questions?
Go ahead. On the mental health issue, I think y'all can be very helpful because you have access to the data. All the people in your group have access to a lot of trauma data. And I don't know what's in there, but it'd be nice to look and see if what is in there as far as secondary diagnoses, primary diagnoses, suicide, those kind of things.
Actually, most hospital registries, trauma registries, can break it down into suicide, and I think the state registry can break that down. Unfortunately, the comorbidity that you need somebody would have to identify when the patient is admitted that they have a mental illness disorder. That is not part of the National Trauma Data Bank. Okay. It is not part of the current registry. There was some discussion, and maybe we need to include that, but the bottom line is the data that we currently have, we do not have that data.
Okay. All right.
Jory, what's the educational expectations you were proposing for the registrars?
We very much feel like the registrars should have the opportunity to attend the American Trauma Society Trauma Registry course or an equivalent course. For example, the state of Texas has been very aggressive in developing a trauma data management course, which could be considered an equivalent course. The second one is the AAAM injury scoring class. So those of you who are familiar with that class, if you have not taken that class, you're probably doing erroneous or making errors when you're doing your injury severity scoring. Those are the 2 that we really feel like the registrar should have an opportunity to attend within a certain time frame, and then we feel like all registrars should be pushed to the opportunity to complete the certification for a trauma registrar. So I feel like that's minimal. We ask physicians to take ATLS. Every nurse that takes care of a trauma patient has to take TNCC or ATCN, ACLS, ENPC, or PALS. And so again, this is an educational requirement, and to me, we have excellent care at the bedside. But the data quality going into the trauma registry can be good or it can be horrible. So we're using that data to make research decisions across the nation. I personally would like to know that my family member was treated by a research project that had good data, not bad data.
Yeah, I agree with you. Do you think the college is pushing T-QUIP education for them perhaps, and that's what their hidden agenda was?
No, sir, I don't. I mean, I would ask anybody that was there at that TQIP meeting to stand up and comment as well. But I think the issue is, and I hope if there's people watching this video, I don't get fired over this. But the bottom line is...
They're watching.
The bottom line is this. I think that there is a compromise to say that the administrations of the hospital do not want additional mandates that would cost them money to be a trauma center. And my issue is that is so important to have good quality data that I think it should be mandated. I think it needs to be in black and white.
I agree with you. I mean, just for research projects alone is frustrating, and as well as PI projects. I strongly support that.
I would just like to ask any trauma person that's in the audience if they support that to just stand up. Because I think trauma registry education is one of the areas of weakness in most trauma facilities. Any other? One person.
Well, there was a couple of hands back there, so.
Any other questions?
In fact,
I'll take the stand, I'll take the hit.
George, years ago, I took a college course back when computers were small and insignificant, and they called it GIGO, garbage in, garbage out. So unless the data is correct going in, so I support what you're saying. I'm sorry, go ahead, there was a comment.
Oh, I just want to make one comment real quick. Attending several of the committee meetings this week, enjoyed the programs that were presented and a lot of the discussion going on, and yours was no exception. I appreciate the way you ran your meeting. It was very focused, and your presentation was very good. All your data was interesting. So anyway, I appreciate that.
Thank you. I will say that I have sent that PowerPoint presentation to Jane and to Donna and to Brenda and to Eric, and hopefully that, I know it's already posted on the DISH website. It will be posted on the TTAF website, and I hope that it'll be pushed out to all the racks so that they can share it within their racks. Any questions?
Any other questions for Jory? Did I hear you say you have a couple of council action items, or were you talking about your committee?
Our committee had 2 action items, so my question is, do you need to support us in that in the letter to the ACS and then the work group?
Are you under any type of time constraint? Because my first recommendation would be to put that on our agenda in May, but if you need it sooner than that, we can certainly talk about it now.
Well, you know, if I bring up something and I want to do it, I really want to do it. I don't want to wait on you to tell me I can do it.
Well, the college is going to be meeting in April, so that may be too late.
Okay.
If you feel like we have the support to do that and you support it, then
I guess I don't know enough about the issue to support it or not support it. I don't think.
Well, as you know, I'm supportive. I voiced my support at the meeting. And just for the expense issue, I'll just say that the expense of this from a hospital standpoint is trivial compared to the other expenses that we mandate through the trauma system. If you look at physician requirements, nurse requirements, hospital infrastructure requirements, those are very expensive items. This is, in the greater scheme of things, a very small hospital expense. So for all those reasons, the Trauma Systems Committee supported it, and I don't really think council support is needed. I think, and I don't think it will add any more weight to the American College of Surgeons. I think if the Trauma Systems Committee, Trauma System Committee letter will do what you need to get that done. And I guess the question is anyone on the council violently opposed to it? That would kind of be the issue, but I don't think we need formal GETAC committee, GETAC council action.
Just a thought. Your meeting was very well run, and I can't imagine anybody not supporting this. If the data is not correct going in, how can we make any plans? I mean, if you're planning for the state of Texas, what our people need, you've got to have good data.
Aren't these 2 separate issues, though? I completely support the data, but you were talking about something that was sent forward to the ACS and the ACS turned down. Is that the same thing?
Let me just back up just a little bit.
Yeah.
So when we went through the rule revisions for the state of Texas, we required this for the level 3s and the level 4s. And so the state of Texas criteria, we are also, every hospital, 1, 2, 3, and 4 is required to meet that criteria. At the college level, the American College of Surgeons, which obviously every level 1 and level 2 is required, most hospital administrators for level 1s and level 2 go straight by that book. They look for what you have to have. And so the American College of Surgeons was asked to put that same language in there. However, it has been decided to not put it in there, or there's some additional discussion. So my goal was to send a letter to them to say that the state of Texas, with its 280-something trauma centers and trauma surgeons, feel very strongly that that should be in the new book.
I thought the Green Book had 6 hours of CE or some equivalent for registrars.
It does have something in there.
I know it's pretty weak, but
it's very weak. I mean, the bottom line is the ATS, the American Trauma Society registry course, costs about $560. The AAAM injury severity scoring class costs $700. Now, obviously, there's travel to go back and forth. For the individual to complete the trauma registry certification, I think it's about $250. So I think that's easy to mandate when you think about the surgeons, their requirements, the nurses, and their requirements. And again, it goes back to data. You know, you can get data back, and I'm sure you've all done this, where you'll see 99999, and what that means is it's not available, or we don't know what it was, or we didn't find it. Or you get something back and the revised trauma score is 17. I mean, really? So, you know, if you want to make good decisions, you need good data.
Does anybody know why the ACS turned that down? They're not exactly a shy organization.
Well, so they haven't officially turned it down, right?
That's right.
I mean, so the way that process works is they have had people who've gone through those chapters in the book, and there's been small work groups, and the optimum resources document, if I think I'm correct, has not been published yet.
That's correct. It's going to be probably out.
So it'll be discussed at the spring meeting of the COT, and so that's why this is a totally good time to write a letter saying that that the Trauma Systems Committee of Texas has already adopted this, and we believe it should be a national requirement. It doesn't really affect us. If you think about it, we've already made the recommendation. You're essentially recommending New Mexico, Oklahoma, Louisiana, Minnesota, New York have that, and so I think that's a good thing to do. And I don't think I don't think it requires us to endorse it. In fact, I don't think it would add anything. They all know you. They know the trauma systems. They know Texas. So I think that you should do that.
We should do it.
Yeah, we should do it. But if you want we to give a formal endorsement, it's going to come with months and some discussion like what we're having now.
We got that. Anything else?
Did you have another action item you wanted us to consider?
No, I
You
think
had
we're
enough.
good. I think we're good.
I guess the question, does it actually take more discussion? Because in this short period of time, you've convinced me. So could I request we take a vote of the council, and if the council supports it with a vote, we're done? That's a motion.
That's a motion. Is there a second?
Yes.
Is there a second? Any discussion?
Can I make more comment? Sure. So we're probably going to unanimously approve this, but it probably won't change the college. Is there a better way of doing this, just make it at a state level?
I think it would be very powerful if it comes from the Trauma Systems Committee. Another letter comes from Region 6 of the American College of Surgeons. Another letter comes from the Trauma Center, the TTCF, and from TTAF. And we're also trying to push the Society of Trauma Nurses and the American Trauma Society to write the same letters.
Yeah, we should do that, and we'll be meeting. But my concern is we can do that. I think they're almost done with the books, sincerely. Do we still need to circumvent them and just do it from a state level? How can we fix that at a state level? Make sure we do that.
It's already
Okay, so you're just trying to make a nationwide thing?
Yes.
We can definitely do that.
I agree, but I think a lot of people don't really realize, and for the level 1s and the level 2s, our administration thinks I only have to follow the green book. They don't realize that there's this other state criteria. And so it sets the registrars up for conflict. It sets the trauma program manager up for conflict. My goal is to try to make it consistent.
Sure.
Okay, well, we have a motion and a second, and we're discussing. Is there any other council discussion? Are there any stakeholders that would like to provide input? Seeing no one charging the microphone, we'll go ahead and take a vote. All those in favor?
Aye.
All opposed? Motion passes.
Thank you very much.
Thank you, Jory. GETAC Liaison Summary Reports, TTAF, Dinah Welsh.
Almost good afternoon. Dinah Welsh with TTAF. We had our EMS and Trauma Day at the Capitol this Tuesday and had great participation. Our message was really focused on funding. No surprise there. Account 5111 is our focus. We talked about the funding that goes to hospitals, but then also really tried to highlight the funding that goes to the RACs as well as EMS. And Kathy and Jane discussed earlier about the accounts and the additional monies that have been distributed to the hospitals. through the matching funds. But what we tried to highlight is the fact that when the appropriations were reduced last session, that the biggest impact was EMS and the RACs. They're 2% and they're 1% respectively. That pot just got smaller and smaller. So we're trying to make the argument for, first of all, the whole trauma system, that we need additional funding and have the documentation to prove that, but also really focusing on EMS and RACs as well. We've seen, and again, I know there's already been discussion about it, about the stroke system and now a new cardiac or STEMI bill that's going to be filed, and the NICU and maternity ward bill that could possibly, it doesn't say it will right now, but could possibly fall at the foot of the RACs as they exist right now. And again, it's one more unfunded mandate. And this community is great about taking on one more thing and just buckling up and doing. But I think the RACs are definitely at a point that taking on additional is going to require additional funding. So we're really going to fight for that. While Tuesday was successful, our work is not done. We've got 3 months of craziness, and a few people that attended the day at the Capitol and just sort of their time at the Capitol for the first time experienced firsthand. It's sort of like sausage making, and there's a reason why they call it that. There was one comment, it seemed like nobody was really paying attention on the House floor. When they went around to go visit with their legislators, nobody was sitting in their offices. And it's like, well, that's the process. And it may not be pretty, but I guess I've been around it so long that I just accept it as that's what it is. And it's catch as catch can. We will be, TTAF will be sending out alerts. Hopefully you all are receiving information from us. If not, please check your junk folders, because all of you that are on GETAC and most of you probably in this room should be on our list. And it's just a matter of if it's being quarantined. So double check that. But we will be asking for people's help as some of these funding initiatives go forward, as well as the driver responsibility program, bills that would abolish the program. I think they've got some momentum this session, but they still, I think, face a pretty significant brick wall of, if you do away with the driver responsibility program, it is a $400 million plus hit to the state budget over 4 years. And most appropriators, that's just sort of a non-deal. So TTAF would continue with a number of educational opportunities. We've been doing the EMS webinars successfully. We've done 4 of them, and scheduling one for later this month. So check our website. And we appreciate y'all's support and appreciate the opportunity to also webcast once again. Any questions?
Any questions for Dinah? And on behalf of the council, thank you again very much for broadcasting the committee meetings and the council meetings. It really gives stakeholders an opportunity to see what's going on, especially if they can't afford to get here. It's much appreciated.
Well, thank you. Thank you.
All right, next item, as we know, would be number 1, but that's been moved to the end. Item 3 is a status update of revisions to the EMS and trauma systems rules.
We continue to work on the revisions. She might imagine it's a rather large project. Since Mr. Bishop has decided to go work for Chief Kidd, that's kind of going to slow us down a little bit. I did have a meeting with Jory. She was gracious enough to allow me to come up and meet with her last Friday, and we spent the entire day going over 125 for the trauma designation, which has probably the most significant revisions to our rule is going to be in that section. We didn't get through it, but we got a long way. I really cannot predict when we will have a good draft back to you guys. But as I told one of the committees, that once we have a good draft, we'll have our joint meeting, and then it will come back to you. So as long as you hear no news, assume that we are working on it, because that's what we're doing. And I guess just as a ballpark, possibly this summer we will have a good draft.
Any questions for Director Guerrero? Seeing none, we'll move to item 6, which is a review and discussion of draft SOPs to address resource materials posted on the DSHS GETAC webpage.
The policy that you see on the screen and what you have in front of you is something that was developed based on really the number of requests that we got for posting resource documents. Part of the things that we were running to, problems we were running into at the department level was we didn't know if these resource documents were copyrighted. And so we started getting into issues. If it was copyrighted, we can't post the document on our website. I also don't have the resources to research whether that document is in the public domain or if it is still copyrighted. So what we came up with was if a GETAC committee or this council creates the document and it's approved by this council, then we can post that document on our website. For other requests for resource documents coming from the committees or the council, it'll need to come in the form of a link, and we can post the link on our website so that with an explanation of what it's coming from. If it's a resource document for the cardiac committee has actually established a website or a web page at their rack that they will post all their documents to. We will put a single link on their web page under GETAC for resource documents related to cardiac committee. Go here, and it will take them directly to that web page. So that's kind of how we've had to address it as to what we can and can't continue to post. Now, for documents that are going to be used as a resource documents for your committees, even if they're copyrighted, we'll post them as a resource for 2 weeks. So once that committee has met, those documents come down. That's basically what this policy says. Do you have any questions for me about how this operates?
Go ahead. No, you first.
Okay, you first. Thank you, Jane, because we've had a lot of documents floating around that we wanted public comment on and wanted a central location for people to go and find and look. I think you answered my question. Under 1A, any document pertaining to a specific committee or council agenda item will be discussed at the upcoming meeting, will be temporarily posted. Is that the 2-week?
That's the 2-week.
Okay. I know sometimes we ask that we put something out there 30 days for public comment. Should we start telling them it'll be 2 weeks instead of 30 days?
Yes, sir.
Okay.
Unless you can provide us a link, then we
Okay.
can put the link to that document as the resource document, and then they can go to that document and we can keep that there as long as you want.
Okay. Thank you.
And then just because I always look at creative ways to do things. You put a 1 megabyte limit. Are there then an unlimited number of 1 megabyte documents you can put on? Or should it be a total number of megabytes for the documents? I deal with doctors and paramedics.
I know you've shut
know
my
how this
email.
works.
You've shut my email system down several times, Dr.
Yes, I
Greenberg.
did.
Just want
But
you
no,
to know.
is it the 1 megabyte per document issue, or is it total space?
I'm gonna let Kelly address that piece.
Okay, good.
We don't really know. I mean, we've got limited space on the DSHS servers. If you send us 100 megs, probably not, but 4 or 5, probably. So it really depends. When they come after us, that's when we'll know we've done too much.
Are we limited on the amount, the size of the file that comes in? Is it 3, or is that just us sending out? Okay. We'll have to do a little investigating on that because we're not real sure. It used to be that, we couldn't receive anything over a certain size and we couldn't send out anything over a certain size. I'm not sure that's still the... Yeah, we've moved to the cloud. For email, we've moved to the cloud, and sometimes that's good, and sometimes that's not so good. But we'll have to investigate that a little bit more, Dr. Greenberg, and find out. But you've not shut me down since then.
Okay.
Okay.
So I would say that 1 megabyte limit seems rather draconian in today's, I mean, in the sense that for example, the ACS system consultation exit PowerPoint is 2.2 megabytes. I just looked it up. I mean, I don't,
what?
It's probably, I mean, I have a Google account that I pay $60 a year for 100 gigabytes or something like that. It's like, seems, why so restrictive? I know it's not your rule, but...
no, we actually wrote this before we migrated to the cloud. So I do think that has changed. I'm not kidding. It wouldn't come through. We could post it on the website, but we just couldn't get it sent to us via email. So there may be no restriction on the size. So if you would let me look at that and revisit that piece, we may not have a restriction on the size.
Jane, you could always put some verbiage in there that basically says the document must not be any larger than we can receive by email. Then as it moves.
The issue is that email's in the cloud, but our internet, our servers are not in the cloud. So so we really have to explore this. We may be able to get something by email that we can't, have all of these very large documents posted on our servers. Okay.
Or a whole bunch of little ones. That's the other way to get there. So
we're already known as a server hog, so you know.
Okay, this isn't anything that council takes action on. This is just the way it is, and you're going to get back to us with more details.
Correct.
Okay. Any other questions? Okay, we're going to go ahead and move to general public comment. So what I'd like to ask is, item 1 is still on the agenda. We're going to come back to that, and we will allow public comment on item 1 when we come back. But if anybody has any other public comment they'd like to make, other than, even if you want to make comment on item 1, just come on forward.
Vance, can I say something really?
Oh, sure.
I'm sorry, really quickly. And I'm very embarrassed that I forgot to mention this when I did my committee report. But Eagle Med, based in Wichita, Kansas, had a fatal crash in Oklahoma City week before last. There were the pilot and the nurse were killed. The paramedic is in critical condition. They're having the funerals for the pilot and paramedic today, and then there will be a memorial service in Oklahoma City tomorrow. So if anybody is interested in attending, let me know, because I have the details on the memorial service. But certainly won't want to keep those folks in our thoughts and prayers. The other thing I want to say real quickly is I have a few copies of this House Bill 1656. Sorry, if anybody wants a copy of it, I have several extras.
Thank you, Shirley. Public comment.
1656. It's the
Howdy. GK couldn't be here because of what's going on downtown, so she asked me to give some information on the Texas Ambulance Association and some of the things that are going on legislatively from an EMS perspective. Commissioner Perkins mentioned Senate Bill 53 and the change to the ALS definition, and this was a piece of legislation the Texas Ambulance Association has been working on because of some issues with the way Medicaid pays ambulance providers. And they got into a spot where they thought because the Texas ALS definition was different than what you see in the Medicare manual that they would have to restrict paying ALS charges to only those patients who had had an invasive act done. Since 2004, Medicare has paid, if an emergency call comes in, based upon how that emergency call is received, it appears that you need paramedics. And when you get there, the paramedic assesses the patient and determines that they didn't need paramedics. But because everything else led them to send a paramedic to the scene, that assessment would qualify that call as an ALS call and get it reimbursed at a higher rate. In Texas, this is critical because we're so much lower than Medicare. Any dollar we can get out of Medicaid is critical for us. So what was going to happen was they were going to start paying according to the Texas definition, so the ALS assessment would not work. Where that becomes a problem for agencies is we take somebody that's eligible for Medicare and Medicaid, take them to the hospital, we bill it at an ALS rate to Medicare based upon the ALS assessment. They determine it was medically necessary, the ALS assessment makes it an ALS call, they pay that, they send the copay portion of that to Medicaid. Medicaid would automatically pay that because CMS has already cleared the medical necessity hurdle. They would then send, let's say, Schertz EMS the check for the copay. If I didn't turn around and send that back because we only got paid that at ALS because of an ALS assessment in Texas at some point in the future would no longer allow that, then I'm now committing Medicaid fraud in the state of Texas. So we're pushing this out there to try to clean this up and prevent 911 agencies from stumbling into illegitimate fraud. Made a lot of people nervous, including the department and HHSC and a whole bunch of other people when it first was filed. Because it had things in there like if you're a paramedic and on Tuesday your patch is on the left sleeve and you stand on 1 foot while you're doing your ALS assessment, it will work. It was just horribly written language. And affected a lot of things DSHS does regulatory-wise. So with their help, we went back, and the bill that's moving forward is the current ALS definition, which says, means emergency pre-hospital care that uses invasive medical acts with the following attached to it, which includes an ALS patient assessment. That's the only change. BLS is not changing. ALS is not changing. It's just going forward with that added to the current definition of ALS. So we don't mess up the regulatory side of what that definition does, but we do get that in there in the definition of ALS, so hopefully HHSC can continue to pay us according to the same mechanism as Medicare pays. Dr. Greenberg, did you?
So that's a revision to what was filed?
Yeah, what was filed was horrible language.
Okay, yeah, it was invasive, non-invasive.
For both sides, and right. EMT paramedics and EMT intermediates, which then took away the delegated practice piece that the medical director. Yeah, it was horrible. Okay. So at meeting with DSHS, we hammered out the current language and just added that to the end. So that is the bill that went through the Senate earlier this week, and hopefully will be coming in the House here in the next couple of weeks.
Okay. And what are the numbers on those?
It's Senate Bill 53. I don't have the House bill number yet.
Yeah, it's gotten a lot of attention.
Yeah. And so, I mean, some of you probably saw, I did some email blasts trying to explain what that bill was about, because it really is critical for the agencies that are trying to do things right, because it'd be very difficult to track which calls were paid ALS based upon an ALS assessment versus an IV and all that kind of stuff when those dollars automatically get paid. A lot of us do that electronically, so they just drop in the bank account. I mean, it could definitely hurt a number of agencies across the state. A couple other things that we're working on, or at least paying attention to, that haven't been mentioned. There's a bill out there by Representative Larson out of San Antonio, which is House Bill 395. Will allow hospitals and healthcare providers to scan a driver's license to obtain the data off of that for demographics. Healthcare providers, they listed out, it said which includes, but EMS was not included in that. We've gone and met with them and Dual in the Senate, and they've included EMT and paramedic on both of those bills going forward. So now EMS and hospitals will be included in that. So that's a great thing for our data accuracy.
What's the number on it?
395 in the House, and I don't have the Senate bill. Oh, yeah, I do. Senate Bill 166. They're identical bills. two other bills that the Texas Ambulance Association is working hard on, and these are dealing with reimbursement again. I think everything we're doing this session is reimbursement. House Bill 521 and House Bill 522, both by Representative Kemple out of Seguin. House Bill 521 would require that if the EMS agency got the patient to sign over assignment, if they were involved in a car accident and were transported by ambulance and they got the patient to sign over assignment, that the auto insurance companies had to send that payment to the ambulance company and not to the patient. Because once it goes to the patient, we don't get it. And then House Bill 522 is attempting to do the same thing with health insurance and trying to firm up some of the language that's in the code for health insurance to make sure, again, that patients who are transported, the payment for that, if they have insurance, goes to the person who provided the transport. There's another one that we're watching that came out the other day as well. It's House Bill 1531, and this is from an EMS operations standpoint, and this has nothing to do with any of the other political stuff that's going on in our country right now. There's a Representative Ken King on House Bill 1531 filed a piece of legislation that would allow anybody who operates in emergency services in a county of 50,000 or less, and some people go, well, 50,000, that's not too many counties. It's 74% of the counties in Texas are 50,000 or less. Would allow those folks, if they have their CHL, to carry their handgun on duty. Would allow, and gives them the same exemption, basically takes away all the exemptions of the CHL law. So they could go to schools, churches, hospitals, they could carry it wherever they wanted to, but basically like a peace officer. It does not involve any coordination or integration with their employer, and it doesn't involve anything about additional training for carrying a weapon into some of the environments that public safety personnel have to go into. Law enforcement officers are required to have additional training. This doesn't outline any of that. So we're working with Representative King to see if we can get some of that. A lot of the ambulance providers are extremely nervous about that because if something were to go wrong, and granted, likelihood it wouldn't, but if something were to go wrong, the person they're working for is going to be holding that liability bag. Not the person who, well, they're going to have some liability on their own, but the person they're working for is also going to own some of that, and there's no mention in the bill anywhere of any type of liability protection, although the representative says they're trying to reach out and get some, and they're trying to see if they can tuck it in underneath the eminent domain stuff of TML. That does protect municipal and county departments. It does not protect private agencies that contract with municipalities or counties to provide 911 services, which would, I believe, include the folks that contract with ESDs to provide those services as well. So be interesting to see where that goes, but it is kind of concerning from an operations standpoint. And then the last thing, or second to last thing, is the Texas Ambulance Association has been working since January 1st of last year to address an issue with crossovers. I mentioned this earlier with folks who are eligible for Medicare and Medicaid. In the last legislative session, they implemented what is called Medicare equalization, and all that essentially means is that if Medicare pays first and they pay what what Medicaid would have paid or more, then Medicaid can consider the bill paid in full and not pay the crossover or the Medicaid copay. In Texas, we're at least 21% behind Medicare, so Medicare their 80% will always exceed what Medicaid would have paid. So what that did for the ambulance industry was completely wipe out copays on the dual eligible patients. For some providers in the state, we estimate 50% of their Medicaid dollars went away. We've been working with HHSC. We got them to reinstate that on emergency and hospital-to-hospital calls in September of last year. The ambulance industry in 1999 passed a law that requires that copay be paid. HHSC felt they were in compliance with that. We went to Senator Corona, who originally passed that law in 1999. He sought the opinion of the Attorney General. The Attorney General came out in the end of January and said that nobody repealed the 1999 law. Law always trumps rule, and it trumps appropriation requests, and so the HHSC rule was in conflict with the law, and they didn't say they needed to correct it, but he just said it's in conflict with the law. We've since been working with Senator Corona and a few other legislators, as well as the Health and Human Services Committee or Commission, to figure out how we're going to get that corrected. Texas Ambulance Association has taken an opinion that we want two things. We want crossovers turned back on as soon as possible. If they decide to do it today, it's a 52-day process to get it through the rulemaking process. So we want them turned on as soon as possible. And then we would like them to go back to January 1st, 2012 and repay what it was they didn't pay since then. For a lot of our agencies, this is significant dollars. San Antonio Fire Department, $500,000. Dallas Fire Department, probably $500,000. For my little agency, it's easily $50,000. So it's real dollars that we're talking about. We are real close to making some progress on this, and we have had some reports of maybe some conflicting messages be sent. So the Texas Ambulance Association is requesting, and for you folks, anybody else in the audience and anybody else watching on the internet, is that if you are part of a group or you know of a group that is an association, represents stakeholders in the EMS world, and they're doing work at the Capitol, if there's any way possible, you could join us on a conference call next Tuesday. And what we're going to try to do is lay out what we feel the industry needs. We're going to reach consensus with the group that dials in. We're going to have everybody sign off on that, and we're going to take that letter to Senator Corona so he can use it to show that the industry has one message on the crossover battle, and that's to turn them on and pay us back. Or whatever it turns out that message is, because we're really going to open up on this. But what we don't want to do is allow somebody's statement that there may be conflicting messages being sent to derail this process, and we end up in the same financial shape that we are now. So if you know those people, please email me their name and contact information. My stuff's available on the EMS committee webpage, or the EMS committee list on the DSHS stuff, or you can go to the City of Shirts and get a hold of me that way. But we're trying to get this done Tuesday. It's going to resemble kind of the trauma coalition moving forward, but we need to get it done very, very quickly because we're up against a pretty steep timeline to get that letter out and to show people that as an industry, even though we're scattered hither and yon and we're made up, if you could think of a way to provide EMS, we got that here in Texas. We're very, very diverse. We think we can get a consensus statement that says this is what we want on this issue and get everybody to sign off on it. So. Any questions? One last thing, sorry, I forgot to look over at Ryan. Texas Ambulance Association also has our annual conference coming up in April in South Padre. It's a tough assignment, but somebody's got to do it. It's April 11th and 12th. This year we're focusing heavily on fraud and fraud prevention, and we're going to have a bunch of folks coming in. You would normally see them wearing navy blue jackets and carrying large weapons kicking in the doors of ambulance companies. But they're coming to talk to us about fraud, and not so much about the people. They're probably going to talk a little bit about what's going on in the larger areas where we know there's a problem. What we're really asking them to concentrate on is if an agency or an organization finds itself, hey, are we sure we're doing this right? How do they fix that and get back in the good graces without making it worse? So it should be an interesting 2 days. We'll have our normal billing stuff and Medicare, Medicaid stuff, but the fraud stuff with the law enforcement officials, I think, will be very educational.
Any questions? Right. Thank you. Any other public comment? Going once, going twice. Okay, here's what we're going to do. It is.
Mr. Chair, can I just make one quick announcement also?
Sure.
Council members, in your packet, there's a document that says EMT program, proposed refresher and transition course. This was submitted by one of our stakeholder constituents for us to take a look at. We'll be taking a look at it in our next meeting. No action today, just wanted to explain why it was in your packet, and if you would just take a look at it, and we'll be ready to talk about it in May.
Thank you. Any other comment from council? Okay, what we're going to do is it is 12:23. We are going to recess. So council members and anyone else that wants to go get a plate and come back in here can do so. We will have a meeting with the executive committee to discuss item number 1. We're still in a official public meeting. GETAC council meeting is still going on. We're just going to recess for 17 minutes. So if everyone could be back in here at 12:40 sharp, please. Thank you.
17 minutes.
Okay, well, let's get after it. Don't talk about it. That's right. But the open records people come arrest us. meeting from recess. There may be a couple other people getting food. I feel like I'm back in my old Baptist church. Y'all in the back are welcome to come sit up front here. We did not mean to exclude you by bending these tables. It's just easier to talk to everybody, but please feel free to come on down. We will allow public comment, so.
There's always room, always room.
Plenty of room. Right, so let me just kind of set the stage for the discussion, although I think pretty much everybody knows where we're at. As part of our strategic planning, council had a concept or an idea of having 2 days with meetings, and y'all are welcome to correct me, and those 2 days would actually start with a council meeting where we would hear all of the reports all at once, and they wouldn't be given again, and we would sort of coordinate what was going to happen for the GETAC committee meetings, and then have a closing meeting with council to kind of review and take action as needed. And so part of that is we had, I can't remember the exact date, but it's very recently, had an executive committee meeting at the suggestion of stakeholders. And in that meeting, I think what we heard was it's possible that we could do this. We just need to kind of hash the schedule out. So any of you committee chairs are welcome to speak up also if I'm off a little bit. So for today, what we actually really need to do is decide if we can knock this out and have 2-day council meeting, 2-day GETAC meetings. I don't want a 2-day council meeting, a 2-day GETAC meeting. And because we need to let Kelly know, because she's going out for bids for meeting dates in 2014. Is that right? 2014. So if we're going to do 2 days, we need to tell her that we're going to do it in 2 days, and we need to know what those days are. Is that correct? So you can. Okay. Okay. So we need to tell, if we do 2 days, we need to tell you, make it Wednesday, Thursday, or Thursday, Friday, or something like that. Okay. So I'll just basically outlining that information. I think I heard during the phone conference with the executive committee that this is something that's doable. We just got to kind of work out the details. So we don't necessarily today have to get down the exact schedule of when certain committees are meeting or even for how long, but we do need to make a decision if we're going to do the 2 days and the 2 days of the week they would fall on. And with that, I'll just open it up to anyone who would like to speak.
I think it should be 2 days, because sitting in all those committee meetings, which I get to enjoy each and every one of y'all, the same, by the end of Thursday, I can give you the registrar's report. I really can. I mean, I can tell you that, we've got to do something about mental health. I mean, it's redundant. So I do believe we should put all of those front-loaded, have our GETAC, call it to order, have all of the state people come in, all the people, and plus that lets a lot of people go on to their lives, which I think is helpful because they have to sit there as well. And in a lot of the committees, I've heard that Wednesday, Thursday is what I heard over and over and over for the 2 days of meeting, because nurses, and I don't know all the acronyms, somebody meets on Tuesday, TTAF, and nurses on Tuesday, and then have Wednesday and Thursday. Plus that would free up Friday for everybody to go about their ways because of flying schedules. That seems to be a problem I've heard over and over. I thought that was great. Everybody in your group seemed to be very flexible time-wise. None of them wanted to stay to 9:30. I didn't understand that, but that's what I heard over and over the last 2 days.
I heard the same thing, right. And I think just the Wednesday, Thursday sounds like, it just works best for people who are attending the meeting. I guess I have a question for Kelly. Is there a certain time during the week where the rates are cheaper for meetings such as this, or
So, and I'm not sure how we can have a conversation about 2 days or 3 days or 5 days if we don't have a construct of who needs to meet for 90 versus 30. Because if everybody needs to meet for 30 minutes, we're done. Let's do it one day. So I'm not exactly sure how, without a construct of, if we have everybody wants 90 or everybody wants 30, that could drive 3 to 1 right there. I'm certainly anxious to come up with a constructive solution. So I'm not one to do things the old way just because we've done it that way for years. I think that's actually a bad plan. But at the same time, I think we need to pick how many people had 90s, and then are there some that need to be overlapping or not? Can some be done at the same time? Then that will give us 2 days, 3 days, 2.5 days. And then finally, we can do phase 3, which is which days a week. And frankly, the financial component's a factor, but they gave us this whole place for $1,500 because we brought the rooms. The money is not the problem. I wouldn't drive it off of what day we're going to do based on if they can save $250. If it works great for you stakeholders, do Wednesday, Thursday, in a 2-day schedule, that's what I would tell them, and kind of move from there. But I think we need to pick the days after we have these other constructs. We need 90 minutes. Our group is pretty vocal about that.
And how much time do you need for, how much time can you start at 8 and go to 9? 8 a.m. to 9 p.m., 8 to 7 p.m., what are those? Because that also, so it's the amount of hours and the amount of time that, in the day that people would be willing to do.
So I have, from what I remember from the reports, EMS was 90 minutes, disaster was 90 minutes, George's from trauma was 90 minutes. Education is 90 minutes.
And I'll ask though, what if some of the reports you get, now you don't get in your committee anymore? They're done at GETAC to begin with. Do you still need 90 minutes?
I mean, I haven't had anybody give me anything. I haven't had rescue reports.
Have some.
Maybe it's because I'm disaster. I didn't want to comment because I thought maybe it was disaster. I think they've done it in all the other committees as well.
We haven't had any outside reports unless we requested it for decision making.
Okay.
I started my meeting and ran it the entire time, and they just didn't talk once. I mean, nothing I didn't want on the agenda. I mean, I always want that information.
Want to help you out of that hole?
Yeah.
And I think how information is passed now differently. We used to have to do this, but we've got other people watching us around the state, around the country, around the world, if you like. So I think maybe we've still got some of this, but a lot of that information we can do electronically to save meeting time.
Well, our group, every one of them wanted an hour and a half. So, I personally like the hour, but I want to be respectful of what everybody, literally everyone on our committee, felt like that we needed, so.
And if we get down to that point, education can do an hour. Because I know Dudley and I both figured out, we get our work done at the work groups. And we're coming here for public comment and see whatever everyone thinks and then report. So if we get down to needing an hour, I'd rather not. I'd rather have an hour and a half, but.
That was one of the things, though, that came out, is the EMS committee does extra meetings when we're doing something focused. Like we're looking at all these ideas to help combat fraud. So we're doing that in between, so we have 4, 5, 6 hours to sit around the table and brainstorm. We did that with 157 when that was open, and we would put together rule suggestions for that. We did that as special meetings, but a lot of my folks, and one of the things I saw in the survey was that a lot of committees expressed concern that if they went to 60, if they felt like they needed 90, like let's say trauma or disaster, if they were pushed back to 60, that would then result in additional meetings in between, which is additional travel. So being here an extra day is cheaper than having to go somewhere for a meeting that if we could have got it done. You see what I'm saying? So do we incur the extra cost of having to have additional in-between meetings? Your guys do it, and you have a habit of doing that. We do it when there's extra things, but a lot of groups don't meet in between, and they try to get all their stuff numbered out in 90. So
one of the challenges of these stakeholder meetings, I'm terrible about it myself, it's not like a staff. It's not like MedExec. It's not something where you can just go, we're going to talk about this for 10 minutes and move on. Pop, 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 pop. There are some meetings that flow a little bit more effectively because there's a hierarchy and a control mechanism, frankly, that says, I'm only gonna talk about this for 10 minutes, I don't care, I care deeply, but I don't care to talk about this longer than that, and I'm running a meeting. That's not what we have here, where we're basically trying to build consensus and make sure people leave feeling like they've had the opportunity to say their piece, even if they don't get their way. We've clearly shown through legislation, through rule changes, that when people get a chance to say, I got to walk up and say what I want to say. They didn't do exactly what I wanted, but they considered it, I'm okay. Or I'm not as mad as I was, and I'm not going to go home and fight it, if nothing else, right? So I think that's got to be factored in some of the larger, I think, more mature. That's the thing I've noticed as well. The more mature meetings, the ones that have been going longer, actually have more items, and there's more resistance to a smaller. If stroke or cardiac, which are some of the newest we have, they don't have a lot to do. They go, we can do this pretty easily in like 10 minutes sometimes. And so I think that's the challenge is that we've got. If they have more to do, I know the one way to not have a meeting is to have a really small meeting the month before. Then you go, well, we didn't do anything last month. We can kill this in about 2 more meetings, right? We don't meet at all. You don't have anything to talk about with me. Right?
Well, the other thing and I'll go ahead and go there, that council has talked about is, do we actually need 10 standing committees? And if there were some revisions to that concept, then we could have a bunch of 90-minute meetings and knock out a bunch of work that way. So we could have, this could be easily become a 4 or 5 hour discussion, I think, but which is not necessarily a bad thing, but I think we, anyway, I don't know where to go from here other than to say, should we look at, let's look at what a 2-day schedule would look like and just throw it out there and see if it can be done?
I think Ronnie, can I get real quick from the other committees, how long they set? I mean, everybody full.
Typically, we can be done in an hour. But-
It's not cloudy.
They didn't.
Dr. Macias isn't here, but
They say they were cloudy.
They get an hour.
Well,
that's. Sorry.
What about cardiac and stroke?
I know from my experience with stroke, they've been able to finish within an hour.
Which is amazing to me, by the way, just.
Kelly, I did have a quick, I'm sorry. When you do the schedule, is it for a year or for 2 years? Okay, so whatever we come up with, we're only stuck with it for a year, basically, and then we can go back to some other, so it's not like we're pouring it all in concrete forever, right?
Correct, and it's really only 3 meetings, because the November meeting is just.
That's correct.
Really totally flexible.
Okay,
So it'll just be February 9th.
so whatever we decide by the 3rd meeting, we can say this was a really bad idea and let's try something different, and we really haven't sank the ship.
And can I say something about the pattern? We don't have to worry about the pattern. I mean, we don't have to live by what the hotel tells us about. They say Sunday, Monday is the cheapest. It'll start with me saying, we need a Wednesday, Thursday, or whatever day we want. And you bid on that.
Okay.
We can do 30 minutes to
Do you have to give them a time frame within that Wednesday, Thursday schedule? Do you, like from 7 a.m. until 7 p.m.?
I usually get the meeting starts from 8 to 8. So if it's 8 a.m. to 8 p.m. So if it's gonna be more than that, like it starts at 7:59, that's probably fine.
So basically,
So
basically a 12-hour block.
90 minutes. I'm pretty sure that's 15 hours. What he says is important, so that was another factor I didn't mention. The length of the day directly affects.
Well, if everyone needed 90 minutes, so 90 times 10, that's 900 divided by 60 is 15. So that's 15 hours in 2 days. I mean, add an hour and a half for lunch.
11 committees, hour and a half for lunch.
So that's
2 hours for
9
GTAC.
hours. Doesn't account GTAC. So what about rec chair? Is rec chairs?
Rec chairs gets tacked on the end of it because it's not a committee.
Right. It's not part of GTAC.
It's a contractor meeting that they
I
invite.
think it's important too for the council to understand is that you hear about all these other meetings, if this slides a day earlier, a day later in the week, those other meetings are gonna adjust. Where we get a little, and those are the things that we adjusted where they are because it helps conserve travel dollars. So people have to fly to Austin, they fly to Austin, spend a week here,
as opposed to flying off this week and 2 weeks later fly back for GETAC and then 2 weeks later for AVP.
So it's bizarre, but it actually is, it's counterintuitive, but it's cheaper, way cheaper for those people.
Hey, you know, another thing that we might consider for if you're going to look at 2 days, instead of it being 2 8 a.m. to 8 p.m. days, if you started at noon on, say, Wednesday, and maybe that's not the right day, but start at noon on Wednesday, go till 7 o'clock that evening, have a full day on Thursday, and then a half day on Friday. That would allow for travel on Wednesday morning for a lot of folks to start afternoon, and then travel on Friday afternoon then to get home. If we do 2 full days, 8 a.m. to 8 p.m. or 8 to 6 or whatever it is, then there's still going to be some difficulty for folks trying to travel home on that evening. Most people are going to have to travel in the night before you start, if you start at 8 a.m. So it's just another consideration.
So the start time, I agree with her, it's very important. We've done a lot of big GTAC. My disaster committee's done a ton of these meetings in Austin. And you almost have to decide to start at between 9:30 and 10, or they're going to have to come in the night before. For only so for even Houston, which is relatively close, an 8 o'clock meeting is painful. The Metroplex is out, so it leaves anybody from basically Waco to San Antonio are the lucky ones who can be at an 8 a.m. meeting and get up in the morning and be there. Everyone else must travel the night before, so they push for 10 o'clock early. That kills all of the Metroplex, which is early but not that bad, and then Houston and San Antonio, Waco, Region 7 folks. People are going to have to fly in there, then you actually get to the point where, and we actually know the plane trips from Amarillo, Lubbock, and El Paso can arrive between, there are some 9:15 flights that arrive. They're painful for them as well, but it's just like getting up in Dallas. So I agree with Shirley. If you pick 8 o'clock and try to do the 16 hours and power through starting at 08, that means people are going to travel the night before, so you might as well push that to noon. And the other thing is, so you're going to end up with 3 days, people are going to get killed on 3 days.
Well, it's
But now it's 4.
Today it is, I agree.
Yeah. So we cut a day off.
I mean,
So you're saying
We
that,
cut a half day on one end, half day on the other end.
is 2 days.
right,
so you're saying that 10 a.m. is a reasonable start date?
that's the earliest we've been able to get without a lot of pain.
So-
What time do you start your special meetings? 10? 9. We start ours at 10, because it allows people to fly.
I mean, the first day you could go 10 a.m. to 8 p.m. and you're still getting your 8 hours in. But I guess then on Friday, you're trying to squeeze the,
Her point about noon to 8 or whatever, and then power through a big day in the middle, because that's right here, and then hit a small day on the end and depart is 1 full day less than it is right now. You have made a step in the right direction. Everybody can get to Austin by noon. There's not a human in the state of Texas that cannot, no, I mean, seriously, I feel like I'm an expert at trying to get everybody else to my meeting. So, that's a really smart idea. It allows a lot of people to travel reasonably.
The morning before we start.
A perspective of that, I left Abilene this morning at 4:15 to get to a 9 o'clock meeting.
Yeah.
You know, checkout time is
And had 20 minutes.
noon anyway, and how many times are we sitting in these meetings when you almost need to go check out? So if we could check out and be gone.
Right.
what's the option of, and I know we're not going to do necessarily Wednesday, Thursday, but we do all day, we do Wednesday from 10 to 8 at night, and then a full day Thursday. Some people fly out Thursday night, some people fly out first thing Friday morning.
But be done with business by Thursday afternoon.
I'd say start that at 8 in the morning and
Okay. And then
grind
you're
done
done
at 4 or 5 Thursday.
Probably be done
And
by
then some
3.
people can catch some last-minute flights out Thursday night.
If we do hour and a half meetings, 8 to 9:30, 10 to 11:30, then lunch, then 1 to 2:30, 3 to 4:30, and 5 to 6:30, that's 5 hour-and-a-half slots, including lunch for one day.
How much time?
Why do we break for lunch?
Chief Raleigh, do you feel that GTAC needs at the front? Because you guys discussed it a lot longer than we have, so how much do you guys feel you need on the front and you need at the end? If we take the front off,
today's meeting?
I don't think the front office is that, just candidly, what we talked about on the call, I think the front part of it is gonna be much more of an organizational meeting. I don't know that anything we did this morning would be reflected. I actually think that's an hour added, but it's an inefficient hour added. It will have benefits longer term. But what we talked about on the call sound like get their stuff out of the way and then work together to figure out where there's cross-pollination and then move on.
I think an hour.
I agree.
Up at the front.
On the front? I agree. I agree.
Yeah.
That's one that we actually can control.
Yes, I agree with that.
Does the council feel that that would then, at the end, be 2 hours or still have a 3-hour time?
I think at the end, one of the things that takes up a lot of time is the individual committee reports. And if we could change that to just come up and tell us only the things you need to put on next agenda, or the things we need to vote on, and not report what went on in committee, we could probably do the back end, hour and a half max, I would think.
One thing good about that, what we're saying about that, if we preload the first hour, we're here.
Right.
There's no reason for us not to attend the committee meetings.
Exactly.
We get our information straight from that committee meeting rather than relying on a report.
Yeah, I think your Freudian slip up front was really the truth, that if we do a meeting up front for an hour and 2 hours at the end, then it does become a 2-day council meeting, and I don't think that's bad. I mean, I will come and stay for the whole thing, whereas now, I came Wednesday, I went home, didn't come back Thursday, I came back today. I will come and stay for the whole thing, and I'll attend the committee meetings, because if we can streamline that process, it really will be council the whole time. And then at the end, at the 2 hours, we're taking action.
Right, and I think the reason we had this on our strategic plan was we identified that council members aren't as informed about what goes on in the committees as we should be, and it's helps us make better voting decisions. Not that we don't trust the report in front of us, but it helps us answer stakeholder questions if we're more actively involved in the committees and attending something. And so,
If we add those 3 hours onto the 17 hours we had before, because I had 2 1-hour lunch breaks. I like to eat. So you do 90 minutes for everybody, and maybe we shave that back by saying we have 2 60-minute times. One of the things I brought up on the executive committee call was, we have 2 or 3 60-minute time blanks, because we have committees that's, almost always going to do it in 60. There may be times the EMS committee could knock it out in 60. And so, hey, I'll take one of the, and injury or medical director says they need an hour or 90 minutes. We just swap those time slots. We get ours knocked out, But anyway, if you take everybody at 90, plus 2 hours for lunch, that's 17 hours. You add on 3 hours for GTAC, we're at 20 hours. If we go 10 to 8 on Wednesday, that's 10 hours. And if we go 8 to 5 on Thursday, that's 9 hours. So it'd have to be 8 to 6 on Thursday, which is going to put everybody but like Dr. Stewart, myself, Eric, here till Friday morning. Not saying it's a bad thing. I mean, there may actually be stakeholders that pull things up on, move to Friday at that point.
but again, what you just mentioned was all 90-minute meetings, though, correct? Okay.
That had 2 60s in it, didn't it?
No, that's all night.
I think you should ask the chair how much time they do, because I've got some meetings that were over at 9:46 and had X amount of time, because you know exactly how much yours are. Injury prevention, sometimes y'all's is 30 minutes, okay?
It was this time.
It was this time, okay. So if you say 90 minutes, I'm sitting back there playing Sudoku. So, I mean, I'm sorry, I've got words for windows and Sudoku. So, I mean, don't say 90 minutes hard and fast, because that puts you in a terrible position. You're dancing for 30 minutes.
I think he was trying to budget.
Okay.
All the
Well,
committees brought back.
90 is the max.
Please don't think
90
that.
is the max.
And the other
Eric's
thing is
roughly
that
60.
we will still have our pop-off room available. So if I say we can get air medical done typically in an hour and something comes up, some issue comes up and we need an hour and a half, we've got a pop-off room available, so we do our hour meeting and go to the pop-off room.
What's our
Kelly, I
pop-off
would
room?
say that
It's behind us right here.
The pop-off was very helpful.
It's got a ring and some gloves in it in case you need to set it there.
The pop-off has been very helpful, but what's happened, and I think this speaks positively to the GTAC process, but what's happened is the pop-off has become the the other room for Thames used it. Perfect. We need Thames to come because that means they're going to come to the AirMed committee, right? I mean, that's a good thing. But we actually need 2 other pop-off rooms. We need one that's truly a pop-off for her problem, and we need another one that's like the other meetings that are occurring. I mean, we do. And that's cost efficient for a lot of people. You guys start showing value. If you're booking, it costs us an extra $250 or $1,500 to go to $1,750 or whatever. That's money well spent, and there's not a group that's not going to be there. I promise you, once it opens.
What we do, Eric, is that we schedule and we tell whoever we're scheduling it. So you can have this time, the room from this time to this time. GTAC committees take precedence. If the committee needs a pop-off room, then you will have to work around that. So
Kelly brings the heavies in.
that committee will have to adjourn until that. I don't think it's ever happened, but that is the way we book the pop-off room. And I think it's great because it utilizes the space and allows people to meet. But the committees of this council have to take precedence on.
So I'm saying, James, it's going to be more useful as we narrow the meetings. We haven't used it as much, right? We've had the ability to have people have the meetings in there on top because the pop-off is rarely used. I think if we start, it sounds to me like committee chairs are saying, I can probably jam, if I know I've got pop-off and I can jam to 60, more times than not, I may need to use the pop-off room. And my point is, the other thing is we go to 2 days, that's going to automatically create a lot of those groups that want to lay on meetings at the same time because people are in and out. There's not this wider expanse of time at night and the other things. We're compressing a lot of stuff. So I'm simply saying booking the second pop-off room is a smart move. Call it the extra organization. Call it whatever you want. Pop-off 1, 2, organizational thing, whatever. And I'm telling you, I think that's a value added to stakeholders. It's a huge opportunity for us to be in the same place, same time. That other room can be used. More dialogue happens. One of the things there is an intangible that happens, and I'm not going to win this, but I want you guys to understand what we're sacrificing a little bit. So besides trading funny YouTube videos last night, me, Dudley, and Ryan, and 3 or 4 other guys got some work really done that needs, and I'm going to say it, the conversations go way better, 2 beers and some salsa into the discussion. There is value in people breaking bread together and having this, I mean, there just is. And that may not be available anymore, or we have to compress that, but I've had dinners all 3 nights this week with different groups of people that I would otherwise not be in the same place with, and I think that's valuable to our informal network of people who are thought leaders who care about each other and care about patients in Texas. And we ought to consider we're going to sacrifice a little bit of that. That's probably okay, but I just want to make sure we always need to remember all the things we are also giving up a little bit.
The other thing I'd like to speak to on that, and I don't know if it came out in the survey as well as I thought it would. It's what I've always tried to speak to when I spoke to the council in November. The EMS committee, a lot of times, I think we could get down in less than 90. What ends up happening is we touch on a topic, or we get to open public discussion, and somebody brings something up, and people want to be heard, and people want to speak. And usually what takes us to 90 or over, and I think it happened in Stroke yesterday, they went well past into their time. And I think what does that is that you get a topic that engages stakeholders for some reason. Maybe we're going to paint all ambulances blue, and here they all come up to the microphone and tell you why that's such a horrible idea. But we're engaging them, we're getting them involved in the process. And anytime, I've seen it happen time and time, it happens in disaster when they used to go 4 or 5 hours every meeting time. I've seen it happen in our committee, a lot of other committees. You say, okay, this is all great comment. Let's break for 10 minutes and go to the pop-off room, and we lose 3/4 of those people. And it's a great way to stifle discussion, actually, I've discovered. If you're going down the path you don't want to, you say, hey, let's go to the pop-off room.
That's supposed to be a secret.
It's called a timeout.
It's supposed to be a secret.
And I know Dr. Greenberg and I like to give each other a hard time about that, but there are times where that discussion, I think, is needed to prevent some of the things we've had in the past, which is lengthy, loud, hard
things that should have happened in committee meetings end up happening in front of this council. And I'm not saying that's not necessarily inappropriate, but I'll kind of relay it to our city. If P&Z shuts people down, they're coming to city council. P&Z's learned, let's not shut them down, let's let them get voiced here, because it's going to be better on everybody if we can handle it P&Z, instead of having them go to city council where it blows up in front of everybody. So, I think there's some value to that.
Planning and
What's
zoning.
P&Z? Parking
Planning
and
and
zoning?
zoning.
Planning and zoning.
The people tell you how much of a swimming pool you can have in your backyard, or what size commercial building can be built somewhere.
Well, and to add on to that point, I think you also got to take into account that if a department or a trade organization is going to send somebody, they may see more value in our council meeting because they spend less time, but maybe can get quasi caught up with the committee reports. So I think that some of the blow by on the people coming to the mic on some more contentious subjects at the council meeting is that they didn't have time to go to. For instance, EMS was yesterday. I don't even know, man. I've been here since Tuesday. So I started. I'm serious. My dog's going to bite me when I get home. Tuesday, Wednesday morning we start off with education, and EMS was 4 o'clock, and so I'm not saying that the committees don't have analogous charges or whatever, but some of those things may not necessarily directly affect each constituency group. So what happens is they don't send the person down here until the council meeting, and that's part of the reason why if we were to shorten it, potentially they'd say, well, I wasn't going to send you for 3 nights hotel stay because there's Jody's committee on the first day at the first meeting, and the other relative committee to what we do is the second day at 5 o'clock. And so I think that maybe we can also, as a side effect, reduce some of the blow by shortening it to the point where there's some value in saying, well, I need to be there for the whole time. I'm ringside. I get to hear the public comment. That's the other thing I was waiting to interject. I know I sit in the back of a lot of the meetings, and I got admonished yesterday for laughing at something totally unrelated to the presentation. And at least I think that was me. So, because I was laughing. Yeah. Somebody else was sitting next to us. But anyway, so we, but the unique thing is that if you were not here and you only came to the council meeting, they do a good job of giving us what was generically talked about. But you don't see the passion or the specific that somebody's trying to say unless you hear it out of their mouth. So if we condense it and everybody can actually hear them, then they are getting input because they know we're in the audience. And some of us are always in the audience, and some people, because of schedules, can't be in the audience the whole time. But at least it allows everybody to be in the audience, and then I think they feel like they're being heard kind of both ways at the same time.
And I think, they need to be heard, but it's, and Dudley, you and I have been through this, is that we're all trying to look at time here, and we're trying to compress time and get the most out of it. However, Dudley and I, and I know in yours too, sometimes things that we think will not be a hot button issue, we think we're just going to scoot right over, it's going to be nice and quick, or you hit that wall and you're there for an hour and a half talking about the same one. So, but if we go to an hour and a half, and correct me, we have to publish this in the Texas Register a month ahead of time. So if we have a meeting that starts at 9 and you're through at 9:45, you still can't start the next meeting until that time period,
Can I interject?
right?
I don't know. Okay. I've just been listening to everything and what and I don't know if this will fly, okay? But if we have the council start the meeting, starts off, and the committees are just an extension.
Correct.
So I don't know if this will fly. If
I know
we
where she's
have a
going.
council agenda and
Assigned
we have to
times.
do the committee agendas, and so the committees will discuss anything that's on the council's agenda that the council directs them to discuss. If we can do an agenda that covers the council and will cover all of the committees at the initial council meeting, y'all might decide trauma needs 2 hours, EMS needs an hour a day. Shelley, you might need an hour, 45 minutes a day, and assign it that way. I don't know if that will work. I have not run this by OGC. And then it would be a recess, and you come back the next day.
I know that we have to have those in so the public knows what time that meeting is.
Absolutely.
And I think,
How they would know when to
yeah.
be here. They're only coming for stroke, and it could be anywhere between 9:30 and.
Yeah.
That's
Yeah,
how the,
I don't want a cable
you've
repair guy
testified. That's how
schedule.
the rest of the government works.
Yeah,
That
so
actually is true.
if Shelley does get
Yeah.
there at 9:45, you've really got to wait till 10:30 for that next group.
That's
My
how
Wi-Fi
the rest of
doesn't
the government works.
Yeah.
Everybody's testified at legislature.
Chief?
I know, but that's one of the reasons, but that doesn't, that's a problem with it. I mean, we don't want to duplicate the problem
No.
of you never know when you're going to give testimony, because that will,
Yeah, that's the number one thing
No.
I actually hate about coming up here to sit in a
Right.
committee meeting, a Senate hearing or
But
something, is you just know, that is a bad thing.
But there must be a way that it's okay to do. You would think the legislature would be following their own rules. Yeah, so there's got to be a way to do it.
Every time they start, they have a caveat on there, they have to break for when the Senate goes into session, and
Right.
then they'll reconvene after it adjourns for the day, and then they list out everything they're gonna talk about.
Correct.
You get there, like the prime example was the bill we had heard the other day. We were there at 8:45,
And they went,
started at 9, they went into Senate at 11, came back at 1:30, and, you may be there till 4 or 5. The way they do that is, it's the same way you guys do it, I mean, we broke, and we're back here talking about item number 1 again, so.
So it's
all on
legal,
the
it's
agenda.
likely legal.
It's actually
Ronnie's
the
question
start
is
time
different.
that's the goofy.
well, if the goal is to make us more functional and be
Correct.
more efficient with our time, that's not the way to do it.
Or to generate.
If that's going
stakeholder
backwards, I would
loyalty
say.
well,
and participation.
there is a medium in between the incredible structure that we have now and the way the legislature does it.
I think one of
But
the
clearly, if the legislature does it the way they do it, there's got to be something in
one of the
there.
other things too, and Eric and I talked about the other day, that we have times for meetings all over the place. If we can start as a group and committee chairs come up and say, ours was this Wednesday at 9 a.m., we were first out of the bat. If that becomes our norm, people can begin to schedule for that and say, okay, the meetings I want to go, this is what I need to do. Because as a committee chair, every time schedule comes out, I look and go, where are we? And I have no idea where. And unfortunately, Eric called me, or had his admin call me and say, hey, can you guys switch with me? Well, I email some of my folks and they go, we've already made travel arrangements. Well, okay, I'm sorry, I can't. But if we had the same time every time,
Yeah, we're making these drug deals trying to do the.
Yeah.
It's not me. It's not
yeah,
me.
I think that would be more efficient with time, let people know what we're doing, it's scheduled in advance, and we keep it as long as we can.
And I think the other piece of that is you try to, I think Ryan touched on this in your strategic plan, is you try to schedule the things that seem to go together.
I agree.
Mhm.
EMS education, air medical.
And EMS on the same day, yeah.
All on the same day.
Yeah.
Then people, if they don't have to be here for everything, they can schedule their time. We've got TTAP putting a video on, thinking, I don't know about you guys, there's nobody here today. That's because they're all back in their offices watching it. But
Yeah.
It's still
We're
on.
being told that.
They can't hear you guys, but it's still on.
We have somebody who wants to speak.
Go ahead.
Just as a guy in the peanut gallery, if you don't mind, my name's Norman Seals. I'm Assistant Chief of EMS for Dallas Fire Rescue. Relatively, actually very new into this process coming down to these meetings. Just wanted to pass on a couple of points for y'all to consideration from our perspective, and I've talked to a number of other people out in the peanut gallery as well. I agree with Eric. I gain a huge amount of information sitting through the committee sessions, listening to the input, listening to all the pieces that are discussed. Even more than I got today. I mean, what y'all do here is very good and very important, but I learned a lot from that. But even more importantly for me, if I need to speak to Jory, being in Dallas, I can drive 15 minutes up the street and have a meeting with her. Most of the people that come to this meeting, though, that I believe if I need to have a conversation with them, and I'm a big believer in face-to-face being preferable to email or even phone over certain conversations, the opportunities presented here are critical. Sometimes over a beer and a bowl of salsa. Sometimes stepping out of a meeting out into the hallway and having that conversation. I appreciate you trying to be efficient. I would just caution that if you go to where it's 2 days that are 14 hours long, you really hamper a lot of the real sidebar business that occurs that's really beneficial to us all, the networking and those kind of things. Just wanted to back up what Eric had to say earlier. Thank you.
Thank you. So I will tell you, in the history of man, I was pretty thrilled. We had a dinner with the San Antonio Assistant Chief of EMS, the Dallas Fire Rescue guys at chief level, and Houston, and somebody else, me and Dudley and a couple other, but I mean, there was 10 or 12 people that in my lifetime, I'm not sure when that would have happened, and I think those kinds of relationships, they didn't talk about GETAC stuff necessarily, but that is an opportunity that GETAC does start to create. And they may come initially because of that dinner. But now they're here, and we're getting better buy-in from some of the places that I think historically may not have participated as much as any of us ever wanted. The other one thing I had one other thought about that, I can't get that, but go ahead.
Norm,
I'm sorry. Legislation. We've seen what, some of you guys have not been around. I'm as old as dirt, I think. I mean, I feel sometimes like I've been here since we were room 730 up to 739, whatever, in the old building. In the morning. It's covered in asbestos or whatever it is now, right? What's that?
No, it's falling down.
Oh, yeah, the sides are falling off.
Yeah, sides.
We used to deal with we were deconflicting bills. What we used to do is try to find a way to get to everybody who was coming to Austin separately because we weren't in agreement about what we wanted. The bill discussion today is light years better and more cohesive. And I would say that a lot of that doesn't happen in the GETAC meetings either. That happens in sort of the discussions that Chief just talked about. So we don't want to throw the baby out with the bathwater because I think what we'll see is fracturization and then a bunch of, now everybody's doing it inside the law instead of working through the regular process. And the regular process either isn't beneficial to them, it's too quick, too jammed up, whatever. Just another thought.
Eric, what I keep on hearing, and it doesn't bother me, I'm retired, and I live down the road. I'm sorry. I'm gonna be here every time y'all say you're gonna be here. It really doesn't matter. What I was told initially was that we were having people with really financial constraints, that we needed to make this more efficient, tighten it up, so we could save money for everybody, okay? What I'm hearing from y'all is that y'all got plenty of money and that y'all can come and stay a longer time. I mean, as far as I'm concerned, God bless, let's go for it.
So that's not what, so I'll tell you, that's not what we heard. We heard that you guys wanted to participate. So I'll tell you what I thought the driver was. It wasn't to save the stakeholders money. That may have been a side benefit.
Right.
But the driver was so that GETAC members could actually participate in the committees, which I think is a wonderful thing.
Yes,
what Dr. Greenberg just
that's right,
reflected,
so we could.
that he would commit to stay for the full 2 days.
Sure.
I think we need to be pushing towards that moment. I absolutely think that's what we should have is strong participation from the committee, and we should not ask you guys to give up a work month. So I am committed to that, and I don't want to be seen by GETAC itself as trying to suggest that.
Well, the other thing is the amount of actually money and time the state is spending, because we've heard that GETAC is probably the most expensive in money and time of most of the committees. Is that correct? We must be close.
Potentially, because we use outside space. The rest of the councils, to my knowledge, use state space. So there is a factor. It's not a huge cost factor. There is a cost factor in there. Like the DSHS council uses state space.
With what everyone's saying, and maybe it's just me, let me go back. Do we want to change it, or do we want to leave it alone? If we want to change it, then we have to figure out how we're going to do it. If we're going to leave it alone, then we just leave it. I'm still confused on whether we're going to change it or whether
we as a council voted on our strategic plan.
Right.
And again, not in concrete, but the strategic plan, whichever point that was, J, or I don't have my glasses on, but whichever one that was that we would move toward 2-day meetings. So at this point, I think we're having this discussion because the council has already agreed that we should try to come up with some form of that, whether it's a 48 consecutive hours or 2 days. I'm not sure we ever really drilled that down. But that's my perspective. Go ahead, Mike. And then Jory.
I've got to make some comments here. Kind of going back to our last meeting, I guess. GETAC has never, that I recall, ever tried to pass anything that we tried to pass over the stakeholders. Stakeholders have always been our objective next to, patient care and what's best for the patients. And I don't think the strategic plan had this ideal of, we were going to ignore the stakeholders. that was the way it was presented at our last meeting, was that we were these bad guys. And I'd suggest watching the videos from these meetings, watch facial expressions, the way GETAC's referred to, referring to us as they and them, and not a cohesive group, not a coordinated group, that we don't have the stakeholders in mind. And the whole idea behind all this, from what I understand, just like the doctor said, is that we can participate in each of the committee meetings, and that we are all going for one thing, and that is to provide the best care possible to our state and be the most help to each other. One other thing I would suggest too is listen to what's being said at the meetings, and are we staying on subject? Are we staying with the agenda, or are we just listening to ourselves blow off? So I think that's very important too. Is the information we're sharing with the stakeholders something that is of importance, or is it something that's just on my mind today? I try to keep my mouth shut as much as I can, but every once in a while I feel like I got to share my feelings also.
Jory?
I just suggest that we get that computer and put it there and just plot through a 2-day meeting that starts on Wednesday at 10, goes to 7, starts the next day at 8, and then see when it begins. And then look at doing a 2-day time frame that starts at 8 o'clock on Wednesday and goes to whenever it needs to go. So we can kind of see.
Me too, thank you. I think that's exactly what we need to do, is get that up there where everybody can see it. And while they're doing that, I believe the role of the chair is to stay as neutral as possible to facilitate the best discussion. But I do represent the Texas Fire Chiefs, and I can tell you that as much as I push and prod and convince them to go, the response I get is I can't spend Tuesday through Friday in Austin. I don't have the staff and I don't have the budget to do it with. And that, I'm talking generally the cities of 30,000 to 120,000 range. That tends to be the thing. And I say, well, what if we could get that down to 2 or 2.5 and they could power through? Yeah, I could probably do that. Maybe not even every time, but certainly get more participation. So, and then I'll speak selfishly as chair. The previous chair, not speaking on behalf of him, but he actually lived and worked in Austin. It was much easier for him to pop in and out of meetings and have those hallway conversations. And in my current employment, I just can't come in for 3 or 4 days at a time. I want to, but got to keep a paycheck going too. So if we can consolidate it from a selfish aspect, I think I can do a better job as chair, being in some more of those meetings and listening. But Dudley, are you... Who plugged in over there, Dudley?
I'm about to, yeah.
And I probably live as close as anybody. I drive back and forth most of the time, but we're talking 2 hours driving back and forth. And sometimes it's actually, that's the worst, y'all probably all know that's the worst meeting to have, is one is your own hometown. Because it's always one other thing you do and then I'll go. So, my intention, of course, was to come yesterday and I never made it. But if everything is in a consolidated time, and we structure the meeting in such a way that I'm actually going to miss something, I'll go to most of it. I'm not going to say I'm going to go to every single minute of every single committee, but I think we really should quit separating out the committee from the council. The whole thing's the council meeting. We get a lot of work done in the committees.
The other thing you guys was interesting, I think in some ways you don't understand how it's larger than the council now.
Never
I mean,
suggested
in other words,
what?
the GTAC meetings are, it's not 3 hours plus some prep work, and I mean, it is it's a thing. It's where.
It has its own life.
Huh?
It has its own life.
I agree, and I think that's and in some ways that's problematic for you guys, because you shouldn't have to be responsible for this larger blob of this thing, but it is what it is. And these other side meetings, these legislative meetings, these impromptu sidebar meetings, they are incredibly valuable in keeping us focused as an emergency healthcare system in Texas. There's probably it would be hilarious that the sidebar meetings and the pop-off meetings and other things are actually more valuable ultimately to the emergency healthcare system than, I mean, equals, so the medical directors have equals. That's part of this, you know what I mean? That there are not other opportunities for EMS folks to get together or trauma folks to get together, I think. And I think that's where not another hotel lobby you can pull in, grab a Ronnie Stewart, grab, somebody else from a medical director's role, and then have a stroke person. The stroke committee sitting there and you bring Jory Klein. Well, I'd love to have Jory and some other people from trauma talk to them in our stroke committee, but I don't really have that opportunity. We get to meet face to face and sit down for 20 minutes and listen, and you're like, wow, I get it now. That's why it's an intangible, it's hard, I don't know if there's a dollar amount, a time amount that I can put on what that value is, but.
I get more done in whole meetings.
Oh,
Truly,
I agree.
truly. I get more done. Sometimes I will come to a meeting, walk in here, someone will grab me, can I talk to you a minute? I'm in the hall, and the next thing I know, I got 5 people around me, or I've gone through 5 or 6 more that I would never get.
I agree.
I understand that this was part of the strategic plan, and I was for it, and yeah, let's do it. But at the same time, if it's going to harm, if it's going to do more harm to good to change it to 2 days, to leave it to 3, do we try to do the best we can to be here, or do we? I mean, I see both sides of this.
To be fair to so I think we need to meet you guys. I've been sort of probably cast as an anti, so we should try to do our very best to see what this looks like. And Jory's made a very good point about let's put it up so we can all see it, because then you go, and you're going to be so tired by the time you finish that day, you're going to the room and get room service. I can see what that day looks like. Let's look at it. We owe it to you guys. I think you guys have been very good stewards, and we owe it to try to jam it in.
And I think we get some relief from the having the evening get-togethers, the beer and the salsa, and some of those other things, which I agree, they are very valuable. But if we do if we start at 10 or 11 or noon or whatever it is on one day, to help alleviate some night before travel for folks, you still can have that evening. Your next day doesn't have to go till 8 p.m. I mean, you can say, we're cutting it off at 6:30.
Yeah, dinners
Still
and
time to do.
lunches and sidebar meetings are valuable. You're right.
Still time to do that.
Dr. Stewart had something.
Go ahead.
Well, actually, I just had a question. I know we always take a lunch break, and I'm assuming that there are people sitting around the table that attend every meeting. I'm the one that doesn't attend every meeting. I come to the ones that I think pertain that we might be able to work with the group. So I guess I'm wondering, do we have to factor in a lunch break, or I wouldn't mind if the injury prevention committee was meeting from noon to 1 or whatever, and we'll eat lunch before, we'll eat lunch after. But I didn't know if there are people who literally come to every meeting and they get no break, if that would make sense. But there are.
So I would say,
Linda goes to every meeting.
Yes, she does.
I bring my lunch.
I'm going to give a historical comment that I guess I've been coming to these meetings, I don't know, I've been coming since '93. And I do think it is very true that in the early days, in the beginning, one of the real advantages of the trauma system legislation is it basically put people to meeting where in the past they didn't really meet. As a matter of fact, I don't think they even met in their local areas, to be honest. I think you had trauma centers who never talked to each other, who didn't know who the trauma medical directors were. and who didn't really care that much, to be honest. And I think in those days we were our worst. We were our own worst enemies. In that, why couldn't we get trauma system funding passed? I mean, now we're trying to preserve it, but why couldn't we get any of those things passed? Well, we couldn't get them passed because we basically polarized along a lot of different factions: EMS versus the hospitals, hospitals versus physicians, nurses versus the doctors, rural versus urban, south versus east. I mean, south versus. It was like there was many factions, and quite frankly, some of those bills didn't pass because people were going and testifying against them, or they didn't actually usually testify. They usually just went and talked to their legislators and told them how much they hated it. And the last thing a legislator wants is to have the stakeholder groups that they're trying to support go fight amongst each other in committee. And so I think the only way we were really successful is once we started meeting and talking to each other, and you knew who people were, and you could put a face to a name, and we talked about trying to eliminate some of those things for the greater good. I think we made a lot of progress. And I think if you just, I mean, I don't know how much. If you look at the situation we have in Washington right now, I mean, one theory for that is that the legislators themselves don't spend enough time with each other in informal settings, and so they don't really know each other, like, for example, 40 years ago when they basically hung around more together. And so I think what you're saying is very real. I will say this too, though. One of my observations is that this whole process has always been pretty inefficient with respect to people's time. It seems like that that's not viewed very, that this is nothing new, just so you know. This was true in 1995 in TTAF. There were meetings, basically, it was inefficient with respect to people's time. And so I think the goal of trying to be more efficient with people's time is a good thing. It's well intended, but we don't want to have. We want to try to minimize the unintended consequence. If you want to see a meeting really deteriorate, just pass out Girl Scout cookies in the middle of the thing. Eric's over there fighting for the Thin Mints. Anyway, my point is that I don't think it's necessarily bad, but I think we should be very sensitive to the potential unintended consequence of eliminating informal action, eliminating informal interaction among the stakeholders, because I think that is very important. I will say I'm not certain, and this is probably self-serving, but I'm not certain I need to go to every committee meeting. Honestly, I don't think I could take it. I'll just say it. I think you're blessed. I mean, you're gifted to be able to do that because.
No, I don't have y'all's background. And see, I don't think all of y'all have to go to all the meetings. And I think that's the time, because I think your interaction is, you get more done probably than you do in the committee meetings, because you know whose ambus is yellow and the rest of them are, or who smacked who or whatever. So, I mean, all those things, that interaction is, I think, extremely important for y'all. And I want to point out that Dr. Stewart has all the cookies now. Just wanted to point that out. But no, I think, and I would hate to take any of that time away. I have to come because I'm the public member, and I don't even, the acronyms, I spend half my time looking them up. But I have to do those. And if anybody else wants to come, because I find them fascinating, what y'all do. I mean, Dr. McGraw's yesterday, fascinating. So anyway, it's just, y'all don't have to go to all of them. I do. That's my problem. I don't have any problems with any of the times that y'all meet. It's just, y'all just need to come up with something that all of y'all will be happy with, that will meet everybody's budget constraints and time constraints.
So I want to say a couple of things. Linda, first, you have been the best public member I think we've ever had.
Ever.
Absolutely.
Second, offense to any of you guys, but I know my boss at least, and I'm gonna say if we went to a day and a half, if we went to a day and even shorter than 2, the chance of having 75% of the GTAC members in all the committee meetings, which we could go back 3 meetings after and not have them. Not because of poor intentions, but because oh my gosh, I can't do it, right? I'm going to tell you what I think would happen. I don't think that there would be people sitting for 2 solid days, even though they say they would now. I think in practice, that's very difficult when you already know most of the issues and you really need a summary of it. I don't think Dr. Greenberg needs to sit through.
Right, but you know where I will be? In the hall.
Yeah.
In the hall.
The same place we keep talking about where everything happens.
In fact,
I'll
be the elephant in the room. I'll be the elephant in the room and say, we can't have all council members in the room at the same time. So,
Can you not, you can't sit in a committee meeting? You can go to the orchestra? You have to be, what's the thing?
If the whole thing's the council, you can.
Conducting business or something.
there's the perception that if
cannot
all
have
council members are in the room, the perception could be that we
Mailing each other privately, we know that for sure.
But Mr. Chairman, if the council is,
All y'all today didn't talk. You're hearing from the business, from the staff, the public, that's deliberation.
We can't
But-
even hang out.
So like, when we open a new fire station and all the council members are there, they have to post that as a meeting to say that they're there.
but if we list the
Yeah, but
2
if the
days
meeting's
as a
posted from
council
Thursday
meeting.
to Friday, I
Well,
mean,
true.
Yeah.
Wednesday to
I agree.
Friday.
So we just gotta be careful about that.
More importantly, Bobby's point was exactly right, it's in the hallway.
Right.
That's where we're gonna have, I think that's more, it's about.
And again, I agree with the comment that we need to try to group those meetings according to their pertinence to each other.
You ready there, Mr.
So they do it?
Peter?
Can I make one more comment? Kind of clarify maybe what I was trying to say a while ago. Networking has always been the best. Any of the hospital meetings I ever attended, we get more out of the networking than we did the meetings. And I have to say, this meeting I have enjoyed probably more than I have in a long time. I enjoyed y'all's meeting with the presentations, and same way with Dory's. It's been very good, and it seems like it's been very focused this time. I like it.
So,
Can you review, Dudley, how many,
Overlapping constituents, EMS and your committee.
the people that you know or the committees you know, what their time limits are again?
What I do is I put everybody down for 90 minutes.
Yeah, just need to put somebody.
Based upon, let's just start there.
Can I comment on that? That's a great segue for me. My comment is I think it's unrealistic today that trauma system says we need 90 minutes. I think that the medical directors say we only need 60 minutes because that volume of work for the committees is going to be variable. I mean, yeah, today you need 60 minutes, but a year from now you need 90 because you got a bunch of stuff going on. So in this framework, maybe instead of all 90-minute slots, maybe you make 6 90-minute slots, 4 60-minute slots, and when you subcommittee chairs have to turn in your agenda, you request your time slot. So if your agenda is only looking like it's going to need 60 minutes, you take a 60-minute slot. And you do that in good faith. In other words, you don't just say, well, I'm always going to take a 90-minute. And maybe it's first come, first serve. That'll facilitate getting agendas in, et cetera, et cetera. So just a thought.
thank you.
Nice.
But it's the other thing we could do. I agree. So aeronautical, education, EMS,
I'm not going to listen to you anymore.
the medical directors, I would venture to say they all want to be on the same day, close to one another, right? They're all EMS related?
Right, and I think that that's exactly, you're correct. I do think, though, that you would want to put on the same day, but maybe staggering topics, because you take away half of your brain trust if you have an EMS committee say first. We have to go to the pop-off room to throw punches, and just, that's a joke for all of you out there. We have to go to the pop-off room, and then you immediately start the EMS education committee meeting, then you're going to have people that are going to be pulled, so if we can stagger them within the day with kind of.
So the other interesting thing is we have stroke and cardiac. They're kind of acute care. So if you went EMS, stroke, and did another like education,
Education.
cardiac,
cardiac, yeah.
So that gives you that mental time to break down or
Right.
do what you need to do and then come back for the committee meeting, specifically related to you. So if we could kind of stage those so that it's kind of on the same day or close to the same day, or at least, that late that afternoon and, first thing in the morning so that we can maximize time and still give that time for the networking and the other activity that goes on.
So I'm going to sound like I'm arguing against myself constantly, but it's not
Who knew?
unusual. So the staggering of things that are like, these things seem just like the others. When you move those around, it actually creates a political opportunity for someone. Someone talked about the two chiefs there. Dallas Fire Rescue, both of them were not listening right now. But if they didn't, you kind of have to be able to say, this is completely counterintuitive. You have to go say, no, I don't know what idiots are putting together the schedule, but I got to be down there for 9, and then the next day is at 10:30. I got to stay that night. It's like if you jam it all up, you actually indirectly cause some effects. And I also agree with Jory in that it is a difficult day to get 3 or 4 really important big meetings. They're all, and you sort of become mentally exhausted. So staggering some of the other, not odd, but the other meetings is probably helpful.
And before we roll too much into this, one of the things I was going to say earlier, and a lot of people kind of said it very similar, but so if there is an issue with people with finances and it's, they don't have the money to come here for 3 days or whatever, I'll argue most people, I won't argue most, there's a significant number of people that come here that are here either from Monday or Tuesday. So regardless of what we do here, they're not going to come in for 2 days and leave. They're going to be here for the other meetings that occur around this. But, and I don't mean this in any way, shape, or form, I'm just going to lay it out there, but if you look at the meeting that is not attended, now that we're broadcasting over the internet, it's the council meeting. And I think that is because people come in and they get their networking opportunity and they get their opportunity to be heard at the committees. So when that stuff comes to council and council takes action, they're comfortable with where that's going because it's been, some cases, beat to frickin' death in the committees, but it's been worked out. And I think it was one of those things we talked about in November about using the committees to drive that consensus and not try to get to a point where that's always happening here, or else we can cut all these back to 30 or 45 or 50 minutes and then give you guys 6, 7, 8 hours to do your business.
Which actually I think that's the best argument for the networking and the discussion in committee, because I deal, so as a department chair, I deal with a bunch of different factions who interact with a bunch of other people, and they're all so friendly people. And a lot of times I basically say, you know what, this needs more talking. You need to go talk. You have to talk to each other. You don't come here. I don't want anyone to. When we had real dysfunction in the council was when basically everyone felt that for the council meeting, we came with no consensus, and we were going to decide at the council meeting. Well, that led to a lot of y'all weren't here for those day-long meetings. They went forever with fighting. It's good that it's boring, and I don't know whether it's a good or a bad sign that I don't know whether it's a good or a bad sign that there's a lot fewer attendees at the council meeting. It's probably good, but I'm not exactly certain. It probably is related to these things that are that little light post over there that I think is a camera. It's probably related to that, but I don't know. What do y'all think? That'd be well,
the fact that it's on Friday morning after everything else is done, people are gone on Thursday. Right. I think that's part of the reason.
I agree with you. If we do look at any other schedule, I would say that allowing people who are going to be here 2 or 3 days, if you give them a work day during a work week, then they're out for 2 or 3 days and they have a closing work day before things get put off for another 2 days over a weekend, people are probably a lot happier. I know that it's very difficult to end here on noon, regardless of what you travel by, and you're not going to go home and do anything. So, for instance, when I left my office Monday, my staff said, "See you next Monday," and that's pretty tough. So, if we can shorten it down and give people a work day on either side, then they can keep their day jobs up to speed as well. It's pretty difficult.
So you're back to talking about moving, so we'd have Friday open, but.
Well, I mean, arbitrarily, we've been saying
I'm just
Wednesday,
saying,
Thursday.
I
What
think
if it's
that-
Tuesday through Thursday? I
So
don't
I'll
know.
tell you, if to Ronnie's point, if it's over, it's not the day of the week, is why they're not coming to GTAC. They're leaving. I will tell you, they'll stay for GTAC on Friday. They used to stay all the time, and they thought there was going to be
Some controversial issue
Absolutely.
that was
We're
going to get
voting on
ramrodded down there.
I'll tell you one. All orthopedic surgery at level 3s will be required. There will be no exceptions. Lead level 3s must and shall. That's a word, right?
This is an example and only an example.
There were 1,000 people in that audience that day, and it went till 4 on a Friday. People were missing flights to Amarillo because they were not leaving because they thought GTAC was going to. Remember that?
I remember all
And
that.
that's my point. Is I agree. I think it's tough to figure out if you're right or not, but I think you're right that the reason people aren't staying or showing they're departing on Thursday night or first thing in here. I think they come in here. The room is pretty full till 10 or 10:30, 11. I don't think we should go in the afternoons with GTAC ever because the people who have to go to the west are going to leave at 2:30 every time, no matter what. It doesn't matter what's going on. They're not going to miss a flight on Friday at that time.
Chief, go ahead.
I just wanted to say, I know we've talked a lot about networking, and I think that's important. We've talked a lot about time. I'm a mother. One of my kids has been texting me constantly already, going, "Are you coming home yet? Are you coming home yet?" So I definitely agree. We all have time. I came up here, I had to leave 3-something Tuesday morning to come up to be here for the meeting on the Capitol. I didn't plan to slap the governor when I was coming up here. Not the intent. But I think it is.
She cold cocked him. She didn't slap him. She cold cocked him. Back of her hand.
Hey, but we wanted to make an impression. But I think it's more than just networking. I think to me, part of the strategy of the council should be to try to get the stakeholders' involvement. When I became EMS chief 3 years ago, my captain told me, he said, Dallas Fire Rescue has got to quit staying in its own sandbox. We have got to get involved outside of our own city. And I said, okay, I don't know how to do that. How do I do that? And he said, start with GETAC. He said, ever since Maxie left, Dallas has not been involved in GETAC. We need to that's a good place to start, get back. And so I started coming, and Dudley and Brian and some of the others on the EMS committee were really great. It was about the time they were looking at rule changes. So I was going to Austin and to San Antonio and everywhere with the rule changes, and it was a great involvement. And then, okay, now kind of what? And then I made the very great move one night of asking Eric and Chief Kidd what the RAC was, because I went, what's this other acronym? I haven't quite figured this one out, because, he told me to start with GETAC, so I started with GETAC. And so I said, okay, now I'm kind of plugged in there. I keep hearing this RAC. What does that do? And he got me plugged in. And when I first started coming about 2.5 years ago, I was the only chief from the Dallas area that showed up. I don't know if you knew, but today there were 6 of us. Because when I got involved, then I go back and I get the other people involved. So it's more than the networking's good too, but it's more about getting that stakeholder involvement. And if it wasn't for that time when these guys sat down with me outside the meetings to explain to me what was going on and explain to me the importance of it, then I might have never continued on that, and these other chiefs might not have been showing up here today too. So the networking is great, but I think more it's the way of getting, because some of us, we don't want to ask the question during the committee meetings because we feel like we're stupid if we ask. So we wait until that evening when we see somebody and can go up to them and ask them, hey, what are y'all talking about? What is this? So I think it's real important to the stakeholder involvement too, to have that time. It's more than just networking. It's the ability for the stakeholders to really find out what's going on and to kind of pull them into the system.
Thank you very much.
Yeah.
In the interest of not going until 4 or 5, can we is it okay with the council if we just kind of focus, and the committee chairs focus on what a schedule might look like? Because I'm hearing a lot of pros and cons either way, and we're picking up on all the good side stuff, the networking and the fact that we're in a system where the committees are really getting a lot of stakeholder input and a little comfort with that. So can we look at some sort of a schedule? I don't know what that would be, and here's where the committee chairs really need to.
So this is the one that we talked about earlier, starting at 10 in the morning, thinking that would give everybody time to get to Austin. They wouldn't have to stay on Tuesday night unless they wanted to or they were here for other things. So 10 to 11 with GETAC, 11 to 12:30 with the first committee, an hour off for lunch, and then come back at 1:30 to 3 for committee 2, 3 to 4:30 for committee 3, 4:30 to 6 for committee 4. You could slide another one in there. That would take you to 7:30. That may be more important as we look at day 2, which would start at 8 o'clock in the morning. Every 90 minutes, you break from lunch again from 12:30 to 1:30, which I would suggest committees said they needed 60 minutes. We put them up against that lunch hour. That's just me.
That's exactly what I was about to say.
But anyway, then you come back at 1:30, and then GTAC meets from 6 until 8. If they need a 2-hour break, if they need a 2-hour block, that is very similar to what happens at the EMS conference every year on that Monday. And I think potentially people that are going to stay may very well take the options on that evening that they take during the conference, which is they stay for the item they want to hear, and then they go out and have a good time and network. If you pulled Committee 5 over to Wednesday and you went to 6 to 7:30, then that would get GTAC over instead of at 8 o'clock, would get GTAC over at 6:30 in the evening if we started at 8.
The only issue with that is Wednesday's typically rec chairs.
So what about making rec chairs on Tuesday? TTCF is going to be on Tuesday, but rec chairs on Tuesday. That way the racks.
There's so many rec chairs that are nurses. There's enough of them. There's like half.
I'm not saying have them overlap. How long does TTCF go?
We got TTAF as well on Tuesday.
Yeah, it's 8 to 5 or something. It's like a marathon.
They do all day, and then TTAF comes in for like 3.5 hours.
Yeah. So, is that right?
What do you do? What do you
10
do all
o'clock
day?
on
3:30? So let's, from a practical perspective, let's just assume Dudley did the best job just now.
Okay.
So if I'm traveling in from San Antonio, life is perfect for Eric. I get up, I eat with my kids, I get on the car at 8, I'm here by 9:30. I meet some people, I have my meetings all day, and the thing wraps up at 8, I'm home at 9:30. Okay? Eric's happy. Dr. Greenberg's happy.
Yeah, same.
Mike Stewart's happy.
Alan Tyrock? I don't know.
Right.
Not happy.
He'll be going home the next morning.
Wanda Helgeson.
Correct.
They're going to probably have to fly in Wednesday night, because remember now, GTAC is going to be the organizing thing, is that first thing at 10 o'clock.
We can get in for a 10 o'clock meeting, I think.
El Paso can, but Amarillo can't. They can't be here till 10:30 or 10:35. Not that I've memorized the Southwest schedule from Amarillo.
or Lubbock.
Or Lubbock.
When is isn't there also the HPP contract meeting?
That happens on Tuesday during GTAC. During
TTCF.
So,
usually by name.
So my question is, we can move the rec chairs following TTCF and after your meeting, would you not?
Yes.
And so.
What does TTAF do? Are you saying move TTAF to that, not rack chairs? I'm
No,
sorry.
I'm saying move rec chairs to that meeting.
Okay.
To like 3:30 on Tuesday. They could go to 5:30. TTCF picks up at 5:30. TTAC picks up at 5:30. So Tuesday is one big deal.
Yes.
That's what that makes that, but then it also makes it fall into the GTAC schedule.
Everybody we just talked about those groups, it is GTAC. They would see that day as a GTAC day, oddly enough. It wouldn't be GTAC.
It's still shaving off 2 days.
I don't disagree. I'm not arguing. I'm saying
That
it's
means that Wanda
yeah,
will already be here.
already here. Yep.
All those people that have difficulty flying from rec chairs would already be here on Tuesday because they're already coming in for that
Yep.
disaster contract.
So what about going home on Thursday?
They're not going home on Thursday, they have to stay Thursday. No one who's traveled the size of about 6 of us within 90 miles are going home after 8.
What, what I'm hearing is there's a possibility some people, even with the 10 o'clock on day one,
Thank you.
are still going to have to come in the night before.
Yes.
So why don't we start the GETAC meeting at 8 o'clock in the morning?
Because not everybody's going to have to come in it the night before.
I was actually going to go the other way with it. I think if you change it to 60 minutes on that first meeting after our initial council meeting, which then if it doesn't, or the meeting after lunch, I don't care, but it takes 30 minutes out. And Dudley, I can't hardly tell. Is that 5:30?
This one gets over at 6.
Yeah, these are the fully loaded committees too. These are all an hour and a half.
Right.
So this is as long as it could possibly
Right,
take.
I think that was the
Right.
intellectual argument was to try to leave it at 90 and see what happens. Then you start, if you start.
Then you shave
now,
it.
It's a little.
There are 4 committees that look like they're 60 minutes. At least that's what I have.
I agree.
Intervention, pediatrics, stroke, and cardiac.
And medical directors, we can do it in an hour most of the time. We'll fit whatever given to us.
Jory, if you look at the schedule though, I think we can all agree that this is getting close to being doable.
Oh, yeah.
Let's do it.
Because especially if
I
we
mean,
do the
quite-
direct shares Tuesday.
I'm going to say in my idealized view of the world at this moment in time, it becomes possible to envision if the committees do all their work, do everything possible. I mean, GTAC could be an hour. I mean, if we skip all the reports, I mean, if you basically minimize those reports, I mean, it could be done. It probably shouldn't be done this first time, but maybe that should be a goal.
And if I'm going to half of the committee meetings anyway, and we're saying possibly people aren't in the council meeting today because they've already been in the committees, then why do we need committee reports at the GTAC close meeting?
So there's the.
Just
there's
action.
The ideal, and then there's you guys that I know very well. And it's gonna be no committee reports, and we didn't go to that meeting, so it's like the worst possible.
I think you have to have.
You're me, I mean, I don't.
You have to have the committee reports for minutes. You'd have to have some sort of an abbreviated committee report for minutes because that's a historical snapshot.
So consider my comments distracting and keep going.
Can I just suggest this then? So if we have all these people already here on Tuesday, to go back to Van's suggestion, so if you have GTAC that starts, let's say at 8:30, it goes to 9:30.
Yeah.
And so in that's where we'd want DSH's report. So we're gonna knock out all those things. We're gonna say, this is what we're going to accomplish in our meeting, period, right? Yeah. That's 1 hour. So then, Dudley, we could pick back up. So that goes from 8:30 to 9:30, start at 10 and do 2-hour meetings and then 2 90-minute meetings.
So you're going to start this at 8:30?
8:30 to 9:30.
Okay. Then we're going to move the next one up and be an hour-long meeting.
So, what I have is trying to group people. Like on the first day, there's a way to do injury prevention, pediatrics, trauma systems, and disaster. Because there's a group of people that come in for those meetings specifically. And there's a group that come in for the disaster, education, stroke, disaster, education, EMS, and medical directors. So if they come in for disaster, the reason I'm bringing that up is they're going to be here that night, they'll be here the next day, we'll take a show. Right? Is that
Yeah.
fair?
Yeah.
So you have 2 1 hours.
I have a group of people who will automatically be here on Tuesday that would easily be, I want the worst slot. I've always wanted the Wednesday kickoff GTAC meeting slot.
Okay, then you have it.
So moved.
Not at 7, what are you making up here? I gotta wait for.
Well, no, I mean,
That would put you at 9:30 on Wednesday.
Yes.
so you want that to be an hour-and-a-half slot instead of an hour slot?
Well, the
Yeah,
time,
don't.
we can mess around.
Again, I think a lot of the way the committees work will change as well. If you start out with GTAC and you start with some expectations, I think everything's going to be different. We always think about what we got now and just moving it. I think the way we do business will be different. It may be worse, but it'll be different.
Just from the hospital side of the house, the hospital people want to attend TTCF. Many of them are part of the RAC chairs. We have dual roles, disaster management, and then in addition to that, the areas that they're most interested in are going to be the injury prevention, pediatrics, and the trauma, and then there's always the stroke and the cardiac as well. So you can't put everything on one day. So if you pull those two out, the stroke and the cardiac, to the second day, to be the break between the EMS, medical directors, and the education committee, then I think we've accomplished what we want. Right?
So, Shelley?
Just very quickly, because I'm going to need to leave. I think injury prevention can be flexible and everything. I like what the suggestion here. I'm all about making more efficient use of meetings, but also been hearing about the networking and having experienced that at different levels. I think that's very important too. So I just want we'll be flexible, plug us in wherever.
Thank you very much, and thank you for being here.
So 1 hour is good for you, right?
Honestly, I think we can start with 1 hour, but there may be times that we need an hour and a half.
Everybody needs flexibility. I think everybody needs flexibility.
Yeah.
They should shrink and.
Okay, let me suggest, it sounds like we're working hard at making this, whatever you want to, the 2-day plan doable. I would recommend that council approve the 2-day, let Kelly know. Then we work on this schedule right here and then put it on the committee agendas to make sure we get plenty of stakeholder input on what that will look like. And then we give the final schedule approval at the next council meeting.
And I think it might be, you tell me if you disagree with this, it might be helpful for the executive committee or the committee chairs to kick this around a little bit and see and recommend what you think would be best before the next meeting.
So this is more helpful for me than anything. All of the dissertations I can write about why my way is right, I've changed my way of thinking about things today by listening to people's, this is one of those things that really, I think, is valuable with understanding different perspectives. I'll be glad to think about it and write back what comments I have, but I do better in this kind of an environment on these types of problems.
Okay.
I think this would be a nice setting ever so often.
Another conference call, the executive committee, in a couple of weeks, like we did the other day, would be very helpful to follow this discussion up, which I don't know if that's not
Kelly, what's your cutoff date?
Pretty much need to send out the RFPs now. So I need to know how many days. If we have the right chairs the day before, that's really going to be in effect 3 meeting days as far as I'm concerned. We've got to have the same setup. We've got the GETAC for right chairs.
So this is where the department could be way more efficient?
There's not a lot of state buildings that accommodate.
So the Department of State Health Services is making me come to town 3 or 4 days. It happens to be regulatory is doing some of it, and other people are doing some of it, but the department's doing that. So if you want, there's nothing more irritating. We were at the Arboretum Holiday Inn Express on Tuesday. People stayed there one night, moved over here to so if you could get with preparedness on your days, I don't know how you guys can share money. It seems like it's the Department of State Health Services. But let them, well, here's what I'm trying to say. Book the days, and then people, right, it's like splitting the check or putting the alcohol and the food on another thing, or me and Ronnie splitting the check in half.
Yeah, when's that happen?
Well, I've got lunch buffet tickets here that I'd like to discuss.
Well, I'd like to double check with Jackie Betts, but I mean, the way we've done TTAF in the past is TTCF has bought that Embassy Suites room for the day. So it may be that if TTCF is taking the cost, we'll have rack chairs in that room for free. Dishes would have it for free if that's allowable.
But more importantly, for the stakeholders, if you would book the rooms, I'm telling you to ask you to go out for the days, And you guys figure out between preparedness and whoever, if it's two contracts or one or whatever, but it's silly that we're working independently. And people are having to book rooms at different hotels and move around or drive back and forth, so there's a loss of fidelity.
Preparedness is waiting on Kelly to book the space.
I know.
And the dates, because that's what then they schedule their meetings.
You need some more informal networking.
That's right.
I suggest you go get beer and salsa.
Let me ask a question. So HPP on Tuesday, and we're thinking that'd be a good time for rack chairs. But I'm not thinking everybody sits around this table at rack chairs meetings is here for HPP, are they? I don't go to HPP, but I have to sit up here and look like I know what I'm doing for rack chairs.
It's because I'm not there.
Well, even if you were there, you'd have to sit up there and look like you know what you're doing. I mean, but you're not going to HPP and neither am I, and I'm wondering if some of these other racks of the 22 are the people that are up here at that.
So to answer the question, and this would be very helpful for GTAC to discuss, that's a contractor meeting.
Yep.
I deal with significantly more money on the preparedness side as the contractor meeting. We get $2 million in contract funds on the preparedness side, and DSHS, the department's happy for me to attend and sign my name as the contractor. For $250,000 on the trauma dollars, I've got to make sure I have a board member present, and that's left over from 1998 when racks were first getting formed, and the rack chairs were the people doing the work. Every rack has, at this point, they should be able to have the opportunity for that contractor meeting with the rack, it's called the rack chairs meeting, but it's really a contractor meeting, that is the rack chair preferably or his designee, and that can be a paid executive director, no different than the way we're doing it on the preparedness side at 10 times the amount of responsibility and risk. So that's just that's an editorial.
That's not under our auspice though, is it?
Yeah.
Rack chairs?
Okay. It's under our recommending
recommendations to the
capability.
department. So the broad idea that you make recommendations to the department, yes. Among stakeholder thoughts, yes.
So with the 1 hour, the 2 1-hour meetings, and how many 1-hour meetings did we say we're going to have? 2, 3, 4?
It's been
12?
suggested we could have as many as 4 or 5, I think. Yeah.
How about half?
Okay.
Can we?
So if we had 4, that knocks another hour off. You can move another committee member over, or another committee meeting over to Wednesday. If that 1 hour, if all the 1-hour meetings happened on Wednesday, or you could shave that 30 minutes or an hour off on Thursday as well. It just doesn't really matter. But the way we currently have is sitting with 2-hour meetings, 2 1-hour meetings, everybody else at 90. We could keep rack chairs on Wednesday night. So we'll go from 10 in the morning, or 9 in the morning. To what would that be, 5:30, 6:30, 5:30, 6:30, so almost to 7 o'clock for rack chairs, just like we did Wednesday.
We may have, I'm sorry to interrupt, Dudley.
That's all right.
We may have some council members that are going to have to leave, and I'd hate to lose a quorum after this healthy discussion. Is it possible we as a council can give instruction that we will, for 3 meetings in 2014, we will try to meet Wednesday and Thursday with the final version of the schedule to be determined? Can we?
That motion.
I'll second.
I got a motion and a second. Any discussion, especially from the chairs? Are we torpedoing anything, or?
Just looking at this, and I know this isn't necessarily the one stuck in stone, but this is not going to do anything for a large number of our stakeholders, because they're still going to have to come in on Tuesday, and they're still not going to leave until Friday.
What time is Thursday over? I can't see that.
On this right now, currently is over at 6:30.
Pretty late. I would hard to get out.
Yeah.
A lot of people.
Yeah, and Dudley, I agree with you.
People who are driving 6 or 8 hours are going to have the same issue.
Yeah, exactly.
I agree with you, Dudley, for the people that are already coming here, but the hopes is one of the side hopes is that we will get more people to come that aren't the ones that normally come here. And maybe I'll be wrong on that. But
And remember, our role is to represent the stakeholders. Everybody keeps talking stakeholders, GTAC. Well, guess what? I am a stakeholder. We're all stakeholders. So I don't think that should be exclusive us. And in fact, I'm supposed to represent like every emergency doctor in Texas. The good thing is I usually forget about that when I'm here, and everybody else up here, I think we forget what our exact role is because we're trying to pull the wagon in the same way, and I see that as good. But the stakeholders are here because we're here.
And the only thing I would say, Chief, is, well, I don't know if we're going to necessarily attract any more people with this schedule. I think you might be more apt to pushing a later start on Wednesday and going into Friday morning like we do now. And the only reason I say that is it gives people that don't have to come in for all the rack stuff. They can come in Wednesday morning and be here for all the meetings. If they don't want to stay for the GETAC Council, they leave Thursday night if they can. If not, they stay till Friday morning and attend this in Vail. What we're doing is we're giving them a chance to skip a day on the front end, because when we start at 8 or 9 in the morning, they got to come in on Tuesday night. If we start at noon, can they come in on Wednesday morning, so now they don't have that Tuesday night stay, as opposed to here, they're still going to have the Tuesday night. If they truly want to participate in everything, let's say, I mean, the gluttons for punishment, they still have to come in on Tuesday, and they're still bailing out on Friday, not on Thursday.
In the worst case scenario, is it detrimental to change to 2 day? Or is it the same, is it the status quo?
I don't know
what we're doing now.
Well, my question is,
It's the purpose of why you want to go 2 days.
Yeah.
Really, so it's a little obtuse as to what the 2 days really is. If the 2 days is to make it so you guys will come to all the meetings, then what you're supposing is fine. If the 2 days is there to make it better or cheaper for the stakeholders and all that other stuff, you're not helping at all. So that's what, it goes to the core of the push for the 2 days.
And what is 2 days?
We spent hours talking about this at our retreat. And it seems to me, the process I was going through was the people that are that into the system are going to be here anyway. What the 2 day would increase the margin. That's what I got out of our meeting. If we could pick up 15 or 20 people, 15 or 20 stakeholders, I don't think we're going to run anybody off. But I think we're going to make it more attractive to.
That's the purpose of the 2 days, is to make it more attractive to stakeholders to attend.
That's in my head. Now, I'm not saying that that's the consensus of all the board members.
And to cut costs. This will cut, no matter how you go about it, it will cut one night off of everybody.
Actually,
The state and us.
This won't.
Well, I shouldn't say everybody. I should say a majority of people.
It wasn't just cut
Depends on
off.
I won't say that.
Like
It was cut some
could
time
grind.
off away from your other job.
Chief, if you get done with a meeting, if you get done with this meeting tonight, God forbid, it's not going to happen, but let's say this is Thursday, and you get done with it, we follow this schedule, and it's slated to go to 6:30, and it goes late to 7:30. Are you driving back to Pearland tonight? 8:39? What would be the cutoff you wouldn't drive back to Pearland?
Probably, I'd say probably 7:30 or 8.
What would be the cutoff for you not driving back to Wichita Falls, right?
Depends on how I drove. It depends on how long I've been here, to tell you the truth, and what I feel like. I mean,
Let's see, I would probably start flying. But Nancy was waving it.
We know a motion was made. Who seconded the motion for our notes?
Dr. Greenberg seconded it, and just to clarify the motion, it was to start and end all GETAC council and committee meetings, whatever schedule that looks like, start on a Wednesday and end on a Thursday. Is that what your motion
it was just 2 days.
Okay.
I don't necessarily think that the Wednesday, Thursday is
Okay,
important.
2 days, but basically all GETAC council and committee meetings would happen over a 2-day time period,
48 hours.
48 hours.
That's already in your strategic planning document that you've already approved.
Right. I think there's one more caveat to what Eric said about what is 2 days and why we want to go to 2 days. And is 2 days 48 hours, or is it from 8 to 5, 2 days in a row? Because if you went from noon on Wednesday to noon on Friday, it's still 48 hours.
So that's more enticing to me, but it might not be to the others.
True.
Right, it's the exact same time you've consolidated committees and done that stuff, but you're going into that Friday for the GTAC Friday.
The people who have to come in on Monday, the people who have to come in on Monday and Tuesday are going to be here Wednesday morning. Maybe they do rack chairs on Wednesday morning instead or something. But
people who wouldn't necessarily come in on Wednesday don't have to come in. They save that time, and they would come in for the power stuff, which is on. They come in Wednesday night, you're here for Thursday, and then maybe stay for Friday if GTAC looks like it's gonna be contentious or a problem. That almost consolidates for those people to target on Thursday only.
What I'm excited about is that opening meeting where we're all together and discussing.
Wednesday at noon.
Yeah, whatever day, whatever time it is, I think that's where we're gonna accomplish.
If it were Wednesday at noon, it would be over. I mean, this has been pretty good to get the website and get the whole thing, so we can do this like this. This is helpful.
The other part of the discussions that we had was to save some folks some time at work. If we start at noon on Wednesday, I think most people, a lot of people, could spend the whole day Tuesday at work rather than having to take off at noon to get here for an early Wednesday morning start, or even a 9 a.m. Wednesday morning start. So, and I think that was part of our discussions, if I remember, is people having to take so much time away from their
Yeah, so
paying job.
you're a good person to ask. You, Dr. Tyrock, and Ryan, just so I know for sure people have pretty significant things. If there's a 9 o'clock GTAC, you've got to be here sitting in that chair no matter what. You taking that risk the morning of, or you come in the night
I have to
before?
come in the night before. There's no possible way to transfer.
9 a.m.
Even in an airplane.
10 a.m., sitting in your chair, ready to go for a 1-hour business meeting.
Now, I mean,
10 a.m. is doable for us.
I say,
10
I'm
a.m.
thinking,
in your chair, functional, not
Here.
landing at 9:45 doing
No,
the.
it's doable. 9 o'clock you can't do.
I
My
think,
concern is, I'm sorry, go ahead.
go ahead. I was just saying, I really honestly think it's more of an 11 o'clock hour. And just because I know how everything goes, and we're assuming that people who drive can get through major traffic hubs at 8 a.m., which is almost impossible. We're assuming that flights aren't delayed, or that, and I was just gonna say that. Let me tell you, as a pilot coming into this town, you guys got, the people that live here, you got the craziest weather on the planet. Everyone
They got
else
the
around
craziest
you for
people on the
100
planet,
miles
too.
will be crystal clear, and the airport is down to minimums, are not accepting traffic. So you do have to assume that people are gonna be delayed. So I understand, but I'd rather put the hour and a half on and go to dinner late than I would be to jeopardize a quorum at 9:30.
Well, if I take the 7 o'clock flight out of Lubbock in the morning, that gets me here at 8:15. By the time I get my bag, get a rental car, and then drive here with the traffic, it's not going to be 9 o'clock when I get here.
You need 10:30 or 11.
Right.
Lubbock has a direct flight, Amarillo has no direct flight, it's all out, I think.
Well, and Lubbock may not be a possibility on that direct flight in the mornings, especially while they're having their legislative meetings. That's, that just may not be, and that's only every other year, and I understand that, but still, it's a problematic time.
So is the motion for 2 days, for 2 calendar days, or for
48 hours, I think.
48 hours of work space and time?
2 calendar days.
Calendar days.
2 calendar days is what I was asking.
Yeah, be some more flexibility to work.
If y'all continue this discussion, we're just
Schedule them across 2 calendar
4 more
days.
minutes. Talk amongst yourselves, just for
Oh.
4 more minutes.
Blah, blah.
Just to be, out of curiosity, see how many people are still watching. Dudley, look up there in the camera and say, if you're still watching, email me for the next 10 minutes.
How many are logged on? 5? How many?
5.
5 people
Five.
are logged in. How many were logged in this morning?
13.
Okay.
And how about the other days? How high did the number ever get?
We've had, so far, the total views on the channel is just over 2,500.
How many?
Over what period of time?
That's
Since they've been doing it?
Since we've been doing this.
Oh, okay.
This week.
Hang on a second.
That counts. if
What are they, the
somebody
Wizard
does
of
it.
Oz now? What are they doing?
But
behind the
listen,
curtain?
I was gonna ask for a heart.
Are we on our 3rd or 4th meeting that's been broadcast?
Oh, no.
Oh, it's,
Everybody's looking at me like I'm crazy. It's not that much.
One of those 13 is my wife.
Okay. Everybody's like, oh, no, it's been like 10. No, this is
No.
like the 4th.
We started last year.
It's been
It's been several, we just have been kind of getting more streamlined each time.
Right, but I mean, come on, 2,500 people taking part compared to nobody being able to take part, that's huge.
2,500 views, that means if it glitches out and they have to reconnect, that counts as.
I'm still gonna take the 25.
Yeah, don't
Well,
burst his bubble.
let me just say that I think and maybe I was out in Never Never Land, I think the idea of 2 days was the consumption of 2 full business days.
Correct.
And when we were talking about it, and because, and maybe I'm just, again, I was in Vance land, that if you're starting on a Wednesday and ending on a Friday, you've eaten up 3 of my business days.
Yeah.
But I can get here, or I can get here by 9 or 10 one morning, and even if I'm flying out the next morning, I've still got most of that third day I can be at work. So that's what I was thinking when we were talking. It was 2 consecutive calendar days full. But that's just from my perspective.
If we can't come up with the exact calendar, could we come up with which committees should meet consecutively on the same dates? Because I think that's important to be able to plan for our stakeholders.
And it would be nice if y'all had the same time every time, so, you knew and you weren't trying to swap with education.
The only, I like that, but I was gonna give it up because Bobby's point about if I had 60 minutes versus 90 was valid, and I can't do, I would give up the dedicated time to buy more 60-minute slots, which narrows our, right, I mean, you almost have to decide we're gonna have half and half.
Right.
And the 60s and 90s are gonna do some swaps when we're putting the agenda together. Well, that screws up my desire to, but I'm more than willing to sacrifice having the same day.
What if it's just the same day or near the same time? I mean, if you say that you're going to be one of the first 3 or 4 on a day.
True. That's what they need. They need the morning of Wednesday,
right.
Whether that was the 8 to 9:30 or the 9:30 to 10.
They just know Wednesday at some point before afternoon.
Yep.
Because you need 90 minutes for sure.
We really need to vote before we lose any council members. And so we have a motion that's really a repeat of what we already voted on in the strategic plan, but I think it's a motion to confirm to Kelly that all of the council and committee business will be done on 2 days.
Yeah, so the motion would actually be to convey to DSHS, while seeking their contracts for 2014, to plan on 2 full days for the GETAC process.
Okay. Do you want to second that amended motion? Okay.
So I want to know from the committee chairs, do you think this is doable, at least to try for these 3 meetings and see how it goes? Or is this not doable from your stakeholders standpoint?
My committee said they would really like it. And they all basically are going to come in and go. So 30 minutes one way or another is not a big deal, but they would actually like to go for an hour. And because they would rather just address issues and not take the reports. That was actually what was conveyed to me by them. And the other thing is, I think if we get
reports now, are they?
No, yes, we are getting some reports.
They are getting stuff from other committees. Their problem is different than the rest of us.
Right.
They're getting reports from us, which we need to stop.
Right.
They're getting reports from other groups so here's their problem. I mean, no offense, but they're the medical directors, so everybody wants to get the medical director blessing. And so everybody goes, well, we'll go report to the medical director, so they're aware, and we don't get killed.
Yeah.
It's a courtesy, and it shouldn't happen for them unless it's direct. I mean, the other people should just bow up and say, we didn't ask you because we don't think it's germane. We're not going to go ask you every time.
The other thing is, I think we're going to be stuck with 2 years or whatever we decide, because look where we're at right now, already having to give instruction. We will have done 1 meeting before we have to decide on 2015. So we're actually committing to 2 years, which I think is good. I think it's going to take that long to figure it out.
We're committed to 2 years?
No.
He's right, by the time we only have 1 meeting under our belt, by the time we have to revisit.
We'll have one
meeting under the new schedule.
The wheels come off in the first meeting, we'll know.
Yeah.
That's good.
Hotel at the Hilton, it's easier to get in and out of at the airport.
Mm-hmm.
Because you can fly down that toll road, and I mean fly down that toll road.
Yes.
And she does.
80.
You can get stuck in traffic. I mean,
This is like coming into the heart of the
worst.
The heart of the beast when you drive into here.
So the motion.
Do you guys have
Okay.
any flexibility with that? It's straight up low bid. I mean, if the night's in, the person want to cross over here out of the room, and they said yes, that's what we'd be. So let me ask you another question. Can T-TAP, they're not even here.
Yes, she is.
Is that, so they're already paying for this for the digital thing, is there a reason if TTAF were to graciously host at a location of their choice and offer to the state of Texas as a gift from a 501c3 to offer that location, do you care?
Thank you.
Does DSHS have to pay for the room?
I don't, if they provided us that space, if we could, well.
I think the only problem with that is there's no guarantee.
You're welcome. You hold our EMS committee meetings in my location, and I offer that.
I understand, Eric. The reason it could be problematic is because they are an approved other organization that does
Oh, they do work for them.
surveys for
yeah.
designation. It could be
Y'all are
construed.
difficult
Can,
to deal with.
does it have to be a hotel that puts in a bid?
Okay,
No.
got,
Although you won't, we can't do anything about the room. Like, if you want hotel room, I need to attach it to the space of the SHS.
So TTAF knows you paid, let's say, 12, I know it's around 50, whatever you paid this time, let's say it's $1,500. So TTAF knows you paid $1,500 and you're going out for bid and they bid $1,000 and they're the low bidder.
Starting to feel dirty.
If they're a place that has the space.
You can't do
Okay.
travel agency?
guys,
You can't do it.
Okay.
we really need to take a vote on this,
Real
like
quick,
now.
I want to show y'all two
Y'all are
things.
difficult to deal with.
This is Jory's example, starting at 8:30. That's bad if I can't even read it. I'm from the computer screen. 8:30 to 9:30 with the GETAC, an hour and a half meeting, a 1 hour meeting, a 1 hour meeting, and 2 hour and a half meetings, finishing up at 5 o'clock. There'd be room for rack chairs after that if you wanted to do that. Starting up at Thursday, going from 8 until GETAC is over at 5 o'clock. That's with 1, 2, 3, 4, 5 1 hour meetings, which she labeled as injury prevention, pediatrics, stroke, air medical, and cardiac. And then what I did, because my question about is it 2 business days or 48 hours, is I threw that together. Starting at 1 o'clock on Wednesday, getting done at 6, starting up at Thursday, getting done at 5:30, GTAC coming in Friday morning for 2 hours, out of here by 10.
Okay,
And
I'm going to have to be the mean chair and say, we're running out of time here, and we have, the proposal is for 2 consecutive business days, correct? So, I mean, I hate to cut it off, but we got to.
With Tuesday being the TTCF.
The same thing it is today. Except for wherever rack chairs is going to land. And I think those guys need to be consulted about where they're going to land. Or we're going to have to change the format of that meeting, which you guys could advise to have.
So we're supposed to sort of weigh in. Ronnie asked a question. Do you think it's going to be helpful or not helpful? Could we basically ask if we can support the plan? Yeah, we're going to lose our minds. I'm fine with you guys moving forward with this. From Eric's perspective, disaster. I'm going to say that with a caveat that this will not improve any participation, nor will it dramatically improve GTAC committee member presence in the committees. I'm going to tell you that that's what I think will happen in that year period. And I think also it will decrease the opportunities for networking, and I think it will decrease the other stuff that happens surrounding that. I'm talking about pop-off rooms. But I don't think it should, well, I can't prove that. So I'm not going to be a barrier to this.
Thank you. Can the chair legally call for the question?
I can.
Mike just called for the question. Okay. All those in favor of 2 consecutive business days, regardless of what that ultimately looks like, which is the motion, correct, Ryan? Signify by saying aye.
Aye.
All those opposed? Motion passed. So Kelly knows it's 2 consecutive business days. Now, the next thing we have to do is figure out what days those are.
I'll make a motion, big Wednesday and Thursday.
Wednesday, Thursdays, that's what we said, correct?
And anything that's not Monday and Friday has it.
I'll make the motion, it'll be Wednesday and Thursday.
Is there a second? Any discussion?
I just had one question. It's kind of a moot point, but after you voted, if the RFP goes out and the RFP went out for 3 days, could you write it where you say it's either going to be 2 or 3 days, and what's the daily rate, or do you have to go out and say it's going to be these 2 days period?
You have to go out and say what it is.
What?
You can't do it anymore. Once it's,
Okay. Okay.
Why are you asking that, Dudley?
We're making some suppositions on some people that aren't here. It goes back to what Eric said. I don't think it's going to improve. I think we're going to inconvenience some of our current stakeholders by moving some things around, and I think we're going to lose that. And so I was thinking, we're in a big push to push this to 2 days. I feel like we're doing again what we did, what you guys did at your strategic planning retreat, is that we're locking ourselves into something without the chance to really talk to the stakeholders. And so I'm concerned about that. So I was curious if she could put out a bid for 3 days with a caveat in it that if we go back to just 2 days, what would that discount be, and then look at that as her bid. I don't know if that's possible to do or not, but that prevents us, it's almost like we're rushing to make this decision again for convenience.
So it's convenient to have her need to do it, I can tell you that.
So I would say, what do you do now for Tuesday? For Monday, Tuesday?
The Texas Trauma Coordinator Forum, their treasurer, Jackie Betts, has made a deal with the Embassy Suites here, so that's a lot.
So you do it at Embassy Suites?
I have a question. We're locking ourselves into a 2-year deal. Initially, we said we were locking ourselves into a 1-year deal. So if this was a mistake, it would only be for 3 meetings for the next year, which is not right, because
I'm just saying realistically, we're going to have 1 meeting, and then we're going to have to instruct
Kelly's
Kelly
gonna have
again.
to go, yeah.
But train wrecks happen quickly.
Right, no, but are we better served to not change anything right now? And I understand our strategic plan, and we agree. Are we better served to not change anything today and take the extra time to get the input from the stakeholders? And I don't know whether it'll make a bit of difference if we have another 6-hour meeting, another 6-hour discussion later on or not. But at least it would maybe give us a little more time to get the input from the stakeholders as to what days would work better. Do we want a 48-hour, a 2 business day meeting? Is that what's going to serve everybody? Can the other folks that meet around our GETAC meetings, can they rearrange their meetings to fit in with those schedules, and what would that look like? So are we better served for not changing anything for a year, or changing something for basically for 2 years? This isn't going to maybe be the best for us.
I guess I think just if we ask our committee, the trauma system.
Yeah, there was stakeholder.
We talked about all these issues. Wednesday, Thursday, we talked about the days, we talked about how early to begin, how late to go. So I think the only group that I know of that hasn't been asked would be the RAC chair. Is that right?
They don't care, they're told them.
It's just a question. I just feel like, we're talking about rushing into a decision on what kind of days we want to use, what days of the week we want to use, and I just hate to see us commit ourselves for the period of time that we're committing ourselves when we're basing that on a rush decision, and maybe not everybody's overly comfortable with that. They're agreeing to it, but just my thought.
I think I totally agree with Shirley in that I think it's fair to those other organizations. I'll use TTCF as the example. I think it's fair to them that they have an opportunity to discuss this proposal because, hell, for all we know, TTCF may want to meet on Friday. Everybody stick around Thursday night. We're going to have our major meeting on Friday instead of us assuming that they're just going to keep it on Tuesday or whatever day it's on. So I agree. I think we keep 2014 like it is and use the next year and a half to come up with something that's agreeable to everybody.
You can't re-vote and unvote, can you?
Pass another motion.
Yes, you could just, yes, you can.
Decided last summer is we stick with it, made by y'all.
Well, can we do this? I think we spent a lot of time talking about this, and again, the committee did talk about this and, gave us approval. So could we take what Dudley has and come up with 4 different options, and one being leave it like it is? And then that could go back to the committees for discussion. Because I think
I didn't thought about this, Scott. So this is what worries me. Everybody's built these schedules and all these other meetings. We're trying to fit our own around GTAC. You guys may get exactly what you want with a bunch of people. There's a completely different thing if you ask people their opinion. So I've just lived this in the last 2 weeks of my life. You can make the perfect decision. You can make the best decision for several groups of people and do it badly. And what was a touchdown with a 2-point conversion ends up being a field goal. And if you had simply just kind of done it a little bit differently, it's 8 points on the scoreboard. And I'm telling you, I think that's where you're at right now. You can make a decision that everybody else will go, that actually worked out okay, and later on they warm up to it. I'm telling you, I'm trying to be as those who know me well, I'm being as malleable as it gets. This is as flexible
as Eric gets.
I'm not gonna fight this. I'm not gonna go rally, get the pitchforks and the stroke. I'm not gonna do that. It's not fair. I sat through the meeting. Some of you guys have valid points, and I will support it. I will say that I was at the meeting and lived with it. But I think Scott's point and other groups may work around you, and you may get a bigger win, and you will be seen as inclusive more if you decide to take a pause for whatever that is for this particular RFP.
And I would just like to throw myself on the mercy here. I apologize. It's just, we deal with this in Iraq. We call it paramedic intuition on what is a trauma alert. And Ricky Reeves and I, and he's not even here to defend himself, but we were talking around breakfast this morning. He was talking about firefighting experience, and we were talking about medical experience. And we just had this, if your gut's telling you something's just not right, it ain't right. And you gotta, and so that's why I said something. I mean, you guys have made a decision. You guys, I appreciate the follow-up conversation. Just when things like this, and as contentious as this was at the end of last year, I just think slow and deliberate is so much better than, well, we had to do it because we have an RFP to let. And I mean, whatever the excuse is, I mean, if that's the reason we got to do it, we got to do it, then I'm like Eric, I'll live with it, and we'll make it work, and we'll sell it like it's the best thing since donut hamburgers. But did you try those at the fair, by the way? Whew. But anyway,
if we're not concerned about spending money, send the RFP out anyway. Yeah, and then we'll try to, and if it doesn't work, it doesn't work. Nothing gained, nothing lost.
Well, and I'm going to.
You're going to do that
anyway.
anyway.
It doesn't, whether we change or don't change, it doesn't change what I'm going to be doing in my travel time anyway, nor will it change anything for anybody up in my part of the world, and that's who I'm thinking about right now. So, either way, I'm good. I'm just, if we can save some folks some time, that's just my.
So let me, just to clarify, because if we've decided to go on 2 business days, how could you go out for 3?
I go out for whatever I go out for. If you go, say, okay, we're going to go out.
We just wasted Dudley, can you put up that other one?
Which
one? The one I came up with before, too.
Noon to noon?
Noon to noon. This goes against my better judgment.
Sure.
I mean, I don't.
There we go.
I don't mean to sound self-serving, but I guess I'm a little bit frustrated because I hope you guys realize everybody in this room I respect deeply.
Hold on.
I respect deeply, and I respect the fact that everybody has a difference of opinion. But I guess I'm a little angry, and I got another word that starts with a P really right now, and I'm boiling. What am I doing here at 2:55? I got to be honest with you. I thought you guys had a committee conference call. It was put on here, and we've just circled the wagons for the second time. I got my butt eaten out in front of the microphone for not being conscious to the committees. So then I thought it was over with. We're going to leave it as it was. Then we come back, and there was an executive membership meeting with the committee chairs. Now we're back to doing it back again the same. I mean, with all due respect, I mean, come on. I mean, decisions are hard. But what are we doing? I mean, the question becomes, I mean, I want the consensus process. I'm telling you, I'll take a call any time of the day or night. My cell phone is stuck to me like a mole. It charges next to my bed, but at some point, we've got to make a decision. I mean, what kind of message are we sending, really? I mean, it's to me, we're kind of in the same boat again. The only other thing I have to say is, why do we have to put out an RFP 1 year in advance?
That's what you have to do.
Because if we're going to get the hotel space, that's how far out in advance we have to go.
It is.
Otherwise, we get to the point where we either can't get the space or the rooms come at a premium price.
Okay.
Yes.
Or we stay the night.
Or we're at the night's end.
Right.
And a year is short.
4,400 square feet, and that's 1,900. That's a lot of space, and actually, there's only about a certain number of hotels that even have that.
That have that many rooms. I mean, please don't walk out here thinking that I'm trying to be a jerk, but it's just frustrating because 2 years ago, I think it was a strategic plan started that process, and I wasn't able to be at the first retreat for health reasons, and then, so I wasn't in that at the very beginning, but it just seems like we're right back to where we started from. I understand that we have to take into account the other people, and I understand that. But the reason why they have their meetings in Austin is because we have our meetings in Austin. So, I mean, we want flexibility, but they're not asking our flexibility. I mean, it's not a reciprocal relationship. I just think that if we need to go to 2 days, let's go to 2 days and be done with it. If we don't want to do it, then let's just not do it. But how many more times are we going to come to the well to try to decide that?
I think you bring up valid points, we should make a decision today. That's why I was willing to be flexible a little while ago was to expedite this. But I'm gonna tell you, every time in our rack, when things keep rolling up like this and do this little washing machine thing, is because everyone in the room feels that we haven't really figured it out. And ultimately, people are gonna live with it, but it's gonna be a sore subject. And we also have to talk to the other groups. And I think we're rushing it because Kelly has an RFP. And I think, so I will tell you, in our rack, the prudent thing would be, Ronnie and I would decide in our rack, go for 3, leave it as is, and start talking this up for the next year.
And I'm fine with that, but let's choose one way or the other.
But that's not the strategic plan, that's not what GETAC, that's not what y'all had in your meetings, I was acquiescing, but I'm telling you, that's what I would recommend you do, but I'm willing to live with the other decision, fine with it, and I will not, I'm telling you straight up, I'm not gonna be a baby about this. But that's what I would do, and that's why it keeps coming up.
And Ryan, having been through several of these issues
Right.
that are really controversial, I think we're all just sharing, caring kind of folks, so we want to make sure that everybody's taken care of. And I remember sitting through a meeting one night at state conference, and we were there until I don't know what hour it was, but Dr. Rock was not going to let us out of that room until we had the consensus of every person in that room, and even the poor janitor that walked in the back of the room at the very end, he had to have his consensus before he would let us go.
That's coercion, that's not consensus.
I'm fine with that. I'm fine with that. I
But
have no problem with the process.
at some point, we do have to say, okay, here's the way it's going to be. We have to adjust. We have to adapt. Adapt and overcome is what we do. We have to adapt, and in the long run, if it doesn't work, then it's still not a terribly long time that it doesn't fit well for everybody. I think as we go along with whatever we come up with, whatever we decide on, as we go along, people will get used to it and they'll be okay with it, and then they may even start to like it. But it's just, having not everybody having an opportunity to go to the microphone and say, well, here's what I think, is a lot of times where we get the controversy.
The other question is, from all this talk, is do we have to wait till February's meeting to start this? So we talk about she bids 3 days, we talk about it between now and then, we decide on which of these, between now and May, we decide on which of these schedules we want to do, and we do it in August. Why not? I mean, if the room's empty, they've already paying, if the room's empty, the room's empty. I mean, Eric and I can come in here and do dancing or something, or ping pong or whatever. And we can do the Harlem Shake, the GETAC Harlem Shake.
I was going to say the same thing, and I always hate to say what I think, because then for the next 5 hours I'm going to text you people and say, please don't be mad at me. I'm serious. If she puts out an RFP for 3 days and we put a trial on, then we put a trial on and see if it works. I mean, if it works, then by August, that gives her plenty of time, because it'd be November, and then she would have an opportunity for the next April.
We do August and February, and May, we critique it, we see what everybody's thoughts are. Hey, this is the greatest thing. We're set.
I'm gonna go back to my statement earlier, though. It's gonna work only if we stand with our guns and we run GETAC as GETAC members, and that the committee chairs support it, and not be in the meetings saying, yeah, here they go again, they're screwed us again. As long as we have that support all the way through, and like Gloria was saying, it was discussed in each of the meetings, so.
The meeting that was controversial when Dudley and Eric came up and said what they did, do you think that people from these other constituency groups didn't come up because it was immediately said, we're sorry, and we did, or did we give it a public hearing when they had the opportunity? Because it was on the agenda, and there was an open microphone, and the only people that had dissension, and rightful dissension, was the committee chairs. Those other people had to have had constituents in the room from the other groups. So the question is, when that microphone was open, is the feeling that they did not come up because they felt like Eric and Dudley made a good point and it got shut down, or
Sitting in those committee meetings, the discussion was already made, and the decision was already made before GETAC ever happened.
Well, I understand what you're talking about.
Well, I sat through those committee meetings, and I heard the comments and the conversations going on and directed by the committee chairs. And,
That was the consensus, because it was on the agenda for this meeting this afternoon.
no, I'm talking about for last meeting, last November.
Last November, it was a feeling that there was a closed-door secret meeting and a decision was made and everybody has to deal with it. So, I think.
We had one.
That's the issue.
We had one shareholder that came to our open meeting.
Okay, but come on now, let's just be honest. Open meetings, schmopen meetings. We have it in a little small place. We announce it. I know you probably don't want to hear this, so I'll just say, and I know I'm being recorded, but we had a legal open meetings, but it's not like having it here at a regularly scheduled time where you talk about it, so you can understand how the stakeholders, and whatever you want to call them, whether you call them stakeholders, the people who actually do the work, that's who we're talking about, right? The people who actually are the ones. That's what we're really talking about here, by the way, just to clarify. What are we, because I'm sitting here thinking, look, this isn't a key patient issue we're talking about here. I can live with any of this. It's like it doesn't, I can live with keeping it exactly the same, and I'm going to do pretty much what I've done for 20 years. I'm going to do that, and it's going to be fine. Or I could go to a 2-day meeting and extend to 3. It's not an issue for me. But what we're really talking about is what Jory said, the notion that the reason why people get concerned is if we want to have a really efficient meeting where we just tell people how to do it, that's what their fear is. And we should recognize what their fears are, what their concerns are, and be sensitive to those, because that's what we told them first in November that we would do. That's what we told them, is we would listen and we would consider it. And to me, that's what we're really talking about here. We're not talking about this meeting. It's about, is the GETAC Council going to basically have a relatively closed meeting that's very efficient, where we just say what we think and move on? Because if it is, then that's going to be a deal breaker, and they're not going to live with it. And we're going to have, I've been through this before, we're going to have much longer meetings, much more dissension, much more trouble, much more pain. So I know what the right answer is, and that's basically to be flexible with respect to what the stakeholders want to do. But from my side, we're trying to do that, right? We are. I mean, we have the Trauma Systems Committee. This was discussed in 2 days. It was discussed. And the Trauma Systems Committee, I think, said they could live with it totally fine. And they would meet from 8 a.m. till 7 p.m., no problems. They would do that. So I think that's just Trauma Systems Committee.
I have one last comment, and I don't want to rush to judgment. We've talked about this a long time. But we did get the subcommittees to come before us today in an open meeting with an open mic. And did I miss it? Did anybody bring up a rush of judgment as far as the two-day meetings?
So if you want.
No, I'm just asking.
All right, so you get it. You understand it? We walked in this meeting with a sense of calm, a sense of constructive. We put that behind us, with sort of the emotions. And you have pulled the scab off of some of that, and I get that. If you want to talk about it, the problem is you change something. It's the meeting time this time. Ronnie's exactly right. It's a process problem. If you change the meeting time, well, next time we're going to change the level 3 orthopedic criteria. That's what the fear is. It's not about the meeting time. Ronnie's exactly right. He'll live it that way. GETAC will change. Everybody will do it. It's about the way you decide to construct business and do an open meeting in Kerrville and Utopia, and then come back with your plan and present it all. And that's the problem. But I actually walked away from all this. I walked away from it last week. I shook each one of your hands. And I said today, publicly, twice, I'm not trying to kick over the sand on the anthill about what the problem is. But if you don't, it's unfair, once we move past emotional issues, to say, well, no one mentioned that today. Well, yeah, we're trying to move on. That's frustrating for me.
Well, and I think too, we delayed the discussion on this until after lunch, or till lunchtime, and probably, well, right or wrong. Had we done this first thing this morning, before we did any of our committee reports, then we probably would have had a lot more comment because there were people here. And that's just, that's just comment. Like it's just a thought.
Maybe I'm just way out there again, but now I'm hearing that you can go out on your RFP for 3 days worth of meetings, right?
We'll go up for whatever.
Okay, so you can do that. So what I think I heard Dudley say was, we don't have to pour anything in the concrete, because we can reduce it to 2 days worth of meetings on a trial basis. So
somebody will use the space.
All the committees can talk about this in May and say, which is the best 2-day schedule? We want to try this in August. Is that fair to say?
I think it is, and I'd like to do a little mea culpa here, because I tell you honestly, after November, I thought the issue was gone too, and then you called the executive committee thing, and we found ourselves on the phone even almost. I think I even said, hey, we're doing it again, and I may have dozed off or something, I don't know, but all I asked the EMS committee about was how long of meeting time do we need? I didn't quiz my committee about number of days and how do you think it would work, and I didn't take that type of comment, maybe that's one of the reasons this isn't sitting easy with me, is because Jory did all that with trauma, and I'm feeling, man, I need to get Jory to come run my meeting, because I kind of dropped the ball on that. But I think if we it gives us more time to discuss this amongst everybody. It gives us more time. I don't know. It's not easy. It sucks. Change always does. It just doesn't. I don't know. It's just not sitting.
I'm saying, this is just me, so it's not but from my standpoint, I can live with I say I can live with, and it's true, I can live with either of those things. To me, if I was doing this, if it was my organization, I would say, okay, we're going to make a change. We talked about it. We're going to do it. Let's do it and see how it works. And if it doesn't work right, if it's messed up, if it doesn't work well, or if even if people want to change, we're going to basically reassess it. And that's what I would say we should do. We talked about this from a strategic planning point of view too. GETAC can, but it shouldn't be paralyzed by indecision over issues that are basically not major issues, or that the the conclusions are pretty self-evident of what needs to happen. So to me, if it were me, we've gone through all this, we've talked about it, I would say let's try it. I would say give the flexibility of go out for a 3-day bid. That way we have the opportunity anytime along the way to say, because I think they kind of feel, I mean, I haven't talked to them about this really, but you have the sense that you kind of feel like you're sort of driven into you're herded into the little chute, and there's no moving once you're out of that chute in a way. Even though I don't think that's definitely not the intent. I don't think it is, but I can see how you might feel that way. That wasn't the intent.
What I'm hearing is.
Change my request. I want 4 hours for my meeting.
We'll send you to the pop-off.
Tuesday, Wednesday, Thursday? Is that the 3 days?
Well, they'll drive their meetings around that.
And Wednesday, Thursday were the days we talked about reducing to 2 days, was Wednesday, Thursday. That's the 2 days we had the most discussion on, so.
I would say Wednesday, I'm making this up right this second, so I don't hold it dear to my heart. Wednesday, Thursday, Friday, that leaves open the option of always going, okay, if it doesn't work, we're gonna go back to the same old way we've been doing it the whole time. So I would say.
Wednesday, Thursday from the thing.
Right, you could do Wednesday, Thursday, and you could still do Tuesday.
For her point, for the RFP, you do Wednesday, Thursday, Friday.
Right.
Then we start talking constructively with the other groups, with TTCF and everybody else about what a trial would look like, and do it quicker.
And with the other DSHS people to see if maybe they could add on to Tuesday, and then you could have your disaster thing actually all in the same place.
That's the constructive way that I
Okay, can y'all live with that?
Because the point of us doing all of this is so when somebody picks up the phone and has an emergency, all of y'all work together. That's the purpose of this meeting, whether it's 2 days or 3. Y'all got to figure out how much time you need, so if my granddaughters get hurt or there's a hurricane, y'all can do your job efficiently. That's the purpose of all this meetings.
Okay.
So whether it
Okay.
be 2 or.
Chief, I have one other thing I promise you will be short. We need to think about, does it work or does it not, and what does that mean? We don't need to discuss it, but in May, I think that discussion, or between now and May, that discussion needs to be had, is what are the endpoints, what is success, what is not success, so we know how to either poll the stakeholders, or, if we come in here and they're all holding pitchforks and torches, probably not a success.
What are the metrics?
Yeah, what is success and not success? I think we need to think about that. Go ahead.
I think to me, success would be, is the count, are the
I said
committee
we don't have to
chairs,
discuss
are
it.
the committee chairs and their the committee chairs represent the stakeholders, they feel like it's working well, and does the council feel like it's working well? And if the answer is yes, it's a win. If it's no, it's obvious.
What if it's yes, no?
Well, then
That's what it's gonna
Then we have some more, I don't know, I'm not certain, I don't really think it may be yes, no. I don't really.
We don't have any clue, come on.
I don't.
So
Okay.
Chief, can we do
Proceed,
another
decide on
executive
this.
committee called in to talk about implementation of this sooner rather than later?
Let me try to summarize what I'm thinking I'm hearing from several different areas. That it is the goal of the council, if at all humanly possible, to have 2 consecutive business days of GETAC business. And that what we're asking the committees to do in May is discuss that. What could that look like? There's 4 or 5 different schedules, because we're going to try that at a future meeting. Is that fair enough? And now, that's where we're going to get the stakeholder input. We really don't want to get a discussion of, is it 2 days or is it 3 days? We want to say, if we go to 2 days and we try it as an experiment, what will that look like? What ideas do you have? And then y'all come back to council and say, this is kind of a preferred schedule if we're going to go to 2 days. And that we can try, and not even if, because we kind of said we're going to go to 2 business days. We're going to do that. What is the best schedule that works to try that out? And if it doesn't work, we still have 3-day meetings and we just go right back to what we were, if that's what.
So you're saying get input in May to try it in August?
I think that's what Dudley was suggesting, is
Right,
get the
right.
input in May and let's try this thing in August, because we've already got the 3 days anyway.
Since we've backpedaled all the way to the beginning anyway. I mean, there are other options besides just the 2 business days that we've discussed that can decrease travel as well. It's the noon to noon, which actually
Okay.
Dudley put in. We could, if saying we're doing it in 2 days is such a difficult pill to swallow, and this is what we discussed in the retreat too, because there's so many other things to go along with this, number of committees, how long the committees meet, all that kind of stuff. We've not even gotten there yet. The other option is, if we're going to stick with 3 days, why don't we try the abbreviated 3-day schedule? Where you start at noon.
12.
Yeah, you start at noon on one day, you end on noon on the 3rd day. And
actually,
I'm sorry to pull it all the way back to that, but if
started
we're
at 8,
starting
we're done
over,
by
I think we
10.
ought to start over.
Is that a main discussion, or is that something we should work on a committee on a call?
That was one of the original, that was one of the original ones I put out, but again, it's easy for me. I live down the road. And now we're starting over again, so I hate to even bring that up.
Could we put together maybe 4 schedules? One being the current one, we already have 2. If there's another option, so when we meet with our committees, they can see. And I think one of the things that we have here is we sort of grouped, like if the trauma coordinators want to come in, they can still have their activities on Tuesdays, and they can see they have to commit to be here on Wednesday, and then some are going to want to go home. Same with EMS, if they want to come in late Tuesday, they're going to be here, Wednesday, they're going to be here all day Thursday for their activities, and GTAC, and get their input on not just the days, the length, but also the committee structure, the sequencing, so that we, as the committee chairs, can tell them this is what we're going to plan for the next year to have our meetings, so you can plan to be here next month.
I think anything's possible. I guess I sort of need y'all close your ears, sort of need a consensus of the council members that when we have the executive committee teleconference, that we can come up with the 4 or 5 schedules and then post them for the committees.
In as much
I
as the
think we're going back on-
consensus-driven
yeah,
process, I don't think
can
that
do
we need to keep our focus on just the committees, because the whole reason that we got derailed earlier was not because necessarily the committees. Certainly it's a consideration, but it was also the ancillary meetings on either, or not really on either side, but on the front side. So I think that there needs to be some specifics to address. Somebody needs to go to each of the other people, or constituency groups, or alphabet soup groups that meet leading up to GTAC and get their opinion as well. That's what I'm trying to say.
But I think that's the great thing, if we had some schedules to give them,
Right.
we could say to TTCF and their.
Right. I'm just saying we just need to be sure to do that so that we don't get back without knowing what they want to do.
But what I'm looking for is, can Ronnie and I have the executive committee teleconference and come up with those 4 or 5 schedules and then ship them out for
How
consideration?
many
Is
you
that
got there?
okay with y'all? Is that-
Yes, I think that's wonderful.
I think we already have some.
Okay.
I mean,
Yeah,
between,
Yes, your answer for me would be yes.
yes,
Yes.
because I put
Okay.
some together at the very start of this, and then Dudley has a couple. Did you have more than the one she was working?
There's this one that could start at 8:30, or it could start at 9 or 10. It just depends on what time we want to get done on Wednesday and Thursday. And then you have this one that starts at noon or 1 and gets over at 10 or 11, depending on when you start on Friday.
Well, let's have an executive committee teleconference and kind of come up with what those 4 or 5 are going to be to discuss. And I guess Ryan pretty much hit the nail on the head when you said we got to make a decision and we got to go forward. The one thing that I've learned as chair is this entire GTAC process is strong, but it's also fragile. And it wouldn't take much, and I think Dr. Stewart was alluding to that, it wouldn't take much for what we have to start crumbling a little bit, because we have albeit a minority, maybe, a group of people who don't feel like we listened. And it would be a shame for this good process to start to crumble because some people didn't feel like we listened. And I think the solution we have here, by saying we want 2 days, what are the different ways we can accomplish that, be it noon Wednesday to noon Friday or 2 business days, gives the opportunity for that input. And I think that's, and I know sometimes that slows things down, but it's a stakeholder-driven process, and the stakeholders need to know that we have no ill or malintent. We're trying to improve the process, and we're just trying to make sure we get some input when we do that.
And that's exactly, please don't go out of here thinking that I wanted to circumvent anything.
No.
My point is, I feel like that we almost have analysis paralysis.
Yes, we do.
And that's my only fear, because it also erodes their confidence in our decision-making capabilities, because there's a line there, there's too reactive and then there's too unreactive, and you gotta kind of balance it. So I just don't want us to start getting away from being able to make some decisions.
And I think you more eloquently put what I was trying to say.
Just for housekeeping though, we had a motion that was passed, don't we need to somehow
So do we
get
need
rid
to
of that?
rescind that? or-
Yeah.
The one we
How do we
voted
do
on
that?
the one we voted on unanimously?
Yeah, for 2 days.
Mr.
business
Chair,
days.
I move that we rescind the motion and the vote as recorded a while ago.
I think I have to make that move because I was the one that made the original motion. Somebody that knows Robert's rules better
Oh,
than me.
God, who knows? Sure.
Probably.
Second.
We voted on the motion, though, did we not?
Yeah, so it's new business, actually, is all it is. It's
Okay,
new business.
never mind, I won't steal your
You can
thunder,
always
so go
undo
ahead.
something that's a new business.
Okay, so the motion is to not limit it to 2 business days?
Not limit the RFP. For today, don't we really just need to tell Kelly, go forth and pick 2 days or 3 days, and I think we're at 3 days?
Right.
And we're going to continue to work on
I make
this.
a motion that we direct Kelly to our DSHS staff to move forward with is the contracting process the right term? Was it the RFP for the upcoming year's meetings for 3-day to be Wednesday, Thursday, Friday, and that the executive, well, I don't have to, I think it's enough right now.
That's enough.
Is there a second to that?
Second.
Okay, we have a second. All those in favor? Aye. All those
Now, what I-
opposed? Okay, go ahead.
Now, I think the executive committee should meet, all the committee chairs, and kick this around and see whether we can get it to 2 days. If we can't get it to 2 days, then, and try to do the things that you talked about, even if you're not going to 2 days, to make it more efficient with respect to time and people's travel issues.
I would like to make a motion for a short time goal, that we try something different at the August meetings. I don't even care what it is. It just needs to be something different.
Stay status quo.
Yeah, go ahead, Jane.
Can we please call it an executive work group?
Executive work group, that's what I meant to say, Jane.
Okay.
That's what I meant to say for those on the,
It's recording at this point. I don't know if there's anyone live.
But we also need to readdress from 2, we've just asked her to do 3. We passed unanimously for 2, so we need to rescind that. We need to rescind that.
Well, we rescinded 3 days when we did 2, so it's,
Okay.
we just changed policy.
The RFP, one address what you want to do.
We just changed our policy. That's the
Right.
problem.
Okay.
And Kelly, while you're at it, would you see if you could get us less than a $33 gratuity on an $11 lunch?
Could I ask that you read the minutes for the first motion, second, and passage? Could I have the court reporter read that for us, please?
You read that? I don't need it, read back, read it back.
On the very first motion?
The motion I made that was seconded and passed for 2 days, can you tell me what that said?
Okay. It just says that there's a motion, Brian made a motion to go to a 2-day, 48-hour schedule. And Dr. Greenberg seconded that motion, and all were in favor of the motion.
So now what do we need to do?
So, we did say a 48-hour schedule.
And we said 2014, too.
Right, in 2014.
But doing a 3-day RFP doesn't change that either.
No.
It is in 2014, yeah. I got the 2014 part.
It's Batman and Robin over there.
Yeah.
So,
We don't necessarily have to
Change
rescind or change anything.
I personally
right
think we could put it as a item on our next GTAC agenda because by that point, the committees will have met. Hopefully, you guys will have had your executive session, or what did you call it? Work group. And we could put it on our agenda at that point and make appropriate motions so that we just can let it simmer.
Jason, I'm
what I
unplugging.
think. That's It's not a motion, it's a thought.
Very good thought, Brian.
Don't you say a word. Don't you say a word.
I've been pretty quiet. I just want to make one really quick comment. It's been said that TTAF and the other affiliate groups, we will adjust as GETAC does. I mean, that's just the fact. But the one thing that I will throw out there is, for example, TTAF is planning a fundraiser in August. And that fundraiser is based on GETAC meeting Wednesday, Thursday, Friday. So, I mean, I understand the need to change, and we will adapt, but by the time we meet in May, TTAF will hopefully already sign contracts for our fundraiser. So, and it's not about our fundraiser, it really is not, but I think TTCF and other groups are in that same boat of they are going to be setting things in stone in the next month or so.
When is your fundraiser for August? Is it on the Thursday night?
We are hoping to do it on Wednesday.
Okay.
Wednesday evening.
Yeah.
If we do an 8 o'clock thing,
Yeah, that's really my, I mean, because at first I was thinking, oh, well, we'll be here Wednesday, Thursday, but if they're going until 8 o'clock, that really doesn't help with our.
In May, when we discuss that, what we're going to do possibly in August, would you please remind us that you already have a commitment, and then that will help us.
So,
Yeah.
none of the current things we have now is go as late as,
Yeah.
and one of the ones George put together, have the medical directors, and Dr. Greenberg already said they can be done quick, so.
Can be.
So
We will adjust to the time given us.
I won't come.
I'm gonna tell you what this has felt like. So my daughter plays club soccer. So we end up out of town a ton. And the game's over, and it's time to go to dinner, and everybody kind of wants to eat together, but you have to spend this time of everybody going, well, do you want Mexican tonight? Well, my daughter has a peanut allergy. It's like, there's this thing that happens. And when 4 of the families went to the bathroom, they come back and go, we're all going for pizza. They said, they would have probably agreed to pizza if you had just asked them. The problem is you have an important part of the team, you have the coaches of the team and the and the managers, but you don't have all the parents. And when you get everybody sitting in a big circle, there's always somebody going, just pick it, I don't care. But there's some other people.
That wasn't me.
There's somebody else going, I really wanted a steak tonight. I've been dreaming about a steak, and there's a good steak place. Everybody goes, oh, that's great. And everybody leaves, and the team stays together. Or you can live my dream. Well, I'm not going to do that. But there's another side to it.
On the second motion where Mike Click made a motion to have the meetings Wednesday and Thursday, who seconded that motion?
Don't help put me.
You may have to listen to the recording.
I believe you
I
did.
thought not.
I think Linda did.
Okay.
Dr. Greenberg, I think you
I did,
I don't know.
but I won't.
Resuscitate Dawn.
Okay.
Anyone can join.
Me and I can share some blood pressure medicine.
All right, so, to summarize, according to Eric, in May, we will all decide where we're going to go eat.
I'd make a motion, we go to Gloria's.
Okay. All right. I'd like to thank the committee chairs and everyone, all the stakeholders that have hung out through this. Again, it's not negative. We're just trying to improve the process, and in the process, make sure we keep as many people involved as possible, because I think that's what makes GTAC roll along. So nothing anyone says or has said should be taken as a negative. It's all just part of a growth and change process. So that being said, is there any other business before this council that we need to take care of? Seeing none, I'm sorry, is there any comment from the public?
Is there any public?
Why doesn't
No comment from the public. All right, thank you all very much. Appreciate the love and respect on the journey. I'll call the meeting adjourned.
Do you want your cookies for the road?